Good morning, dear students. Hope you all are doing well and your preparations are in full swing for your forthcoming NEET PG examination. Before going into our discussion, I pray to God Almighty that all of you clear your NEET PG exam in flying colors and get your post-graduation of choice. Now, I welcome you all to our final revision series of Medico. And today's topic is physiology. So, in the subject physiology, today I've taken around 40 to 50 questions, 40 to 50 high yield questions covering all the systems in physiology. Now, without wasting time, let us directly dive into the questions. And I encourage you to interact and make this a lively session by interacting and posting your answers and comments in the comment section. I will try to answer all your queries as much as possible. So now let us start our physiology revision series. So we are starting with general physiology and membrane potential. So the first question here is Gibbs-Donan equation is mainly due to what? Is it due to calcium? Is it due to bicarbonate? Is it due to phosphate? Or is it due to proteins, right? So we have four options. Before answering this question, as always, let us discuss some basic details. So here, let us have some discussion on membrane potential. So what is this membrane potential? In any cell, okay, there occurs a potential difference between the inside of the cell and outside of the cell. Okay, so there occurs a electrical potential difference. So what do you mean by membrane potential? In any cell, there occurs an electrical potential difference between the inside of the cell membrane and the outside of the cell membrane. This electrical potential difference that happens between the inside and the outside of the cell membrane is called as membrane potential. So membrane potential is nothing but the electrical potential difference. Okay, just a sec, we'll just take a break. The pen is not writing properly. We'll get back to you soon. Welcome back. So we were discussing about membrane potential, right? So what is membrane potential? Membrane potential is nothing but when you have a cell membrane, there occurs a electrical potential difference between inside and outside of the cell membrane. This potential difference is called as membrane potential. Okay, the same membrane potential, when you record it when the cell is at rest, then at rest we call it as resting membrane potential. Okay, and this resting membrane potential, you will all know it is different for different tissues. For example, for the nerves it is around minus 70 millivolt. For your skeletal muscle, cardiac muscle, it is around minus 90 millivolt. And for pacemaker tissues like the pre-Botzinger neurons or your interstitial cells of Kajal or the cells in the pacemaker cells in the SA node, this resting membrane potential is oscillatory between -40 to -60 millivolt. So now you know what is membrane potential, what is resting membrane potential. Okay, so now when you have a semi-permeable membrane. So look at this picture here. We have a semi-permeable membrane and we have solutions in two compartments are there, solution A and solution B. Okay, now in solution A, you have some ions. You have sodium ions and chloride ions, and in solution B also we have sodium ions and chloride ions. Now the movement of these ions across the cell membrane. How do these ions move across the semi-permeable cell membrane? So the movement of this ion is mainly dependent on the permeability. The movement of this ion is mainly dependent on the permeability. Okay, permeability of the cell membrane. So why are we discussing this here? Why are we discussing about the permeability of the cell membrane? Because I said there is a electrical potential difference that occurs across the cell membrane. Why or when will an electrical potential difference happen? Only because of the distribution of the ions. Because of the distribution of the ions across the cell membrane will cause an electrical potential difference. So how can the ions move through the semi-permeable membrane? That depends upon the permeability of the cell membrane. Okay, and then along with permeability, the other factors like your Gibbs-Donan equation or Donan's effect, Nernst equation, and Goldman-Hodgkin's reaction, all these will also are factors which are going to affect the movement of the ions. So the first one what we are seeing here is the permeability. Let's discuss a little bit about the permeability of the cell membrane. Okay, permeability of the ion in the cell membrane. You have, what are the common ions? Can you tell me what are all the common ions which is present inside the cell? Yes, sodium, potassium, chloride, bicarbonate, etc. So these are all the common ions which is present inside your cell. Now these ions have to move through this semi-permeable cell membrane. Okay, so how will they move through the semi-permeable cell membrane? It depends upon the permeability of these ions to the cell membrane. So if you compare all these ions, can you tell me which ion is the most permeable ion in the cell membrane? It's a very important MCQ. Which ion is the most permeable? Yes, it is the potassium ion which is the most permeable. Okay, so permeability of an ion depends upon two things. Permeability of an ion across the cell membrane is dependent upon two things. One is size of that particular molecule and then its weight. Okay, weight also when it is hydrated. Okay, weight of the molecule in its hydrated form. So these are the two factors that decides the permeability of a particular ion. Let us consider these common ions. Let us take now sodium and potassium. You have the sodium ion, you have the potassium ion. If you look at the molecular weight of sodium and potassium, the molecular weight of potassium is 39 and the molecular weight of sodium is around 23. Okay. Okay, so now the molecular weight and so the molecular weight of sodium is around 39. Molecular weight of sodium is around 23. Okay, I think it is visible for you, right? Okay, now the molecular weight of sodium ion is 23, the molecular weight of potassium ion is 39. So when you look at the molecular weight, please tell me by looking at the molecular weight, which ion will be easily permeable? The ion which has lesser molecular weight should ideally be easily permeable, right? But in reality, potassium is 500 to 1000 times, okay, 500 to 1000 times more permeable than sodium. Why? Because of the radius or the diameter. Once it is hydrated, the diameter of the sodium is greater compared to potassium ions. In this hydrated form, the sodium ion is larger than the potassium ion. That is why potassium ion is the most permeable ion. So now I think one concept is clear for you, right? What did we discuss so far? We saw what is membrane potential. Membrane potential is nothing but the electrical difference that happens between the inside and outside of the cell membrane. And what causes this electrical potential difference? The distribution of the ions across the cell membrane, right? Now, how or what influences this distribution of the ions across the cell membrane? The permeability of the ions across the cell membrane decides the distribution of the ions across the cell membrane. So when you talk about permeability of an ion, what are the factors that is important for deciding factors for permeability of a particular ion? The size of the ion when it is hydrated and also the molecular weight of the ion. Lesser the molecular weight, greater will be its permeability. At the same time, when it is hydrated, the size of the ion also has to be small to be easily permeable through the cell membrane. Okay, so based on all these features, we know among all the ions, potassium ion is the most permeable ion across the cell membrane, and that is why potassium ion contributes to the genesis of resting membrane potential. So these are all the concepts you know, and every line here is an important MCQ. Okay, which ion is contributing for the resting membrane potential, how many times is potassium more permeable compared to sodium. Okay, and they can also ask based on the molecular weight, sodium ion is smaller compared to potassium ion, but still what is the physiological reason for potassium ion being most permeable? These are all some expected MCQs which has been asked over the years, right? So now with this baseline, with this basic knowledge, let's approach this Gibbs-Donan equation. Okay, so we are going to see three equations today. One in for this question, to answer this question, you should be knowing about Gibbs-Donan equation, then you should also be knowing about the Nernst equation, and then finally the Goldman's equation. Okay, so in Gibbs-Donan, so now let us look at the Gibbs-Donan equation. So they're coming back to the same picture here. We have a semi-permeable membrane, and on both sides of the semi-permeable membrane, solutions are there. Two solutions are there, solution A and solution B. Okay, at equilibrium. Okay, at equilibrium. Okay, the total number of cations in solution A is going to be equal to the total number of cations in solution the total number of cations in solution A is going to be equal to the total number of anions in solution A. This is, I am talking about when the cell is at equilibrium. Okay, so when a cell is at equilibrium, the total number of positive ions in a particular solution is equal to the total number of negative ions in the particular solution. The same thing applies to solution B also. The total number of positive ions here, in this example, we have taken sodium and chloride, common ions, right? So the total number of sodium ions is equal to the total number of chloride ions. So the total number of positive and negative charges are equal. So basically what does this equation tell you? The number of positive and the number of negative charges on that particular side is equal. So that is one. Second thing is, at equilibrium, the product of the anions and cations on side A is equal. The product of the anions and cations on solution A is equal to the product of anions and cations on solution B. Basically, what we are deriving from both these equations, what inference do you get from both these equations? That at equilibrium, the charges, the positive and negative charges are equal and balanced. That is what we can derive from this equation. This is at equilibrium. Okay, and all these ions are diffusible ions. All these ions can diffuse across the cell membrane. Okay, now imagine a situation where a non-diffusible ion, which is negatively charged, a negatively charged non-diffusible ion. Okay, a negatively charged this X, what you're seeing here, X is a negatively charged non-diffusible ion that is added to solution A. Now what will happen? Tell me, now what will happen to this equation? On side A, is the total number of positive charges and negative charges equal? No. Now you have more negative charges in side A, right? So the sodium is not equal, the positive number of positive, rather than telling is as sodium, the number of positive charges is less than the number of negative charges on side A, because we have added a non-diffusible ion. So now, since this ion is non-diffusible, to maintain electroneutrality, what is going to happen? This chloride is going to go, this is a semi-permeable membrane, this is a diffusible ion. So this negative charge in the form of chloride is going to go to solution B. So in solution B, the concentration of chloride is increasing. Okay, now to compensate for this, what will happen? The positive ion in form of sodium from solution B is going to come to solution A. So in solution A, the sodium level is increased. So now what has happened? The presence of a non-diffusible ion has altered the equilibrium, has altered the distribution of the diffusible ions across the cell membrane, right? Are you able to understand the concept and keep track of what I'm telling? So whatever balanced distribution that was there during equilibrium gets completely disrupted when we add a non-diffusible ion to one side of the cell. Okay, so to one side of the cell, when I add a non-diffusible ion, what is happening? Asymmetrical distribution of diffusible ions is taking place, and this is called as Gibbs-Donen effect. So what is it? Okay, so now look at this equation now. So here all as I told, sodium is more here, chloride is more in solution B. So now the total number of positive charges on side A is greater than the total number of positive charges on solution B. Similarly, the total number of negative charges on, I hope it is visible to you now. Sorry, it was in a lower resolution. Now, the total number of negative charges on side A is less than the total number of negative charges on side B because of the asymmetrical movement of these diffusible ion. So, what does Gibbs-Donen effect say? The presence of a non-diffusible ion on one side of the membrane affects the distribution of other ions which are permeable. Okay, so this is going to result in what? Asymmetrical distribution of ion across the cell membrane. Okay, so to put it in very simple terms, what is Gibbs-Donen effect? Asymmetrical distribution of ion across the cell membrane. Okay, that is Gibbs-Donen effect. Okay, now can we extrapolate the same scenario, same analogy to our own cells? Consider the intracellular fluid and extracellular fluid. Okay, inside the cell. Okay, same analogy. We will take it for the intracellular fluid and extracellular. Instead of solution A, now you take it as ICF and you take this B portion as ECF. Okay, so in intracellular fluid, what are the can you name the non-diffusible, or can you think about the non-diffusible anions which is present inside the intracellular fluid? Please take some time and think and answer. I will just see in the comments. Okay, so the non-diffusible ion which is present inside the cells are what? Nothing but the phosphate and the proteins. Okay, so proteins and phosphate are these negatively charged non-diffusible ions which is present inside the intracellular compartment. Okay, so the same scenario exists across our human cell membrane. Okay, between the ICF and ECF we have the same scenario, right? Now, what is the use or implication of this Gibbs-Donen equation? So now we understood via the Gibbs-Donen equation, we understood that there are the ions are asymmetrically distributed across the cell membrane. So this is one understanding we got from the Gibbs-Donen equation. What is the implication of this? Okay, this Gibbs-Donen equation, there will be an electrical difference across the cell membrane. That is what we saw now. And that electrical difference can be determined with the help of Nernst equation. The second and most important one is, because of this presence of these protein anions inside the cell, protein is an osmotically active particle. So what it will do? It is going to hold water. It is going to draw fluid into it. So if it draws fluid into it from the interstitial spaces, what will happen to the cells? They are going to swell and rupture. This is prevented. Okay, this is prevented by what? The sodium potassium pump which is present in the cell membrane, which is going to pump 3 sodium ions outside and only bring 2 sodium ions inside. Okay, and it maintains the osmotic equilibrium. Thus, Gibbs-Donen equation tells us, or via Gibbs-Donen equation, we understand how the cell is maintaining its cell volume and shape. Okay, clear? So what is the implications of from Gibbs-Donen equation? What do you understand? We understand two things. One is asymmetrical distribution of ion across the cell membrane because of the presence of non-diffusible non-diffusible phosphates and protein anions in the cell membrane. Second thing, because of this asymmetrical distribution, the cell can swell up and burst, but this is prevented by the presence of sodium potassium ATPase. So the Gibbs-Donen equation, there are MCQs asking which among these four equations tells us about the cell stability and cell volume. So which options will you take? Gibbs-Donen equation. So that is Gibbs-Donen equation. Okay. So now with this background, let us answer this question. Gibbs-Donen equation is mainly due to what? Calcium, bicarbonate, phosphate, or proteins. Now the answer is obvious. What is it? Presence of proteins. Why? Proteins are non-diffusible anions present in the intracellular compartment. Okay, now we are done with Gibbs-Donan equation. Now we will move to the next equation, that is Nernst equation. So in membrane potential, the most important are these equations, right? So any question comes from these equations, you should be able to answer. Once you have done with this revision, you should be very, very confident and clear in answering any questions which is coming from this membrane potential. So Gibbs-Donan is clear. I hope it is very clear. If you still have any doubts, please post your questions in the comment section. Next, we are moving on to the Nernst equation. Already in the implications we saw, right? What does Nernst equation do? The magnitude of this electrical difference. We told electrical potential, always I have been from the starting I have been talking about this word, right? Electrical potential difference, right? Now, how much is this electrical potential difference? The magnitude of this electrical potential difference for individual ions. This is a key word you have to remember, individual ions. For a single ion, the electrical potential difference for individual ions is calculated with the help of Nernst equation. Okay, so for example, just look at this. Okay, so now let's look at this. What are you seeing here? It is a cell, right? And inside the cell, now you know asymmetrical, one thing is very clear, asymmetrical distribution of ions across the cell membrane. When I say asymmetrical distribution of ion, what type of ions is inside and what type of ions is outside? Inside of the cell, the cations are always more. Inside of the cell is having more positive charges. Okay, according to the based on the Donan's effect compared to the outside of the cell. And can you again, we just now discussed, can you recall and tell me which is the most abundant intracellular cation? Potassium. Okay, so the inside of the cell, the most abundant intracellular cation is potassium. So inside of the cell you have a lot of potassium. So naturally what is going to happen to maintain its concentration gradient? To maintain its concentration gradient, potassium ions is going to diffuse out. So this is concentration gradient. So to maintain its concentration gradient, since more cations are inside of the cell, these cations, and the most common cation, abundantly available cation inside the cell is potassium. So to maintain its concentration gradient, more potassium is inside, less potassium is outside. So to maintain its concentration gradient, what is going to happen? Potassium is going to leave the cell. It is going to diffuse the cell. Okay. This will keep happening for a while, and then at one point it will stop, and the potassium which came out is going to enter into the cell again. Okay, this potassium is again going to go back to the cell to maintain its electrical gradient. Okay, to maintain its electrical gradient, to maintain its concentration gradient, potassium is leaving the cell. What do I mean by concentration gradient? It's going to move from a region of higher concentration to region of lower concentration to equilibrate on both the sides. So that is why potassium, which is present more on the inside of the cell, is leaving the cell and going outside, because the potassium concentration is outside is less. So this is what we call as concentration gradient. Okay, when potassium is leaving, what will happen? The potassium, the positive charges inside the cell will reduce. The negativity inside the cell will increase. Once the negativity inside the cell is increasing, automatically what will happen? The proton anions which is present inside the cell is going to stop the diffusion of potassium, and at the same time positive potassium ions which were there outside is now going to come inside. So now that is what is called as electrical gradient. So both, at one point the electrical gradient is exactly balanced by the concentration gradient, but in opposite direction, and this point is called as, this potential is called as equilibrium potential. Okay, what is this potential called as? Equilibrium potential. And our Nernst equation is going to measure the magnitude of this equilibrium potential. Okay, fine. Okay, so how are we going to measure this equilibrium potential? This is a very important question. They will ask you to calculate, they'll give the Nernst equation, or they will ask you, they'll give you the values for a particular ion and ask to calculate the Nernst equation. Many questions have come in previous years, but it is a very, very easy, it's not so tough, you can calculate this very easily. So now you know the basis of Nernst equation. The formula for calculating the Nernst equation is here is the equilibrium potential is given by the formula plus or minus 61 to the logarithm of concentration of the substance outside to concentration in the inside. Okay. Now let us take some common ions here. Let us take sodium. Suppose they have asked you to calculate the Nernst equation for sodium, Nernst potential for sodium. Then how will you calculate the Nernst potential for sodium? Is calculated by concentration on the outside is around 150, concentration on the inside is 15. So how much it is? Plus or minus 61, log of 61. So for the sodium ion, it is plus or minus 61 log 10. Okay, log 10 is 1. Okay, so the Nernst potential or equilibrium potential for sodium ion is plus or minus 61. So you have calculated it to be 61. This much you know. 61 you have got, right? How would you decide upon the charge? Most of the time you will do the calculation correctly. Very, very simple. Outside divided by inside, that's all. But what is the charge you are going to put? That is the important thing. Okay. How are you going to decide about the charge? So while deciding about the charge, you have to think about two things. One, you look at the concentration gradient. That is why just now we discussed, right? Concentration gradient of that ion. Okay, for sodium ion. Now tell me the concentration gradient for sodium ion. Is it from inside to outside or from outside to inside? What is the concentration gradient for sodium ion? It is from outside to inside. The extracellular sodium is more compared to the intracellular sodium. So naturally what is going to happen? It is going to come into the cell. Okay, so that much you know. Concentration gradient for sodium is from outside to inside. Now, because of the movement of this ion, okay, now how did you decide that it is coming from outside to inside? By looking at its concentration gradient, where it is more from that compartment, it is going to come to the lesser compartment. Okay, now by the movement of that ion into the cell membrane, what is happening to the charges? So second thing is movement of the ion results in what type of charge inside the cell. Okay, so as the ion is moving into the cell, it is a positive ion. So what will happen? The positivity inside the cell is going to become more. Okay, that is why here for sodium it is positive. Okay, plus 60 millivolt. So the resting membrane potential for sodium is plus 60 millivolt. Now the same way if you calculate for potassium, look at potassium. If you calculate the the Nernst potential for potassium, it is coming to around minus 90 millivolt. Here, why it is minus 90? What is the concentration gradient for potassium? From inside it is going to go to outside. Potassium will leave the cell. From inside it is going outside. So when positive ions are leaving the cell, what will happen? The negativity inside the cell will increase. So that is why here the charge is negative. Okay. Now I think this concept is clear. If you understand this concept, you are never going to make any error in deciding the charge. All you have to see is which direction the ion is going to move. Is it going to move from inside to outside or it is going to move from outside to inside? Okay, one point. As a result of the movement of the ion, what is going to happen to the charge inside the ion? Are the negative charges increasing or the positive charges increasing? Whichever charge is increasing, that is going to be the value here. Okay, so that is about Nernst potential. Okay, here in this tabular column, again I want you to see on one thing. Okay, what is this? This is for chloride ion. The resting membrane potential, all these are Nernst potential, right? So now the resting membrane potential, not the resting membrane potential, sorry, the Nernst potential for chloride ion, the Nernst potential or the Nernst equation for chloride ion is around minus 70 millivolt. This minus 70 millivolt Nernst potential for chloride ion is the resting membrane potential for which tissue? This is the resting membrane potential for a neuron. Okay, the resting membrane potential of the neuron is around It's a very important MCQ that has been asked. The RMP of a neuron is around minus 70 millivolt. This corresponds to the Nernst potential of which ion? It corresponds to the Nernst potential of chloride ion. Okay, so that is our Nernst equation. Fine. Then the last equation in this membrane potential is Goldman's equation. Very, very simple. Goldman's equation is nothing but, in Nernst equation, what did you see? You calculated the equilibrium potential of single ion. So if they ask equilibrium potential of a single ion, you will always choose Nernst potential. If they are asking the equilibrium potential of multiple ions, then it is Goldman's equation. That's all, as simple as that. In Goldman's equation, multiple ions are involved. Why? Because practically we know that only one single ion doesn't exist across the cell, right? We have multiple ions are present, and these multiple ions and their permeability is going to contribute to the action potential. So that is why in Goldman's equation there they have included the permeability and concentration gradient of the common ions. So here again in the formula, the membrane potential, the equilibrium potential is given by RT by F, where R is the gas constant, T is the temperature, F is the Faraday constant. This is all constant. Logarithm of potassium, permeabilities of potassium, sum of permeability of potassium, sodium and chloride, and their concentration gradient divided by the concentration gradient of the same ions, right? So that is the Goldman's equation. So from Goldman's equation, what do you understand? The membrane potential is determined not only by one single ion, by the gradient of each of these individual ions. Fine, that is the inference what we derive from Goldman's equation. Okay, so to summarize, very important, please make a note. Gibbs-Donen effect is going to tell us how a cell is prevented from rupturing. That is the shape and volume of cell. How is it maintained? Gibbs-Donen equation is going to tell us that. Nernst equation is used for calculation of equilibrium potential of one ion, single ion. Goldman's equation, calculation of the diffusion potential of multiple ions, multiple permeable ions. Fine. I think this is clear, and most of the questions and topics in membrane potential, I think I've covered it. You're set for your membrane potential. Now let's go to the next question. Following are the levels of various ions in a body fluid. Okay. Identify the type of fluid. They are given the values, and now they are asking you whether this is a intracellular fluid or extracellular fluid. So that is the question. So how much is the sodium? The sodium is around 10 milliequivalents per liter. Potassium is around 140 milliequivalents per liter. Just by looking at sodium and potassium itself, you can decide. By now, you should know this answer. Okay. Chloride is around 15 milliequivalents. Bicarbonate is around 12 milliequivalents. So in this, how much is potassium? 140 milliequivalents per liter. Potassium is more, sodium is less. So classically, what is it? Is it let us look at the options. Okay. ICF, plasma, interstitial fluid and cerebrospinal fluid. So what is the answer here? It is the intercellular fluid, ICF. In the ICF only, intracellular fluid, the concentration of sodium is, concentration of potassium is high, and the concentration of sodium is low. So the fluid here is your ICF. Okay. So here is your table showing the concentration of some common ions. So sodium is more in the intracellular fluid. Okay. Potassium is more in the, sodium is more in the extracellular fluid. Potassium is more in the intracellular fluid. Okay. And chloride is more again in the extracellular fluid. Bicarbonate is also more in the ECF. Okay. And calcium also is more in the extracellular fluid. Okay. Now coming to the predominant ions. Okay. Overall predominant ions, the most abundant cation in the extracellular fluid is sodium. Okay, please note this. Again, MCQs have been asked. Most abundant cation in the extracellular fluid is sodium. Okay, the most abundant anion in the extracellular fluid is chloride. So in the extracellular fluid, the most abundant cation is sodium, most abundant anion is chloride. Okay. In the intracellular fluid, the most abundant cation is potassium and the most abundant anion is phosphate. Most of the time here people make mistake and take it as proteins. It is not the proteins, it is a phosphate which is the most abundant anion inside the intracellular compartment, inside the cell. Is this clear? Okay. Now going to the next question. Identify the type of transport across the cell membrane. So here they are asking us to identify the different types. What type of transport from this picture based MCQ they are asking us to identify the type of transport. So here what is the thing which you see? So this is the extracellular. First identify which is the extracellular side and which is intra. So here they have told this is the extracellular compartment. Extracellular compartment, the concentration of this particular ion is more. Okay, now what are you seeing? A carrier protein. See, this keyword is a carrier protein. A carrier protein is transporting this particular ion from the extracellular compartment, that is from the region of higher and extracellular. I see the concentration is more. So the concentration is more on the outside. From a region of higher concentration, it is going down to a region of lower concentration. Okay. So from a region of higher concentration, this particular substance is moving to a region of lower concentration. So first this you already saw. So what type of transport will happen from region of higher concentration to lower concentration? Passive movement, right? Okay, passive movement. So one point is clear. Next, what type of passive movement will employ a carrier protein to move that particular substance or substrate? In passive movement, the one which involves carrier. So to identify this transport, we have finalized two things. One is this transport is a passive transport because it is moving from a region of higher concentration to lower concentration. Okay. Second thing, what did we see? This is a type of passive transport which employs a carrier protein. So what is it that is passive and it employs a carrier protein? Facilitated diffusion. Okay. Can you think some examples for facilitated diffusion? The transport of glucose from the interstitial cell into the blood via the glucose transporter, GLUTs. So GLUTs are all examples of facilitated diffusion. Okay, most of the time confusion comes here between the glucose transporter GLUT and the secondary active transport sodium SGLT, sodium glucose co-transporter and glucose transporter. You will always have some confusion and sometimes you tend to make some mistakes. Remember, glucose transporters are always facilitated diffusion. Okay, SGLT is an example of secondary active transport. Sodium glucose co-transporter is an example of secondary active transport, whereas GLUT is an example of facilitated diffusion. So in this scenario, so what are the options? Can you see facilitated diffusion here? Yes. So option C is facilitated diffusion, right? Okay. Now let us briefly revise a little bit about transport across cell membrane, just the salient points. Okay. How many types of transport are there? One is passive transport, then active transport. Okay. Then what is this? Vesicular transport, and finally what do you have? Transport across epithelia. Transport across epithelia. 4 types of transport. What are the different types of passive transport? We have first is simple diffusion, then just now we saw facilitated diffusion, third is osmosis, fourth is filtration, fifth is bulk flow, and number 6 is solvent drag. So all these 6 are examples of passive transport. So please remember all these 6 are examples of passive transport. They will ask all among this are examples of passive transport except. Okay. Active transport, only 2 types. Primary active transport, secondary active transport. Vesicular transport is of 2 types. Exocytosis, endocytosis. Transport across epithelia, transcellular cellular and paracellular transport, right? So this is broadly the different types of transport across cell membrane. Most of the questions are going to come within this active and passive transport. Okay, so what are all the key features of this active and passive transport? Okay, so simple diffusion you all know. From this picture you can say simple diffusion is the substance which are lipid soluble will simply directly, lipid soluble gases like carbon dioxide, oxygen and all, what is it going to do? It is going to simply diffuse across the cell membrane. Okay, lipid bilayer. Then you have facilitated diffusion. Okay, where you have a carrier protein which is going to carry this particular substrate from a region of higher concentration to a region of lower concentration. So that is with passive transport. Okay. Okay, so here, sorry, this is facilitated diffusion where you have a carrier protein which is carrying, this is the carrier protein which is carrying this molecule. So here what you see is a simple diffusion where a channel protein is there. For example, movement of, we have your leaky channels for sodium, leaky channels for potassium. Okay, leaky sodium channels, leaky potassium channel, these are all examples for simple diffusion. Okay, you have your channels through which those particular ions are going to easily diffuse from a region of higher concentration to lower concentration. What is so drastic about this passive transport? No ATP is used. So this is energy independent. Passive transport is energy independent. Okay. So passive transport, we saw simple example for simple diffusion and then example for a facilitated diffusion. Okay. Now, what is osmosis? Movement of a solvent from a region of lower solute concentration to a region of higher solute concentration. Okay, since the solute is not able to move, it is a solvent which is moving from a lower solute concentration to the higher solute concentration so that it dilutes the side which is having higher solute. Okay, to maintain an osmotic equilibrium. So that is called as osmosis. Okay, then comes filtration. Okay, filtration is when a fluid is filtered forcefully, when a fluid is made to leave a compartment forcefully because of the difference in their Starling's forces. What are Starling's forces? The oncotic and hydrostatic pressure. Because of this, when a fluid is moving, we call it as filtration. Okay. What is bulk flow? When a large amount of fluid is filtered, we call it as bulk flow. And what is solvent drag? When large amount of fluid is getting filtered, it is going to drag the solvent along with it. Okay, so we call that is called the solvent drag. So that finishes our passive diffusion. Now coming to active diffusion, two types of active transport, not diffusion. Active transport, two types of active transport are there. Primary active transport and secondary active transport. What do you mean by primary active transport? Both, first is key features of active transport is uphill movement, ATP dependent. Okay, uphill means from a region of lower concentration to the lower region of higher concentration with the expenditure of energy. Okay, now the energy is utilized primarily for the transport of that particular substrate, then we call it as primary active transport. Suppose the energy that is released by this primary active transport, if it is utilized to transport another substance, then we call it as secondary active transport. The energy is indirectly utilized by the transport of another substance, then we call it as secondary active transport. Okay, so those SGLT are all examples of secondary active transport. Okay, let us look at the picture here. So this is active transport from a region of, look at the direction of the arrow. For passive transport, the arrow was coming from higher concentration to lower concentration. Now for active transport, energy is utilized and the arrow is moving from a region of lower concentration to a region of higher concentration. Okay, now what is one more common thing what you see here? Carrier protein. Carrier protein is utilized, again this is a tricky MCQ, they might ask. Carrier protein is utilized in all of the following process except primary active transport, secondary active transport, facilitated diffusion, simple diffusion, right? So here the moment you see the word diffusion, you might think carrier protein is not utilized. So that confusion should not be there. Both active and passive mechanisms utilize the carrier protein to transport their substrates. Only difference is in passive process, energy independent, active process is an energy dependent process. Okay. Now, here you saw example of active transport. Let us, what is primary and secondary active transport? Examples of primary active transport, most common example is sodium, potassium, ATPase pump, which is going to pump 3 sodium outside and 2 sodium inside the cell. Okay, most ubiquitous pump inside the human cell. Okay, so now what is it doing? This pump, it is called as a ATPase pump. Why is it called as an ATPase pump? Because it has inherent ATPase activity. It is going to break down, or it is going to cause hydrolysis of ATP. Since it causes hydrolysis of ATP and energy is released, the transport is happening. Okay, now the energy released by this, if it is utilized to transport some other substance, then we call it a secondary active transport. So in this example, the energy released by the sodium potassium ATPase primary active transport, it utilized by this SGLT, sodium glucose co-transporter, to transport glucose along with sodium into the cell. So this is an example of secondary active transport. Okay, so now, little bit about this carrier protein. We have been discussing carrier protein so many times. Okay, now is it clear, all of you? So we have seen all these passive movements we have seen, active movements also we have seen. And one thing what is common between passive and active movement is both passive as well as active transport can utilize carrier protein, right? Now, carrier protein. So three types of carrier mediated transport are happening. One is uniport. Okay, movement in one direction, only one substance. Okay, again movement of all these ions like sodium, potassium, etc. Now you have symport. Symport is what just now we saw, sodium glucose co-transporter. Okay, SGLT. Then you have not only sodium glucose, similarly sodium amino acid co-transporter. If so many co-transporters are there in your renal tubules for reabsorption, right? Then another thing is, another type of transport is antiport. In antiport, what is happening? One molecule is moving inside, the other molecule is coming out. So that is with the help of a carrier protein. All these three, when we are discussing carrier protein mediated transport, you have three types: uniport, symport, antiport. Okay. So now in this antiport, what is happening? One is moving inside, the other is moving outside in opposite direction. Example is sodium hydrogen exchanger. Okay, anion exchanges. All this is going to be examples of antiport. Okay. Now we will see the difference between simple diffusion, facilitated diffusion, and active transport. Most of the key points I have already discussed. Okay. One another important concept what you have to remember here is, whenever there is a carrier mediated transport, be it passive or be it active, two things will happen. One is saturation kinetics, it follows saturation kinetics, and competitive inhibition will happen. What do we mean by competitive inhibition and saturation kinetics? Okay, then competitive inhibition. What is saturation kinetics? The amount of carrier protein that is available is not infinite, right? A specific amount of carrier protein is only present at a given point of time. So the carrier proteins can get saturated when all the when this particular substrate that needs to be transported is attached to all the carrier proteins, then it is going to get saturated. So that is called as saturation kinetics. Okay, the saturation of this carrier proteins. Then competitive inhibition. Competitive inhibition means we have the carrier protein and we have a substrate. This substrate is going to bind with the carrier protein and the carrier protein is going to transport this substrate. Suppose in the same cell you have some other substrate which is structurally similar to the substrate which needs to be transported. For example, let us take glucose and galactose. Okay, from the intestinal lumen, we want both glucose to be absorbed, galactose to be absorbed into the interstitial cells, right? Now, what will happen is generally both glucose and galactose are structurally similar. Now, the carrier protein which is going to transport glucose can be competitively inhibited by galactose also. then what will happen? The transport of glucose is going to be reduced. So this is called as competitive inhibition. That is substrate structurally similar to the one that needs to be transported. If it is present, it is going to go compete with our actual substrate that needs to be transported. So this is called as competitive inhibition. Okay, then the rest of the things I think we have already seen. Rest of the differences I have already discussed. Okay, so now that ends our discussion on general physiology and membrane potential. Almost all the important high yield topics have been covered. If you still have some doubts, you can always go back to our revision series, where in our app we have the entire lecture covered. Okay, for more details you can also look into the app. Now coming to the nerve and muscle physiology. So next topic we are moving on to nerve and muscle physiology. If you have any doubts, you can always post your queries in the comment box. Okay, I will just see if you have any doubts for general physiology and membrane potential. Protein, which is going to transport glucose, can be okay. So no doubt so far. Now we will move on to nerve and muscle physiology. Okay. So in nerve and muscle physiology, lot of questions. Most high yield topic is this different types of nerve fibers. Okay, so let us discuss that in detail so that you don't make any mistakes. Okay, so what is the question here? Slow conduction velocity is seen in which of the following fibers? What are they asking? Slow conduction velocity. Before looking into the options, let us first see the classification of nerve fibers. Once we come back, I always feel once you know the basics, then when you go to the question will never look as daunting as it looked previously, right? So now first let us look at the discussion. Nerve fibers can be classified based on several things. A type of nerve fiber, the type of sensations they carry. Is it an afferent fiber? Is it an efferent fiber? Is it myelinated or unmyelinated, right? Is it present in the periphery, or is it present in the central nervous system? So many classifications are there. But what is very, very important for us, especially MCQ point of view, what maximum number of MCQ is coming is based on the diameter of the nerve fiber and classification based on the conduction velocity. So based on the conduction velocity and the diameter of the nerve fibers, we have the Erlanger's and Guess's classification. Okay, how nerve fibers are classified according to this? Type A, type B and type C. Okay, we have type A, type B, type C according to the Erlanger's and Guess's classification. And one more classification from where lot of MCQs keep coming is the numerical classification. That is one numerical classification. We have fibers 1A and 1B, 2, 3 and 4. Okay, so you just remember and have a clear idea of both these classification. So according to Erlanger's and Guess's classification, generally when you see, if the diameter of the fiber is more, if the diameter of the fiber is greater, then the conduction velocity is going to be greater, directly proportional. Larger the size of the fiber, greater will be the conduction velocity. Okay, second thing you have to remember is myelination. Okay, more myelination, more conduction velocity. This is also directly proportional. Greater the myelination, greater will be the conduction velocity. So keep these 2 points in mind. If the size of the fiber is large, the conduction velocity is going to be better. Okay. And what type of fibers have large diameters? The ones that are myelinated. Okay. So with that in mind, look at these fibers first. Let us not look at the conduction velocity. First, only look at the size of the fiber. From this okay, so from this picture here, or from this tabular column, which of these fibers have the greatest conduction velocity? Okay, sorry, which of the fibers is having the largest size? A fibers. In A, which is one A alpha. A alpha fibers are the largest. Then as you keep coming down, A fibers are again divided into 4. A alpha, A beta, A gamma and A delta. What are the 4 different types of fibers? Already I told you A, B and C fibers are there. 3 types of fibers. In this, A is further subdivided into A alpha, A beta, A gamma, A delta. Alpha, beta, gamma, delta. Easy to remember. Okay, same order. You're starting with the fiber which is having the maximum conduction velocity. So which is having the maximum conduction velocity? A alpha, then A beta, then A gamma, then finally A delta. So among the A fibers which is having the maximum conduction velocity? A alpha. Which is having the minimum conduction velocity among the A fibers? A delta. Okay. As such, among these A, B and C, which is having the slowest conduction velocity? C fibers. For C fibers, it is only 0.4 to 1 micron, 0.4 to 1.2. The size is 0.4 to 1.2 micron meter. Since the size is small, the conduction velocity is also small. Okay, here we have both the comparison between the conduction velocity and the diameter. So you can see the fiber A alpha fiber has the highest diameter, that is 13 to 20 micron meter. So look at the conduction velocity, 80 to 120 meters per second. As you keep coming down, look at A delta fibers. The diameter is only around 1 to 5 micron meter and the conduction velocity is only 3 to 30 milliseconds. Okay, and the slowest fiber is your C fiber because their diameter is also very small, 0.2 to 1.5, and their conduction velocity is only 0.5 to 2.0 meters per second. Right. So another important feature is as you keep coming down, the myelination also decreases. Myelination decreases. So the fibers with the maximum myelination, which fibers will have maximum myelination? A alpha. Which fibers is totally unmyelinated? C fibers. Okay. So now I think roughly you are clear, right? Now, before going into the sensations that is carried by these fibers, we will also compare these fibers with the numerical classification. Okay. Numerical classification, we have 1, 2, 3 and 4. 1 is further subdivided into 1A and 1B. Just like A fibers were divided into A, alpha, beta, gamma, delta. 1 also you have numerical classification 1A and 1B. Does it ring a bell? Where do you have heard of this word? Primary 1A afferents, 1B, type 2 afferents? Your muscle spindle, right? And the Golgi tendon organ. 1B is Golgi tendon organ, primary afferents. 1A and type 2 are our muscle spindle, right? So that is what that numerical classification is what we are discussing here. Okay. So this 1A and 1B belongs to Erlangen's classification. It is coinciding with A alpha fibers. Okay. Type 2 fibers belong to A beta. Type 3 is A delta and type 4 corresponds to C fibers. Okay. Now finally, what is the functions of these fibers? What is the function of these fibers? See, A alpha fibers have the fastest conduction velocity. They are used for somatosensory perception. Okay, somatosensory and proprioceptive functions. Okay, so A alpha is the primary receptors for muscle spindle. So you have to remember A alpha is the primary receptor for muscle spindle. This is a key word. If they ask you which is a primary receptor for muscle spindle, you will say A alpha. A beta is for Golgi tendon organ. So muscle spindle is A alpha. Okay. A beta is Golgi tendon organ. And most common question is which fibers carry touch and pressure? Again, A beta. Okay, very commonly asked, many times they have asked fibers with highest conduction velocity, A alpha. Among the A fibers which has the lowest conduction velocity, A delta. Among ABC which is having the lowest conduction velocity, it is C fibers. Okay, what are the A beta fibers transmit? Touch and pressure. Okay, then coming to B fibers. B fibers are preganglionic autonomic fibers. Type B fibers are preganglionic autonomic fibers. Type C fibers function is postganglionic autonomic, and type C fibers also conduct pain and temperature. And type C, these are slow conduction velocity. So what type of pain will type C fibers conduct? Slow pain. Then what fiber will conduct fast pain? A delta. Okay. Okay. It might look confusing, but it is very, very easy. Simple key points. Okay. A delta fibers carry fast pain. C fibers carry slow pain. Okay. C fibers are also postganglionic autonomic. B fibers are the ones that is preganglionic autonomic. Okay. And A beta fibers for touch and pressure. Fine. Now let us approach this question. So in this question, what are they asking? Slow conduction velocity is seen in which of the following fibers? It is preganglionic. You have the tabular column also here. From there itself you can say, is it option A or is it option B? It is option C or option D. What is it? C fibers are postganglionic autonomic. So the right answer here is option B. Okay. Now next question. A female while watching movie at home sleeps with her hand under her head. Which nerve fibers are most susceptible to injury? So one classification we saw is based on their conduction velocity and numerical classification. One more classification which is important for you is based on their susceptibility to various agents. Three types of agents are only there: hypoxia, pressure, and local anesthetics. Okay, easy. So here what they are saying, she is watching movie at home, sleeps with her hand under her head. So what is happening? Lot of pressure. So which fibers are most susceptible to the injury? Now first you have to identify which injury here. The injury here is pressure. Because she has slept overnight with the hand under her head, the head is going to put pressure on the hand. So the nerve fiber is getting compressed. So the first thing is susceptible agent, you have identified it to be pressure. Now look at this tabular column and tell me which of the fibers is most susceptible to pressure. So if you look here, type A fiber is most susceptible to pressure. So what is the answer here? Type A fibers. Okay. So let us look at this classification. So based on the susceptibility, if you don't remember the intermediate susceptibility, it is okay. But most susceptible and least susceptible, you have to always remember. When you remember the most susceptible and least susceptible, you can fill in the intermediate susceptibility easily. You don't have to memorize that also. Okay. So first is hypoxia. Which fiber is most susceptible to hypoxia? Type B. Okay. And least susceptible is type C. Now coming to pressure again, most susceptible fiber is type A. Least susceptible fiber is again type C. What else is left? Type C fiber. Local anesthetics. Type C fiber is most susceptible to local anesthetic. You can remember, easier way of remembering this local anesthetic type C is, type C carries pain sensation, right? And what is a local anesthetic going to do? It is going, anesthetic means what? It is going to inhibit the sensation. Okay, anesthesia means what? It is going to inhibit that particular sensation. So local anesthetics are given so that you don't feel the pain in that particular area. So remember, C fibers carry slow pain, right? So easier way is local anesthetics means C. What else is left? B and A. Hypoxia is for B. Pressure is for A. Okay. Local anesthetic, the most susceptible fiber is C. Least susceptible is A. Remember these two. The center intermediate, you can always fill it up. Okay. Now, with this, let us approach the next question. Okay. A patient came to OPD with complaint of paresis and numbness after sleeping under his chair. The same type of injury only. What is it? Pressure. Sustained pressure is causing this complaint. So what is common from all these MCQ? What is one thing you learn? People, when they sleep, they put pressure under their limbs, and because of that, the nerve is getting compressed, right? Okay. So now, because of pressure, what is happening? This patient is having paresis and numbness. Which of the following phenomenon explains the phenomenon? Following explanation explains this phenomenon correctly. What does A say? A fibers are more susceptible pressure than C fibers. Okay, your answer is right there. Option A. A fibers, which is the fibers just now you saw here, right? Which is the most susceptible to pressure? A. Least susceptible is C. That is what he is telling. So when you have these MCQs, first what you have to remember is identify what type of agent or injury they are talking about. Are they talking about hypoxia? Are they talking about pressure? Are they talking about local anesthetic agents? I told you very, very easy. Local anesthetic means it is going to inhibit pain. So type C fibers will be the most susceptible, right? Then the rest too you can remember. Now here in case of pressure, most susceptible is A fiber, least susceptible is C fiber. So that is what this first explanation is giving. A fibers are more susceptible to pressure than the C fibers, right? So that is with our classifications of nerve fibers according to conduction velocity, the diameter, and also susceptibility to various agents. Lot of questions from this topic. That is why I have been explaining it in great detail. Okay. Now next question. Identify the true statement regarding the nerve action potential. Again, high yield picture based MCQ. Nowadays in physiology, lot of picture and graph based MCQs are coming. As we have moved on to competency based learning, most of the physiology questions are also in form of a case scenario, trying to ask you to explain the physiological basis of that particular phenomenon. Additionally, other type of questions which now come in recent trend is the picture and graph based MCQ. Okay, so here among the picture based MCQ, definitely one question will come from action potential. Either it is a neuron, skeletal muscle, smooth muscle, or cardiac muscle. So here what you're seeing is an action potential curve of a nerve. Okay, so what is the resting membrane potential of a neuron? Minus 70 millivolt, right? So here you are talking about muscle, nerve. So here for the neuron, it is around minus 70 millivolt. The resting membrane potential of neuron is around minus 70 millivolt. Now, what is the question they are asking? True statement. We have to be always careful. Most of the times, you know the answer. You have read it so many times, you have revised it so many times, you already know the answer. The problem comes only in reading and understanding the question. So what I would always suggest is, depending upon the time available, please, if you find a particular question to be little confusing or little difficult, okay, where you don't have a direct answer, most of the questions don't have a direct answer, what you should do, read the question twice. Try and look at the key points. What are they asking? Most of the times you will see this except, none, except, or, which is identify the true statement, identify the wrong statement. So first you have to know what you want to find out here. What are they asking? So in this question, what are they asking? They are asking us to identify the true statement regarding the nerve action potential. Okay, so here they are given the nerve action potential graph. Okay, in this action potential graph, what is A? A is point of stimulus. What is B? B is depolarization. B to C is depolarization. Then C to D is repolarization. Okay. And what is this E? This is hyperpolarization. Or after depol. Sometimes it will also be given as after depolarization. Okay. Now, what is the ionic? Before going into the options, let us also see the ionic basis so that it will be easier for us. What is this A to B? A to B is what is called as local potential. Okay, so in this local potential, what is actually happening? There is a plus 15 millivolt change. So from minus 70 millivolt, now the action potential has moved on from minus, not action potential, sorry, from minus 70 millivolt, the membrane potential has moved on to minus 55 millivolt. So there is a plus 15 millivolt change. Once this minus 55 millivolt has reached, what is happening? Firing of the action potential happens, that is depolarization is happening. Okay, what is the cause for this local potential? What is the reason for this local potential? Many times they have asked this question. Local potential is due to leaky sodium channels. Okay, and one more thing is opening of slow sodium channels. Okay, opening up of slow sodium channels and leaky sodium channels contribute to this local potential of around plus 15 millivolt. Once this plus 15 millivolt is achieved, that is from minus 70, once it goes to minus 55 millivolt, what is going to happen? Threshold potential is reached. So from B to C is depolarization. Now what is the cause of ionic basis of depolarization? Opening up of voltage gated sodium channels. Okay, fast sodium channel. So because of this, what is going to happen? Influx of sodium, that is depolarization. Then what is happening from C to D? From this C to D, what is happening? Repolarization. Repolarization is what? Due to closure of sodium channels and opening of voltage gated potassium channels and efflux of potassium. Potassium leaves the cell, that is your repolarization. Then what is hyperpolarization? Due to delayed closure of sodium channels. As the sodium channels take more time to close, the action potential graph goes beyond the resting membrane potential and then it comes back under the influence of sodium potassium ATPase, it comes back to the RMP. Another question they will ask is, from repolarization, what is it that is bringing it back to its resting state? So what is bringing it back to the resting state? Sodium potassium ATPase pump. What will the sodium potassium ATPase pump do? Now what has happened? Voltage gated sodium channels have opened. So what is happening? Sodium influx and potassium efflux has happened. Normally in the cell, how is it? Sodium, more potassium is inside the cell and more sodium is outside the cell. So what is the sodium potassium pump going to do? It is going to pump 3 sodium out and 2 potassium inside. Thus it is restoring the resting membrane potential. Okay, so simple. You have seen all these things. Most of the time you will answer all these questions correctly. Only when it comes to resting membrane potential there will be some confusion. So it is the sodium potassium ATPase pump which brings back the by throwing sodium ion out and bringing potassium ion inside, it brings the nerve to back to its resting state. Okay, so that is sodium potassium pump. Now let us look at the options. What they have asked: true statement regarding nerve action potential. Okay, from point B to point D is refractory period. So what this is point B, this is point D. Okay, so what they are telling is this region is refractory period, right? And they have written something also. They have given you a clue. What have they given clue here? Failed initiations. Why there are failed initiations? Because the nerve is under its refractive period only. Because of being under refractive period, there is failed initiation. So what is it? What is the right answer here? This is actually a right statement. Point from B to D is refractive period. Yes, this is true. Let us look at the other options also. Threshold point is A. What is A? Point of stimulus, not threshold. Okay, A is point of stimulus. So this is a wrong statement. At point E, the nerve is more excitable. What is E? Hyperpolarization. Hyperpolarization means what? More negative charges are when it is a hyperpolarization. What is happening? More positive charges are inside the cell. When you have more positive charges inside the cell, is it going to be more excitable or less excitable? It is going to be less excitable. So this is also a wrong statement. Okay. Then point B to D, that is point B to D, is due to opening up of sodium channels and potassium closure. Actually from point B to C is opening up of sodium channels and point C to D is closure of potassium channels. So this is also a wrong statement. So what is the right statement here? What is the correct answer here? Refractory period. So the right answer here for this question is refractory period. Okay. So now we have marked here. So this is refractory period. So what do you mean by refractory period? Let's finish this question and take a short technical break. Okay, so what is refractory period? It is nothing but the length of the time during which the membrane remains unresponsiveness to any strength of stimuli. Okay, so that is why it is written as failed initiation set. Whatever be the strength of the stimuli, what is happening here? There is no response. So that is called as refractory period. Refractory period is also of two types: absolute refractory period, relative refractory period. Absolute refractory period means whatever may be the strength of the stimuli, no matter whatever may be the strength of the stimuli, we will not be able to evoke a response. In relative refractory period, suprathreshold stimuli will be able to produce a response. What is the ionic basis of refractory period? Absolute refractory period is due to the closure of sodium channels closure. So sodium channels closure is happening. So you are not able to bring about no depolarization, no response. What about relative refractory period? Very few sodium channels are open. Okay, that is why suprathreshold stimuli will be able to produce a response. Now, what is the physiological significance of next very important question is they will ask you in refractory period is what is the physiological significance of refractory period? We are discussing physiology. So everywhere it is going to be what is the physiological basis, what is the physiological significance. So coming to refractory period, what is the physiological significance of refractory period? Okay. If you look at your cardiac muscle, it is because of this long refractory period only, cardiac muscle cannot be tetanized. Now coming to the nerve fiber, what do you understand? What is the physiological significance of this refractory period? This refractory period is going to tell us about the rate of impulse generation. Refractory period is going to tell us about the rate of impulse. I hope my handwriting is readable for you. Rate of impulse generation in the nerve fiber. Okay, one thing is we are able to see the rate. It gives us an idea about the rate of impulse generation in the nerve fiber. Next, one-way conduction. One-way conduction is also a property of refractory period. Both of these are again MCQ questions. Okay, so what are the topics MCQ questions here? Usually they'll ask you identify what refractory period. So from the graph here you can identify from the starting of the stimulus until 1/3 of repolarization is complete, we have the absolute refractory period. From 1/3 of repolarization till the end, what you have is the relative refractory period. Okay, physiological basis for this is again, so closure of the sodium channels and opening up of very few sodium channels. So they will ask you the ionic basis, the physiological significance. Okay, so now we will take a short commercial break and we will move on to the next questions coming in nerve muscle physiology. Welcome back. Let us continue our discussion on nerve and muscle physiology. Okay, so now here we have a question. What are they telling here? A person came to the hospital after a road traffic accident. He had severe muscle injury and his serum potassium levels was 5.5 milliequivalents. What would happen to the resting membrane potential? Okay, so before answering this question, let us little bit discuss about the genesis of resting membrane potential. Okay, now how is resting membrane potential happening? How is resting membrane potential formed? Earlier in the starting of our class during the discussion on general physiology and membrane potential, I already told you among all the ions, potassium is the most permeable ion. That is why if you look at this picture also, you can see the arrow. Look at how bold is the arrow. Why this arrow is compared to sodium, it is a very thin line and thin arrow, whereas for potassium it is very bold and the arrow is also big. Why? Because it tells us this is the most permeable ion. Okay, and look at the direction of the arrow. From inside of the cell, it is going to the outside. So when this potassium leaves from inside to outside of the cell, and already we have discussed why it happens to potassium in this way, right? Now, as potassium leaves the cell, what is going to happen? Positive ions are all leaving the cell. When positive ions leaves the cell, what is happening to the inside of the cell? The negativity of the cell increases compared to the outside. Why? Outside becomes positive. Why outside becomes positive? Because potassium ion is leaving the cell. And what is the normal tendency in humans? The maintenance of electrochemical equilibrium. So now what is happening? Positive ions are leaving the cell, the inside of the cell is becoming negative. So to compensate to this sodium ions will try to come inside the cell. The positive ion, because sodium is also a positive ion. And why sodium should come inside the cell? Because the extracellular concentration of sodium is more. So along its concentration gradient, naturally it is the sodium which is going to enter into the cell to compensate for the positive ion loss which happened in form of potassium. But look at the arrow here. The arrow is very thin. That means what? The efficiency with which the sodium ions is transported into the cell is minimal compared to the rate at which the potassium ion is leaving the cell. So ultimately, even though to compensate sodium ion is coming in, the inside of the cell is more negative compared to outside. Okay, and this is the basis of genesis of resting membrane potential. Okay, so this is why resting membrane potential is there. And the resting membrane potential of common tissues, very commonly asked in MCQ. For neuron, it is around minus 70 millivolt. For skeletal muscle, it is around minus 90 millivolt. For thyroid gland, it is around thyroid tissue, it is around minus 50 millivolt. Inner hair cell has around highly negative 150 minus 150 millivolt. RBCs, you see, it is around minus. When you have these extreme numbers, they are very fond of asking these extreme numbers, right? So for RBC, it is around minus 10 millivolt. It is only minus 10 millivolt. A little bit of change will also cause a action potential here. Okay, RBC it is minus 10 millivolt. As I already told you, in pacemaker tissues, okay, in pacemaker tissues, in pacemaker tissues, it is oscillatory, around minus 60 to minus 40 millivolt, and in smooth muscle also it is around minus 40 millivolt. Okay. Now, in this question, what they are telling, the extracellular sodium, whenever there is a muscle injury, what will happen? The sodium, extracellular sodium, when there is a muscle injury, the extracellular fluid sodium will increase. Sorry, not sodium, potassium. The extracellular fluid, potassium ions will increase. So when outside you have more potassium ions, when outside you have more potassium ions, what will happen to the efflux of potassium? The efflux of potassium is going to decrease. Why? Because the concentration gradient is not as much as it would be normally. Outside, already due to the muscle injury, so much of potassium is available outside. So from inside, only less amount of potassium is going to leave the cell. When less amount of potassium is going to leave the cell, it is going to be positive. Okay. So what is the answer here? It is going to be more positive. Okay, option B is the answer. Next question. Following are the components of the sarcomere. Arrange them based on their location from the periphery to the center. So what they are asking is from the periphery to the center. Laterally, they are asking you to move medially. So for this, first let us look at the structure of the sarcomere. Okay, let us look at the structure of the sarcomere. What is a sarcomere? So what you see here is the microscopic structure of sarcomere. Sarcomere is the structural and functional unit of the myofibril. Structural and functional unit of sarcomere is a structural and functional unit of myofibril, right? Now, what you see here is a sarcomere. On the and what is the how does a sarcomere? What is the boundaries of a sarcomere? It is starting from one Z line to the next Z line. A sarcomere extends from one Z line to the next Z line. And what is the length of the sarcomere? It is around 2 micron meter. So the length of the sarcomere is around 2 micron meter and it extends from one Z line to another Z line. Okay, now we are seeing these Z lines. Attached to this Z line, what is this that is attached to this Z line? What is written here? It is written as actin. Okay, so to the Z lines, the thin filament is attached. Okay, thin filament is attached. The thin filament is attached to the Z line. By what is causing this attachment? Alpha actinin. So there is a protein called as alpha actinin which attaches this thin filament to the Z line. When I say this thin filament, it doesn't just contain actin, but it also contains tropomyosin and troponin. Okay, so this thin filament actually contains actin, tropomyosin, troponin in the ratio of 7:1:1. Please remember this ratio. Okay, so till now is one thing is clear. A sarcomere extends from one Z line to the other Z line. Attached to these Z lines on both the sides are thin filaments. How are these thin filaments attached to this Z line? So we have two Z lines. So to this Z line on both the sides, thin filaments are attached. How are these thin filaments attached to this Z line? With the help of a protein called as alpha actinin. All these are potential MCQs. Okay. So what attaches the thin filament to the Z line? Alpha actinin. Okay. Now, when I say thin filament, does it mean only actin? No. Actin is there. Along with actin, you also have tropomyosin and troponin. And what is the ratio? 7:1:1. Okay. Since both of these are 1:1, that is why generally we will say thin filament actin. Okay. Actin, tropomyosin and troponin in the ratio of 7:1:1. Okay, that is with the thin filaments. Then you move further inside. So you know all these green lines. So what are these green lines that is attached to the Z line? All these green lines are thin filaments and they are attached with the help of alpha actinin. Then in the center, what is this blue line that you are seeing? Okay, blue line is nothing but the thick filament, that is the myosin. Can you see here? These blue lines, these thick lines are nothing but the myosin filament. Okay, now in the center of this myosin filament, right in the center of the myosin filament, you have a line called as M line. What do you have? You have a line called as M line. In this M line, again you have another protein called as myomycin. Okay, you just like alpha actinin, in this M line runs right through the center of our myosin. Okay, that is a thick filament. So this M line has a protein called as myomycin, which is attaching this myosin molecules to the M line. So basically, what is the function of this M line? It helps in attachment of these myosin molecules. Right? Now you know how actin is attached, what is helping in attachment of actin, how myosin is attached, and what is the protein that helps in attachment of myosin. Myosin, both it is very easy to remember. Actin, alpha actinin, myosin, myomycin, and the line which causes this attachment is called as M line. Everything starts with M. Okay. So this much is clear. Now we know where is the thin filament, where is the thick filament. Now On both the sides you have the thin filament, and there is a region where you will only find thin filament. There is no overlapping of thin and thick filament. So that region is called as I band. So I band is that region where you have only the thin filaments. On both the sides you have I band where you have only the thin filaments. Then similarly you have a region in the center where you have only the thick filament, only the myosin is there. Okay, now you tell me what is that H band. H band means only myosin is there. In the center of H band one line is going. What is that line? That is called as M line. Then I band means only the light actin, I, light fiber, that is actin is there. Okay, then there is some region where overlapping of both actin and myosin is there. That is called as A band. So in A band, overlapping of both actin and myosin. So when both is overlapping, that region is called as A band. Now is it clear? What is I band? What is A band? What is H band? So what is A band? A band will have only actin. What is I band? I band will have only actin, that is light. Actin is a light filament. Remember, light, Li. So I band. Okay. I band means only actin. H band, only myosin. A band, both actin and myosin are overlapping. Okay. Now, when the skeletal muscle, the below image, look at image B. In this below image, the skeletal muscle here, this is in relaxed state. Here it is in the contracted state. Okay. So now the muscle is contracting. So when the muscle is contracting, see what is happening. What are the changes you see when the muscle is contracting? Z lines are coming closer. Z lines are coming closer. Then second thing, what are you seeing? Z lines are coming closer. What else are we seeing? Do you see I band? I band actually disappears or reduces in length. Okay. What else reduces in length? H band also reduces in length. The H band and I band almost disappears or it reduces in length. What remains the same? Look, what is remaining the same? A band remains same. Very, very important question. Okay. No need to memorize. No need to confuse. Just remember, try to, when you get this question in your exam, try to close your eyes, try to remember this picture of sarcomere. The moment you remember the picture of sarcomere and try to recollect where is light band, where is H band, what is A band, then you will be able to answer this question very, very easily. Okay. So when the muscle is contracting, the Z lines are coming closer, the I band and the H band disappears or the length reduces, and also the A band is the one which remains the same. Okay. Now let us see the labeling. So what are they telling? From the periphery to the center, we have to identify, right? I'll use a different color so that it will be easier for you to. Okay. So from the periphery to the, we have to move from the periphery to the center. That is what they've asked, no? We have to be clear with that. From the periphery to the center. So from laterally, we have to move medially. So in the periphery, which one? Let first look, do they have I band? No, they don't have I band. Next to I band, what do you have? A band is there, right? Before that, what is there? Z line is there, right? So Z line is what? 4, correct? So most peripherally, we have the Z line. Next to Z line, do they have I band? I band is not there. Then do they have A band? Yes, A band is there. Okay. So next to 4, what do you have? A band is 3. Okay. Then next to A band, okay, what do they have? Do they have the H band? No. Yes, they have the H zone. So that is, what is H zone? 1. Okay. Finally, they have the M line. That is the center. That is 2. Okay. So what is the right answer? 4, 3, 1, 2. 4, 3, 1, 2. So option B. 4. That is the right answer. Okay. Okay, next question. Detachment of myosin head from the actin is triggered by what? Detachment of myosin head from actin is triggered by what among these four things? So to understand this concept, let us look at the cross-bridge cycling. Once you see the cross-bridge cycling, this will become very, very clear. This is actually a direct question, but you need to be clear with your concepts. Okay. So before that, let us very, very briefly, quickly discuss about this muscle proteins. Okay. Two types of proteins are there. Three types of proteins actually. Important ones are contractile proteins and regulatory proteins. We have contractile proteins and we have regulatory proteins. What are the contractile proteins? Again, these are MCQ questions. What are the contractile proteins that is present in the skeletal muscle? Actin. Just now we saw here, no? Thick and thin. So it is the actin and myosin, this red and green, sorry, green and blue. Okay. So actin and myosin are the contractile proteins. Regulatory proteins are troponin and tropomyosin. Can you see this here? So first let us look at this myosin molecule. What do you see? The myosin molecule has three portions. It has a head, okay, and it has a neck or the hinge. Then it has a tail. Okay. The center of the sarcomere, where no overlap is happening, is mainly made up of this tail of your myosin molecule. Okay. The neck is very, very important. It is the hinge which bends, attaches to the actin, it attaches to the actin molecule, bends and pulls the actin molecule closer. So that is the function of the hinge. The head is a very important region. It is a globular head. It has two portions. Okay. So one portion of the head is for attachment of actin. The other portion of the head is attachment of ATP. So the head has two portions. One is for attachment of actin, the other is for attachment of ATP. That is with the structure of myosin. Myosin is actually made up of myosin 2. Okay. Briefly about myosin. Next, what you see here, these are actin filaments. Okay. What about actin? Two types of actins are there, F actin and G actin. G actin means globular. F actin is filamentous. Okay. F actin is filamentous actin. G actin is globular actin. Okay. Now, when you arrange these globular, here you are seeing this actin molecule. When globular actin are arranged one after another, okay, it forms a long filament, that is the filamentous actin. Okay. And when you can see the two strands of filamental actin are wound around each other to form this actin molecule. Okay. In this actin, what are you seeing? What is this? These are actin molecules have sites for attachment of myosin head. Actin molecule has sites for attachment of myosin head. Why should it have sites for attachment of myosin head? Because if you want the skeletal muscle to contract, what should happen? So this is my actin molecule, this is my myosin molecule. Suppose this is a myosin. This myosin head has to attach to this actin and pull this actin inside. It is going to pull this actin towards the center of the sarcomere. That is what we want to happen. During one cross-bridge cycling, actually 11 nanometer displacement of actin happens towards the center of the sarcomere. That is how the Z lines are coming closer, right? So now in the actin, you have sites where the myosin head can come and attach. But normally in relaxed state, when the muscle is in relaxed state, when the muscle is relaxed, what is happening is this myosin head, this active sites on actin is covered by tropomyosin and troponin I. It is covered both by tropomyosin and troponin I. If you look at this troponin molecule, it is a complex made up of three types of protein. Troponin is complex made up of three types of protein. Troponin I, troponin T, troponin C. What is the function of troponin T? Troponin T attaches troponin to tropomyosin. So this tropomyosin is there. Here you can see this green line is tropomyosin. This is troponin. So this troponin T only causes attachment of troponin to tropomyosin. And what is the function of this troponin I? Inhibits, I for inhibition. Along with tropomyosin, this troponin I also keeps the active sites on actin closed, covered. Okay, so that myosin head doesn't come and attach. Only when you want contraction to happen, it will uncover it, myosin head will come and attach, right? You know this already. So that is a function of troponin I. Then what is the function of troponin C? Very, very important. Troponin C means it is the molecule protein to which calcium is getting attached. Okay, this is for calcium attachment. So calcium is getting attached to troponin C. So whenever, look at this picture here, calcium that is released from the sarcoplasmic reticulum, whenever it comes and binds with troponin C. So whenever this calcium comes and binds with troponin C, automatically this troponin T, which is attached to this tropomyosin, is going to pull this tropomyosin away. When it is pulling away, when it is getting pulled away, when it's getting pulled away, what is happening? The active sites is getting exposed. The active sites are getting exposed. Once this active site is getting exposed, automatically the myosin head comes and attaches with the actin. Okay. So this is briefly about the mechanism of contraction. What are the series of events that happen? Now our question is specifically on cross-bridge cycling. The question what we have is specifically on cross-bridge cycling. So let us look at cross-bridge cycling. Cross-bridge cycling, only 4 events are happening. A, B, C, D. 4 main events. The first event what you are seeing is when the muscle is relaxed. When the muscle is relaxed. When the muscle is relaxed, we call that state as, please don't confuse, here only lot of confusion comes and you go wrong, energized state. These questions comes as MCQ. Energized state means it is not when the muscle is contracted, when the muscle is relaxed. When the muscle is relaxed, it is said to be in energized state. Now I will tell you why we call it as energized state. Why do we have to tell it as energized state? Now look here, you have the actin, you have the myosin. Okay, that orange color is the myosin. This is the actin. How do I say that it is in relaxed state? Because the myosin has not bound with the actin. The myosin head has not attached with the actin. So I know definitely for sure that this is in the muscle is not contracting. So that I know for sure muscle is not contracting, right? Then what is happening here? When the muscle is not contracting, when it is at rest, the myosin head has two globular, it's a globular head which has two sites for attachment. One is for attachment of myosin head to actin. The other site is for attachment of ATP, right? Right. So now what is happening? This ATP is available in the skeletal muscle, correct? So this ATP will go and bind to the ATP attaching site. And this myosin head has intrinsic ATPase activity. Myosin head, this is a key point. Myosin head has intrinsic ATPase activity. What do you mean by this word intrinsic ATPase activity? That means the myosin head is capable of causing hydrolysis of ATP. So the moment the ATP comes and attaches to the ATP binding site on myosin head, immediately what is going to happen? Hydrolysis of ATP will happen. So as a result of hydrolysis of ATP, here you can see ADP and high energy phosphates are released. And because of this hydrolysis of ATP, some changes are happening. What is the change that is happening? The myosin head is there, no? This myosin, the globular myosin head. Okay, this globular myosin head rotates. It rotates. The globular myosin head rotates and takes a 90-degree angle. Okay, it takes a 90-degree angle and keeps pointing towards the actin. You can see here it is at 90-degree angle pointing towards the actin molecule. So that means what? This is called as cogged in position. What is this called as? Very important points. Cogged in, when do you see cogged in position? During energized state. What do you mean by energized state? When the muscle is at rest. When the muscle is at rest, how can cogged in position happen? Because of the hydrolysis of ATP. So these are the 3 key points you have to remember. If you remember these 3 key points, you will be able to answer that MCQ. You will not go wrong. Okay. So that means it is energized and it is ready to bind with the actin. That is what this state is happening. Okay. Okay, now is it an energized state? Now when calcium is released, what will happen? It will bind to troponin C and it will uncover the active sites in actin. So immediately what will happen? The myosin head will go and bind with actin, and this is called as cross bridge formation. Why do we call as cross bridge formation? Here you have the actin molecule. Okay, why are we calling it as cross bridge? This is actin. Okay, and then you have the myosin head. Okay, now what is basically this myosin head going to do? It is going to cross and bridge this gap. Okay, it is crossing. The head is taking a 90 degree, it is rotating, taking a 90-degree angle, crossing and going and attaching to the myosin head. That is why we call this as cross bridge formation, right? Now, once the cross bridge is formed, what will happen? As a result of cross bridge formation, 2 events are happening. One is power stroke. So you have to remember these key events. That is what they ask. During each of these phase, what are the key events that happen? So during the resting state, what is happening? ATP hydrolysis is happening and cogged in position of the myosin head happens. Similarly, in case of cross bridge cycling, one is power stroke is happening. The second one is ADP and PI are released. Okay, release of ADP from myosin head, or we can say detachment of ADP from myosin head. Okay, so first let us see the first event, that is the power stroke. Then we will see the second event, that is the detachment of ATP, the last event. Okay, so as a result of cross bridge event, 2 things is happening. First is a power stroke. What do you mean by power stroke? Now look at the angle here. It was at 90 degree. Now the angle is 45 degree. That means it is bending at the neck. The myosin head is bending at an angle of 45. Actin is attached here. It is bending at a rate of 45 degrees. So when it is bending, it is going to pull the actin molecule towards the center. Okay. So as it is pulling, the Z lines, can you see the gap here? The gap here is more between the Z lines. Okay. Now the Z line has come closer. That means the muscle is contracting. Okay, the sarcomere is contracting. That is one event, that is called as power stroke. And this state is called as rigid state. What was this called as? Energized state is relaxed state. Now, when the myosin head has bound to the actin, when the myosin head has bound to the actin molecule, it is called as rigid state. Okay, so it is bound to the actin and then it is pulling the actin molecules towards the inside. This is called as rigid state. Now what will happen? Finally, after this power stroke is over, then immediately detachment of myosin head from actin will happen. That is the second event I told you as a result of cross bridge cycling. So detachment of myosin head from actin has to happen. When will this happen? When will the ADP, when will the detachment happen? Only when ATP binds to the myosin head. Okay, only when ATP binds to the ATP binding site in myosin head, detachment of myosin from actin will happen. Otherwise, it will remain in the rigid state. Can you remember any condition where it remains in the rigid state? When can it remain in the rigid state? Whenever the ATP is not available. If ATP is not available, what will happen? ATP will not bind to the ATP binding site in myosin head. Already hydrolysis of the ATP has happened. This ADP is released from the myosin head. So that ATP binding site is empty. So only when ATP molecule comes and binds to that ATP binding site, myosin head will detach. Why do you want the myosin head to detach? Otherwise, the muscle is going to remain in the rigid state. We want the next cross-bit cycling to happen. We want the contraction to continue. So, for that, detachment of the myosin head from actin has to happen, and this is facilitated by binding of ATP to the ATP binding site in the myosin head. Can you think of a state where ATP is not available? Physiologically, under normal conditions, there is enough ATP for this cross-bridge cycling to continue. So, when will this cross-bridge cycle stop? Either when ATP is not available or when that skeletal muscle is attained its physiological limit of contraction. That is the maximum amount of contraction that can happen for that particular muscle. Then the cross-bridge cycling will stop. Now, generally enough ATP is available. When will ATP be not available? After death. Okay, after death we don't have enough ATP. That is why there is rigor mortis. Okay, clear all of you? Now, with this knowledge, let us look at this MCQ. Detachment of myosin head from actin triggered by. Even without looking at the options, you should be able to answer. Detachment of myosin head from actin is triggered by attachment of ATP to the ATP binding site in the myosin head. Where is it there? Binding of ATP to ATP myosin head. Okay, so option B is the answer for this question. Okay, next question. Regarding the skeletal muscle contraction, identify the correct statement. Okay, so they have given you different events in skeletal muscle contraction and asked you to identify the correct statement. Again, let us look at the basics. Okay, for skeletal muscle contraction to happen, what do you want? First, if you try to recall, an action potential is arriving. Okay, and action potential is arriving, and the series of event that takes place, those things we are already clear. I will start from this sarcotubular system. We are only focusing on those difficult areas where you tend to make mistakes, right? So now what is happening? Calcium has come. The action potential has reached the sarcolemma. Via the sarcolemma, the action potential will travel deep into the skeletal muscle. Okay, and that is possible because of the sarcotubular system. That is possible because of the sarcotubular system. Okay, so what is the sarcotubular system? The sarcotubular is a system that is made up of the sarcoplasmic reticulum and the T tubule. So sarcotubular system consists of two components, T tubule and next is sarcoplasmic reticulum. If you see the sarcoplasmic reticulum also, in the center it is thin and in the ends it is bulged. Okay, so in sarcoplasmic reticulum you are seeing two things. What are you seeing? You are seeing a protein called as calcium ATPase. It is also called as SERCA. Sarcoplasmic reticulum calcium ATPase. Okay, this is called as SERCA. Another thing, what do you see here? Okay, what are you seeing here? This green color structure that is present in the sarcoplasmic reticulum, ryanodin receptor. So in the sarcoplasmic reticulum, you have two things. What is it? Ryanodin receptor, then SERCA. Two things we are seeing in sarcoplasmic reticulum. Then you have something called as T tubule. What is this T tubule? It is nothing but invagination of the sarcolemma into the muscle. That is sarcolemma. What is this? Is the sarcolemma. That is the plasma membrane of the skeletal muscle. At specific areas, it invaginates deep into the muscle fiber and then comes out, forming the T tubule. So this invagination is called as the T tubule. In this T tubule, you have another protein attached to the T tubule. What is the name of this protein? Dihydropyridine receptor protein. Okay. So three things you should know: dihydropyridine receptors, ryanodin receptors, SERCA. Okay. For contraction of the skeletal muscle, these two receptors are important: dihydropyridine and ryanodin receptor. For relaxation to happen, you need SERCA. SERCA is for relaxation. Okay. and these two is for contraction. So that point should be clear. For contraction, you need DHP, that is why do we call it as dihydropyridine and why ryanodine? Because it these are the chemical substances that blocks these receptors. That is why we call them at the specific names. So what will happen? An action potential is reaching. That is what I told you. From the presynaptic membrane to the postsynaptic membrane, neurotransmitter is released, and then an action potential is developed in the postsynaptic membrane. We know those series of events. So finally, as a result of that, action potential has reached the skeletal muscle. Now this action potential, because of the presence of T tubule, what is it going to happen? It is going to enter deep into the muscle also. The action potential enters via the T tubule into the deeper portion of the muscle. And we know in T tubule, what is the receptor that is present in T tubule? Dihydropyridine receptor, which is present in the T tubule. Okay. So now this dihydropyridine receptor is actually more than a receptor. It is a voltage gated calcium channel. Basically, it is a voltage gated L type of calcium channel. So it will open. Okay. When this opens, what will happen? The ryanodine receptor, which is attached to the sarcoplasmic reticulum, is going to undergo a conformational change, and it is going to release the calcium that is stored inside the sarcoplasmic reticulum. So inside the sarcoplasmic reticulum, calcium is stored. That calcium will be released into the cytoplasm. Rather than, we can call it as the sarcoplasm, cytoplasm of the skeletal muscle. So when will the sarcoplasmic reticulum release the stored calcium into the cytoplasm? Only when the ryanodine receptor opens. When will the ryanodine receptor open? Only when the dihydropyridine receptor gets activated. Okay, when will the dihydropyridine receptor get activated? Only when the action potential comes. It is a voltage gated calcium channel, so it will respond to the change in the voltage and it will open. Okay, so now what is happening? Calcium has come into the cytoplasm. The calcium which is present in the sarcoplasmic reticulum is released into the cytoplasm of the muscle cell. This calcium will go and bind to the, what will it bind to? It is going to bind to troponin C, and the rest of the cross bridge cycling events will happen. Okay, now the events are over. Now you want the muscle to relax. Then what will happen? You have this protein called as SERCA, the third one, SERCA. Okay, also called as calcium ATPase. What is the SERCA going to do? It is the SERCA is also present in the sarcoplasmic reticulum. It's like I gave you some money for some emergency. You utilize the money. Now it is your turn to repay me back, right? So now same way, what is SERCA going to do? The SERCA is going to, it's a calcium ATPase, which is causing the which takes back the calcium. It is going to actively pump the calcium from the sarcoplasmic reticulum, from the sarcoplasm, that is from the cytoplasm into the sarcoplasmic reticulum. It is taking back all the calcium. Now, once the calcium goes back, it is basically storing the calcium into the sarcoplasmic reticulum so that it is utilized for the next muscle contraction. Okay, so when the SERCA is basically an active pump which takes back the calcium from the cytoplasm and stores it inside the sarcoplasmic reticulum. So when this is happening, what will happen? The muscle contraction will stop. Is it clear for you, the series of events here? Now I want to add another important topic here. There is something called as calcium induced calcium release. So from the discussion so far, it is very clear for skeletal muscle contraction, more than the extracellular calcium, it is the calcium that is present in the sarcoplasm that is important for the skeletal muscle contraction. This much you know, it is clear. And this calcium is basically stored inside the sarcoplasmic reticulum. And these three receptors are playing the role of bringing it outside and taking it back inside. Okay, each of this has one role. Now, in case of your smooth muscle, and in case of your cardiac, this is for skeletal muscle, but in case of your smooth muscle and in case of your cardiac muscle, you have something called as calcium induced calcium release, CICR. What is it? When the action potential is arriving, I already told you this dihydropyridine receptor is basically a voltage gated calcium channel. So this calcium channel will open. When it opens, some extracellular calcium ion will also diffuse. Some extracellular calcium ion will also diffuse into the sarcoplasm of the smooth muscle and cardiac muscle cell. Okay, that is going to further cause release of calcium from the sarcoplasmic reticulum. That is why this phenomenon is called as calcium induced calcium release. So for smooth muscle and heart skeletal, for the smooth muscle and cardiac muscle, extracellular calcium has some role, but for skeletal muscle you don't have any role. Okay, so what are the functions of sarcotubular system? One thing is it is transferring the action potential from the surface to the interior of the cell membrane. Then it is the sarcotubular system only releases calcium into the cytoplasm, and also it ensures muscle relaxation by reuptake of the calcium into the sarcoplasmic reticulum. The series of events, just now we have already seen the same series of events. Okay, what I want you to see now, let us look at the options. Okay. Regarding the skeletal muscle contraction, identify the correct statement. Again, what they are asking is, they've given 4 statements. In these 4 statements, either 3 or 2 of these statements are correct. Okay, so what are those correct statements? Calcium is released primarily from mitochondria. Is this true? No. Where it is released from? From the sarcoplasmic reticulum, not the mitochondria. Next is extracellular calcium is not vital for muscle contraction. Yes, it is true. To an extent, for skeletal muscle, definitely extracellular calcium is not so vital. It is a calcium present in the cytoplasm. In the excitation contraction coupling, the sarcolemmal voltage gated calcium channels have no role. Very wrong. You know, these calcium channels are the ones which are opening, right? And because of that only, the rest of the events are going to happen. So that is a wrong statement. Then what else is left? This is definitely going to be the right statement. Calcium is released from the sarcoplasmic reticulum. Yes, this is correct. So option 2 and statement 4. Both these statements are correct. So which is the correct option here? Option B is the right answer. Okay. We will take a short break, technical break, and then we will start discussing our gastrointestinal system. Welcome back. Now let us start continuing our discussion. We are starting with gastrointestinal system. Why? Okay. Now, what is the first question here? Iron uptake by the enterocyte is mediated by. So we are talking about iron uptake here. They have given us 4 options. As usual, first let us discuss the basic concept and then come back. So what you are seeing here is an enterocyte. Normally, the plasma iron concentration in adult male is around 130 milliequivalents per liter, and in adult female is around 110. Okay, uh, that is the normal concentration. Now this iron can be from heme and non-heme. So we have heme iron and also we have the non-heme iron. Now what happens is when we are taking food rich in iron, okay, so what is happening? This food rich in iron goes into the stomach. So the stomach acid, okay, the stomach acid, what is it going to do? It is going to dissolve this iron. Okay, stomach acid is dissolving this iron. Okay, and then the dissolved iron will attach with ascorbic acid. So once it is attached with ascorbic acid, the reabsorption of iron is facilitated. Okay. Okay, that is why when you take iron tablets, when you take it with a vitamin juice, when you're taking it with lemon juice or orange juice, what is it going to do? It is going to increase the absorption of iron, right? Why? Because the stomach acid is going, 2 things. Actually, the stomach acid will do 2 things. One, it is making this dissolving the iron, it will cause the dissolution of the iron, and then once the iron is dissolved, it can be easily attached to ascorbic acid, and that is going to facilitate the absorption of iron. Second thing, the iron which we ingest from the food, what we get, the iron which we ingest is in the ferric form. Now this has to be converted to ferrous form. Okay, to the Fe2 plus ferrous form. Only when it is converted to the ferrous form and it becomes solubilized, it will be able to form complexes with ascorbic acid. So first work what the stomach acid is doing is converting the ferrous form of iron into the ferric form, and then making it into a soluble form where ascorbic acid can attach to it, and then that is going to facilitate the absorption of iron. Okay, now this iron from the stomach, it is coming into the enterocytes, small intestinal cells. Okay, so which portion of the small intestinal cells this absorption is going to happen? Mainly upper small intestine. All these are MCQs. Which portion? Upper small intestine. So in upper small so in the upper small intestine, specifically in the duodenum and the jejunum. Okay, in the duodenum and jejunum, in the upper small intestine, maximum absorption of iron will happen. Okay, how does this happen? Okay, this is the enterocyte, small intestinal cell. In the enterocyte, on the luminal side, okay, on the intestinal side, we have a protein called as ferric reductase. What is it called as? Ferric reductase. Okay, we have a protein called as, so this is the first step. We have a protein called as ferric. What are we seeing here? Mechanism of absorption of iron, right? So now ferric reductase is there in the luminal side. What is this ferric reductase going to do? Already the stomach acid is also converting the ferric form into ferrous form. Later, even in this enterocyte, we have the ferric reductase, which converts the ferric form into the ferrous form. Okay, so it is getting converted because of this ferric reductase enzyme. Then what is happening? The second step, you have something called as divalent metal transporter. Okay, so Fe2 plus, right? So we have a transporter called as divalent metal transporter, which is transporting this ferrous form of iron into the cytoplasm of the enterocytes. Okay, it is entering into the enterocytes. Okay, once it has entered into the enterocyte, what is happening to this ferrous form iron? It is removed from porphyrin. Okay, porphyrin is removed from it. Okay, porphyrin is dissociated from this ferrous iron. Okay. After that, once porphyrin is removed from this ferrous ion, it moves freely. Okay, it is freely transported by this protein called as ferroprotein into the blood capillaries. So you remove porphyrin is removed from this ferrous, then ferroprotein is transporting it into the blood capillary. Once it enters the blood circulation, it is again reconverted to the ferric form and it is forming. What does it form? What is the transport form of iron? Transferrin. Okay, it forms transferrin. That is how the transport form of iron is formed in the blood. Okay, that is some amount of iron is still present in the, and this removal of porphyrin from this ferrous form is done by an enzyme called as heme oxygenase. Okay, this heme oxygenase does the function of removing of porphyrin from this ferrous. Then what is happening? Some iron is going and forming transferrin. Some iron is still present in the cytoplasm. It again gets converted to the ferric form and forms the storage form of iron called as ferritin. Okay, so this is in brief the mechanism of iron absorption. Now let us see the questions. Iron uptake by the enterocyte is mediated by what? Ferroprotein, transferrin, ferritin. Transferrin is the transport form of iron. Just now we saw. Okay, ferritin is the storage form of iron. Okay, ferroprotein is the transporter. This is the transporter of iron from enterocyte to the blood capillaries. Okay, DMT is the right answer here, divalent metal transporter, because they are asking ion uptake by enterocyte. So from the lumen into the enterocyte, this is what is going to transport, divalent metal transporter. So answer here is divalent metal transporter. So please read the question carefully. Suppose if they ask which is the transporter that transports iron from the enterocyte into the blood, then it is not DMT, then it is ferroprotein. Okay, here they are asking into the enterocyte. So that means it is divalent metal transporter. Okay, next question. Glucose is absorbed from the intestinal lumen by, again, first we saw absorption of iron. Now we are seeing absorption of glucose. How glucose is absorbed from the intestine? It is the most common topic which has been discussed again and again. General physiology it will come, in GI it will come, again in renal physiology also we will be talking about this. What is the name of that co-transporter? SGLT, sodium glucose co-transporter. So again what you are seeing here is an enterocyte, right? I hope it is visible to you. Okay, so what you are seeing here is an enterocyte. Okay, so in this enterocyte, what is this side? The lumen of the intestine. On the luminal side, you have a secondary active transport protein. Secondary active transport protein called as sodium glucose co-transporter. So what it is going to do? It is going to transport sodium and glucose into the cell. So this is a symport. Okay, so that answers our question here. Glucose is absorbed from the intestinal lumen by SGLT. SGLT is an example of secondary active transport. So option A is the answer. But let's further continue our discussion. Okay, we don't stop here. You have still more MCQs in this topic. So SGLT is the one which is transporting the glucose into the cell. SGLT, whenever I said there is a transport protein, it will also have competitive inhibition, right? Now, galactose is also transported by the same SGLT into the cell. So along with glucose, even galactose will also come into the enterocyte. Then another carbohydrate molecule is fructose. Fructose. How is fructose entering into the cell? With the help of GLUT5. So GLUT5 transports fructose into the cell. Okay, now glucose, galactose, fructose, all these sugars have, glucose, galactose, fructose, all these sugars have entered into the enterocyte. Do you want these sugars to stay inside the enterocyte? No. Where do you want them to go? We want all the sugars that has been absorbed from the intestinal lumen into the bloodstream. So we want them to go into the bloodstream. Okay. So how is that going to happen? By facilitated diffusion. Okay. Facilitated diffusion of all these, the transport protein which does the diffusion, which acts as a carrier protein and shifts these sugars from the enterocyte into the bloodstream is GLUT2. For glucose, for galactose, for fructose, for all these three sugars, GLUT2 is the transport protein or carrier protein which by means of facilitated diffusion pushes all these three from the enterocyte into the bloodstream. Okay, so glucose and galactose enter into the enterocytes via SGLT1. Fructose enters through GLUT5. Once into the enterocyte, all these three are entering into the bloodstream via GLUT2. Okay, so that is with the absorption of glucose. Suppose the same question, if they have asked, glucose from the enterocyte is transported into the bloodstream by, what will you choose the answer? Facilitated diffusion, right? Now, the next question. Decrease in gastric secretion due to the presence of acidic chyme in intestine is mediated by what? Gastric secretion is decreased because of the presence of acidic chyme in intestine. So you have your stomach. Okay. So the stomach contents are acidic. So that is what we call it as acidic chyme. Now this, when this chyme enters the duodenum, it has two effects. Once the acidic chyme enters the duodenum, immediately duodenum has these enzymes like CCK, secretin. All these enzymes is going to inhibit GI motility. Okay. So acidic chyme is going to cause secretion of cholecystokinin, secretin, and that is going to inhibit GI motility. Next, distension. Once the stomach contents enters into the duodenum is going to stretch. Again, the stretch sensitive receptors, mechanoreceptors are again going to send the signals and inhibit the GI motility. Okay, and this reflex is called as entero. Duodenum is entero. We call it as, that's why we call it as enteric nervous system. Enterogastric reflex. That is from the duodenum, it goes to the stomach. So we call it as enterogastric reflex. So what is the answer here? It is option B, enterogastric reflex. Why should this mechanism happen? What is the physiological significance of this enterogastric reflex? Suppose if enterogastric reflex is not there, if GI motility is not inhibited, then what will happen? A lot of chyme, lot of stomach contents will be emptied into the duodenum at the same time. At one shot, when lot of stomach contents are emptied into the duodenum will not be able to efficiently digest and reabsorb the nutrients. That is why a controlled amount of secretions, a controlled amount of chyme has to come from the stomach into the duodenum. Okay, so that is the importance of this enterogastric reflex. Okay. Now let us also look at other reflexes, because this is one reflex the question here. We will also have other reflexes, right? So what is gastrocolic reflex? This gastrocolic reflex is what? Gastrocolic reflex. So when the stomach is distended, the gastrocolic reflex is initiated when the food accumulates into the stomach. So the distension of stomach is going to increase the motility of the colon. That is why we call it as gastrocolic reflex. Distension of the stomach increases the motility of the colon. Have you observed this? This is very, very, very prominent in children. After eating food, immediately they will go to the washroom, right? So this is called as gastrocolic reflex, which is highly developed in children. So because of this, what will happen? Motility of the colon pushes the contents into the rectum, which causes the desire to defecate. Okay, and this gastrocolic reflexes is mediated by gastrin, which is secreted from the stomach. So these are the key points what I want you to remember. Gastrocolic reflex mediated via gastrin. Gastroileal reflex. What will happen when the food enters the stomach? The motility of the terminal part of the ileum is enhanced. So this is called as gastroileal reflex. Okay, this reflex is mediated via vagus nerve. Gastrocolic is via gastrin. For gastroileal reflex, it is vagus nerve. Okay. Then intestinal reflex. What do you mean by intestinal reflex? When one part of the intestine is over distended, the rest of the intestine will relax. This is called as intestinal reflex. Okay, it is mediated via the vagovagal pathways. Then colonocolonic reflex. What is this colonocolonic reflex? Same like intestinal reflex. Relaxation of the entire colon in response to distension of one particular part of the colon. One particular part of the colon is getting distended, because of that the entire colon relaxes. Okay, this colonocolonic reflex is mediated by sympathetic fibers. Then finally in the options they have written as enterohepatic reflex, right? Enterohepatic reflex. What is this enterohepatic reflex? It is nothing but the enterohepatic circulation of bile salts. This enterohepatic circulation of bile salts is what is called as enterohepatic reflex. So that completes our discussion on gastrointestinal physiology. Now we will take a break for lunch and then we will assemble back again at 2 p.m. session on Medico's final dash. What are we doing? We are doing the revision of physiology. From morning, we have seen some topics like general physiology, nerve muscle physiology, gastrointestinal physiology. Now we will move on to respiratory physiology. As I said before, I want the session to be more interactive. If you have any doubts or if you want any particular topic to be discussed, please put it in the comment box. I'll be more than happy to help you out. So now let us start with respiratory system. So we have a question here. At which of the following lung volumes the relaxation pressure will be 0? So they've given you here 4 lung volumes. Okay, so at which of the lung volumes the relaxation pressure will be 0? So to understand this question, to answer this question, first you should know what do we mean by relaxation pressure? What is relaxation pressure? This is nothing but the pressure that is in the lungs when this is the pressure that exists in the lungs when there is neither inflow or outflow of air. Okay, so is that clear? Relaxation pressure refers to the pressure that exists in the lungs when the lung and chest wall has no airflow and the respiratory muscles are relaxed. When I say, when does this happen? When does no airflow occurs in the lungs? At which phase of respiration does no airflow occurs in the lung? At the end of expiration, we don't have any airflow. Okay. So at end of expiration, we have no airflow. Surprisingly, post lunch, my pen started writing well. In the starting of the session, the pen was giving me a lot of trouble. So now luckily the post lunch session is an important one. We are discussing important topics like respiratory system, the renal system, and our nervous system. And luckily the pen has also started writing well. Okay. So now the relaxation pressure, that means the relaxation pressure is the pressure at during which, so one point you have to remember, first point you have to remember here is, what do we mean by relaxation pressure? It is the pressure at which there is no airflow into the lungs. And when does this happen? At the end of expiration. Okay, so here they have asked you to select only one among these 4 options, but actually there are 2 pressures, or sorry, there are 2 lung volumes at which the relaxation pressure will be 0. Okay, so there are ideally 2 lung volumes at which the relaxation pressure will be 0. One is the functional residual capacity, the other one is the tidal volume. In both these scenarios, the relaxation pressure is 0. Okay, now what happens in functional residual capacity? Now what is the definition? Functional residual capacity, residual volume, lot of question comes from these topics, so you're supposed to know everything in this. So what is the definition, or what do we mean by functional residual capacity? It is a volume of lungs, volume of air that remains in the lung at the end of normal expiration. So functional residual capacity is the volume of air that remains in the lung at the end of normal expiration. Okay. So now what is basically happening at functional residual capacity that makes it have a relaxation pressure of 0? During functional, for that I want you to look at this picture. So what is a normal tendency of the lung and the chest wall? The normal tendency of the lung is elastic recoiling, inward elastic recoiling. So what will happen? The normal tendency of the lungs is to collapse. Inward recoil. So the normal tendency of the lung is to collapse. Now, what about this chest wall? The normal tendency of the chest wall is to expand outward. The normal tendency of the chest wall is to expand outward. So the normal tendency of the lungs is to collapse inward. The normal tendency of the chest wall is to collapse, is to expand outside. So these are both, the chest wall and the lung are 2 forces acting in opposite direction. These are 2 forces acting in opposite directions. Okay, they are equal and equal forces, but are acting in opposite direction. Okay. And because of this only, actually the intrapleural pressure is negative. Because of this nature, the inward recoiling of the lung and outward bulge of the chest wall, the intrapleural pressure, the pressure that is present in the pleural space, is negative. The intrapleural pressure is always negative because of this property. Okay, so now coming back to our discussion on functional residual capacity and why during functional residual capacity the relaxation pressure is 0. So at functional residual capacity, these 2 forces are balanced. Okay, the inward recoiling of the lung is exactly balanced by the outward movement of the chest wall, outward recoiling, expansion of the chest wall. So when both these opposing forces are balanced, that point is called as functional residual capacity. When both are balanced, the relaxation pressure is zero. This balance results in a zero pressure difference across the lungs and chest wall. Hence, the relaxation pressure is zero. So now you understood why the relaxation pressure is zero at functional residual capacity. Then I said there is one more volume where the relaxation pressure is zero, where residual volume. So what is residual volume? This is the volume of air that remains in the lung after a forceful expiration. So functional residual capacity is the volume of air that remains in the lung after a normal expiration, whereas residual volume is the volume of air that remains in the lung after a forceful expiration. So once after a maximal, rather than saying forceful, it is after a maximal expiration. So after a maximal expiration, what will happen to the lung volume? The maximum volume of air is expelled out. So naturally the lung volume is going to be minimal. So in residual volume, the lung volume is going to be minimal. So the lungs are also going to be at their smallest size. Now what will happen to the chest wall? The chest wall will also similarly have a relaxed position with minimum volume and minimal outward recoil. So again what is happening? As the lung volume is decreasing, as the lung size is decreasing, even the outward recoiling of the chest wall is also equally decreasing. So now again here also both the forces are balanced. That is why even under residual volume, the relaxation pressure is zero. But if they are asking you, they've given a scenario like this here, where both residual volume and functional residual capacities are there in the option, then you have to select functional residual capacity. Suppose if they've given other options, both A and D, both B and C, both A and B like that, then you will select both residual volume as well as functional residual capacity. So that is with relaxation pressure. Okay. Now next question, with aging, what is happening to the lungs? What is true for the lungs? So they've given us 4 statements. We have to, with respect to aging, we have to find out the true statement in lung. As a person ages, the pulmonary compliance will increase. Second is the residual volume will decrease. The mucociliary clearance will increase. Fibrosis of interstitium will decrease. So here this is a direct answer. What is it? The pulmonary compliance will increase. When you look at the other 3 options, the residual volume will also increase. Mucociliary clearance, the immunity will decrease. Even the lungs will undergo fibrosis. The fibrosis will actually increase. The lung will become more fibrous. Then how come compliance is increasing? Is it good or is it a bad thing? Definitely it is a bad thing. Why? Because here, why is the lung compliance increasing in old age? First, let us see what is compliance. What do you mean by compliance in simple terms? Compliance is the ability, distension of the lungs, or the ability of the lungs to stretch. Okay, so the ability of the lungs to stretch or the ability of the lungs to recoil. So compliance is basically the measure of the distensibility of the lung. Again, very important MCQ. The measure of distensibility of the lung is following. So they will give many options. So what is the right answer there? Compliance. Compliance is the ability of the lungs to expand. That is the distensibility of the lungs. Okay. When will compliance increase? Physiological conditions, pathological conditions. Okay. When will compliance increase? Whenever there is loss of elastic properties of the lung, then the compliance is going to be increased. That means the lung loses its elasticity. If it loses its elasticity, it is going to be easy to expand the lungs. Okay, so that is why in old age the compliance increases. Why? Because of the loss of elasticity of the lung tissue, the compliance increases. Okay, so that is why physiologically in old age, due to the loss of elastic properties of the lung tissue, compliance increases. Pathologically in emphysema, you will see those ballooning spaces in emphysema typically. Okay, so what will happen is there will be, this is not beneficial. Why? Because excessive compliance or less compliance, both is not beneficial. Now what happens here in emphysema and old age and all, because of the loss of elastic property, the lungs is able to expand. Okay, it is getting distended with more air, but the air is not going to escape outside. Okay, so there will be difficulty of the air to escape outside because the elastic recoiling of the lung is lost in these conditions. Okay, that is why it is detrimental. Now, coming to what are all the factors that increases compliance. Now, let us look at the factors that is decreasing our compliance. What are all the factors that decreases compliance? One is anything that is going to restrict the expansion of the lungs. That is things or conditions that is going to make the lung stiff will decrease the compliance. If the lung is stiff, then it is not able to distend. Then all those conditions will decrease the lung compliance. Or in the chest wall, problems with the chest wall, where the chest wall movement is restricted, the chest wall is not able to expand, then also the compliance will decrease. Okay, so let us, when you remember this basic concept, remembering those conditions are going to be very, very easy. So when does compliance decrease? Deformities of the thorax like kyphosis, scoliosis, even poliomyelitis, fibrotic pluricity of the lungs, paralysis of the respiratory muscles, pleural effusion, abnormal thoracic conditions like pneumothorax, hydrothorax, hemothorax, and pyothorax. In all these conditions, what is going to happen? The compliance is going to decrease. Since we have discussed or continuing our discussion on compliance, I want to cover other more important areas on compliance. Okay, so let us look at the clinical significance of lung compliance. Here, whatever clinical conditions you saw here theoretically, the same can come as a graph. As I already told, lot of questions on pictorial representation, graphs are coming, right? So if they give this graph in your exam and ask you to identify, suppose they will say this is curve A, curve B, and curve C. Identify A, B, and C. Okay, or identify any one, what they can ask in any manner. So what is it? So what are we seeing? In the x-axis we are seeing the transpulmonary pressure, and in the y-axis we are seeing the lung volume. See, the intrapleural pressure is always negative. The transpleural pressure is positive. More the transpleural pressure, greater will be the distensibility of the lung. So now what happens, as the transpleural pressure increases, the lung volume keeps increasing. Now look at the normal curve B. So as the pressure is increasing, the lung volumes also increases. And what is the normal total lung volume? Around 6 liters. So this is a normal graph, around 6 liters we have. Just now we saw conditions like emphysema where the compliance is increased due to loss of elasticity of lungs. Okay, due to loss of elasticity of lungs in emphysema, the compliance is increasing. So you see, as the transpulmonary pressure increases, look at the compliance. How much? It is more than 8 liters. Okay, so the total lung capacity is more than 8 liters. Normal is only 6 liters. Okay, so this graph is for emphysema. Or we can even say obstructive lung diseases. Rather than just telling you one clinical condition, they can also say it as the above graph. This is C, right? C is representative of obstructive lung disease. Like that also they can say. Similarly, look at the lowermost graph, A. In pulmonary fibrosis, because of the fibrotic tissue, the lungs are stiff. Here, because of fibrotic tissue, the lungs are stiff. So something is restricting the expansion of the lung. So this is again example of pattern seen in restrictive lung disease. Okay, so see how much is the lung volume? Hardly 3 liters. Okay, so if it comes in the form of the graph also, now you will be able to answer. Then we will discuss another very important topic, regional variations in lung volume compliance. Okay, regional variations in compliance. This is mainly, these variations are mainly due to effect of gravity. This is mainly due to the effect of gravity. Because of the effect of gravity, we can divide the lung into 3 zones. Okay, apex or zone 1, middle zone, that is zone 2, and base, that is zone 3. The apex, middle zone, and the base, right? So now, by looking at the size of the alveoli, you tell me which of these alveoli will be having better compliance. That is, which among these 3 alveoli will be able to distend better. I'm looking at the comment box. Okay. So which of these three is going to distend better? The lung alveoli at the apex, look at the size of the lung alveoli at the apex. It is already distended. Already the size is more. Why? Due to the effect of gravity. So it is already distended. Further distension of this alveoli is going to be difficult. Okay, you've already had your food. Now from again, if they ask you to eat something, will you have the ability to eat? Will your stomach expand more? It is going to be very, very difficult. You are going to restrict it because we have already had the food. The same thing. Already this lung alveoli is is distended. So it is going to be very difficult to distend this further. So the compliance, due to the effect of compliance, due to the effect of gravity, the compliance is less. Compliance is less at the apex. So please remember this, very, very important. The compliance of the lung is less at the apex. Why? Because the alveoli are already distended. Since the alveoli are already distended, the blood vessels are all constricted here. The capillaries are all constricted due to this expanded blood vessels, expanded alveoli. It compresses the blood vessels. So at the apex of the lung, the perfusion will be low. The perfusion will be low. Now the middle zone is the ideal zone. Okay. Here the compliance is normal. Okay. Now coming to the base of the lung. In the base of the lung, look at the size of the alveoli. It is very small. Okay, since the size of the alveoli is very small, it is better perfused. So the blood flow will be better in the base of the lung. At the same time, this alveoli is small. So it has a lot of scope to distend and accommodate more air. So the compliance is also better. Better at base. Remember like this. The compliance is better at the base and compliance is less at the apex. And the compliance is normal at the middle zone. Okay. So this is clear. This concept is clear. And another important applied aspect here is they will ask you which among these three zones. This is called as regional variation in the compliance of a normal lung. So among these three zones, which is the zone where Mycobacterium tuberculosis can flourish? Okay, where Mycobacterium tubercular bacilli can flourish more. Tell me where. Yes, it is at the apex. TB. Okay, TB bacilli can grow here. Why? Because it has already the size of the alveoli are large. If the size of the alveoli is large, it is going to hold more air, so more oxygen, more growth of these bacteria. Okay, clear? So that is certain important basic concepts in compliance. I think now you will be able to answer any compliance that comes with respect, any questions that comes with respect to compliance. Okay, now some normal values. The compliance of the lung or the chest wall alone, the compliance of the lung and chest wall alone is around 200 ml per centimeters of water. But when you take the combined compliance of lung and chest wall, it is less. It is only 130 ml per centimeter of water. Why should this variation be? Why is it individually it is more, whereas when you add up, why? Because when you are adding up, we are adding the reciprocals of individual things like lung, reciprocal of the lung and reciprocal of the chest wall. When it is added together, the value is obviously less compared to their individual lung compliance values. Okay, then there is one more concept called as specific compliance. What do you mean by specific compliance? It is nothing but compliance per unit volume of the lung tissue. So the compliance per unit volume of the lung tissue is called as specific compliance. Okay, now there is a formula. They can also ask you to do calculations. So they can give you the values and ask you to calculate the specific lung compliance. So what is the formula to calculate specific lung compliance? So the formula is given by compliance of the lungs divided by the functional residual capacity. So when they give you the compliance of the lung and the value of functional residual capacity, you will be able to calculate the specific compliance. Okay. So now here are a list of all those changes, anatomical and physiological changes that happens during old age. This PDF will be there for you in the description box. You can download the PDF and have a look at all these changes. But important ones, what you have to remember is compliance increases in old age. Okay. Then another thing is, while coming to lung functions, the FEV1 is decreased, FVC is decreased, and total lung capacity remains unchanged. Even the vital capacity is decreased, and it is the functional residual capacity and residual volume which is usually increased. So this part you have to notice. The thing that remains unchanged is the total lung capacity. The rest of the things will decrease. The rest of the lung volumes and capacity will decrease except for functional residual capacity and tidal volume, which actually increases with old age because of the loss of elastic properties of the lung. Okay. Then comes the next question. Functional residual capacity is, we already saw what is it? At the end of normal expiration. That is a volume of air that is present in the lung at the end of normal expiration. So option B, after normal expiration. Or sometimes the options can even come, instead of giving us normal expiration, they will give it as passive expiration. Okay. Then in a pulmonary function test, values of FEV1, okay, is 1.3 liters and FVC is 3.9. They are asking you to signify this. So to signify this, what you should calculate? The ratio. You have to calculate the ratio, that is FVV1 by FVC ratio. Okay, so this ratio is used to differentiate. The ratio is used to differentiate between obstructive and restrictive lung disease. So when you calculate this ratio, 1.3 divided by 3.9, it is coming to approximately 0.33. Okay, so FEV1 by FVC ratio is 0.33. And what is the normal value? The normal value is around 0.8. Okay, normal value is 0.8. Here the ratio is decreased. When does the ratio decrease? The ratio decreases in obstructive lung disease. In obstructive lung disease, this ratio is decreased. So what is this option? What is the answer here? Option B, obstructive lung disease. What about restrictive lung disease? It will be normal or increased. Okay. So here is the ratio. So already I told you normal is around 0.8. And what is the significance? A low ratio, less than 70%. So anything less than 0.7 is going to tell you that it is obstructive lung disease, while a normal or a high ratio with reduced functional FVC, reduced forced vital capacity, okay, is going to tell us that it is a restrictive lung disease. Here important catch is the FVV1 by FVC ratio could be normal, but the FVC, the forced vital capacity, will be reduced in restrictive lung disease. That is the important word you have to remember. Let us look at this graph. Okay, it is the it is a pattern of FEV1 and curve. Okay. So what is this graph? It is a pattern of FEV1 curve in both obstructive and restrictive lung disease. So first, in the x-axis, what do you see? You see time. In the y-axis, you are seeing the forced vital capacity. Normally, what is this FEV1? It is the percentage of that forced vital capacity or percentage of the volume of air that can be forcefully expelled out within the first second. FEV1 is within the first second. The volume of air that is forcefully expelled out within the first second is called as FEV1. Okay. Now let's look at the normal graph. What you see here, blue color, is the normal graph. So in the normal graph, you see this is a FVC. So we are going to see the volume of air that is expelled out as percentage of FVC, forced vital capacity. So now the person is expelling. So here you can see normal tidal respiration is going on. Then the person is forcefully expelling out as forcefully and as fast as possible. So what is happening? The normal graph, it is coming down. He is expelling out. So the lung volume is decreasing, right? Now you see, this is FVV1. This green portion is FVV1. So by the end of the first second, okay, so this is the end of first second, okay, then it is keep going. By end of first second, what is the percentage of FVC that he has expelled? Almost more than 85%. Okay, so in normal graph, within the first second, more than 85 to 90% of the FVC will be completed. Okay, next, look at the graph with obstructive lung disease. Okay, so this is obstructive lung disease. Obstructive lung disease is this green color graph, green color line. Look at the green line. Okay, so in green line, what is happening? Again, the person is taking normal tidal respiration, then he is taking a forceful inspiration followed by a forceful expiration. As fast and as forcefully he has to expel out. So the subject is expelling out and we are recording it. Okay, now this is the first second, right? At the end of the first second, what is the percentage of the air or percentage of FVC that has been expelled out? This is 25, so this should be 35. So in restrictive lung disease, only by the end of the first second, the person is able to expel out only 35% of the lung volume or the forced vital capacity. 35% of the volume of air that is present inside the lung. But normal should be more than 80 to 85, definitely more than 75. It has to be more than 75. Okay, so that is the pattern what you see in a obstructive lung disease. Now look at your right side. You have it for your restrictive lung disease. Okay, we have it for a restrictive lung disease. Okay, this red color is for restrictive lung disease. Okay, this red color line. So what is happening here? First significant thing what you see, the FVC itself is reduced. Look at the FVC here, forced vital capacity here on the normal and for obstructive lung disease. Air in obstructive lung disease, air can easily enter into the lung. So the FVC will be normal. Okay, it is only obstruction to the outflow of the air in obstructive lung disease. But in restrictive lung disease, because of the restriction either inside the lung, stiff lungs, or restriction in the outside, in the thoracic rib cage, air is not able to enter into the lung and properly expand the lung. So to start with itself, the forced vital capacity itself is less. The ability of the lungs to move air itself is less. Ability to move air into the lungs is itself less. So the FVC graph itself is small. In this smaller FVC, whatever amount of air is going in, more than 75% is coming out. That is why the FVV1 is normal. Now do you understand the meaning of this line? Normal or high ratio with reduced FVC. Okay, so that is in case of restrictive lung diseases. Is this clear? Okay, so again we will just very fastly revise between our obstructive and restrictive lung diseases. In obstructive lung diseases, as I already told you, there is problem in the air to get out. Air trapping is the problem. There is obstruction to the airflow. When will there be obstruction to airflow? Most common, bronchial asthma, bronchitis, emphysema, COPD. In all these scenarios, air will be trapped inside, it cannot come out. Okay, so characteristically, the FVV1 by FVC ratio is going to be less than 0.8. FVV1 will be low, FVC can also be low. But most striking is FVV1 will be very low. Okay. How do you manage? This is also another question. How can we manage a person with obstructive? Other than our regular drug management, what else can a person with obstructive lung disease do? He should take slow, deep breath to combat airflow resistant. Okay, so this is again an important MCQ. Okay, now coming to restrictive lung disease. So there is restriction to airflow. Air cannot come into the lungs and expand the lungs or rib cage. So kyphosis, skeletal muscle deformities like kyphosis, obesity, neuromuscular diseases like myasthenia gravis, cystic fibrosis. In all these conditions, there is pulmonary fibrosis. Okay, even pulmonary fibrosis. In all these conditions, there is restriction to airflow. Okay, so reduced volume. Problem is getting the air into the lungs. So here it is characterized by a normal FVV1, normal or increased FVV1 by FVC ratio, but FVC will always be low. How are we going to manage this patient? By having fast, shallow breaths to combat the elastic resistance. Okay, clear? Every single line, as I keep repeating, is a potential MCQ in this one slide. Okay, so please go through it. Okay, next, in forceful expiration. So they are not talking about normal. In forceful expiration, which of these neurons get fired? So what are we discussing about? Neural regulation of respiration. Okay, so first let us look at the basics, then we will come back and answer that question. So you're looking at regulation of respiration. Regulation of respiration, you know, two types, like classified into two. Neural regulation of respiration and chemical regulation of respiration. Sorry. Okay, I think it is visible. Okay, so we have neural regulation of respiration and chemical regulation of respiration. Neural regulation of respiration is going to regulate the pattern of breathing. Okay, so what is neural regulation of respiration going to do? Regulate the pattern of breathing. What about chemical regulation of respiration? It is going to regulate the minute ventilation. Okay, now neural regulation again is voluntary and automatic. Voluntary is from the cerebral cortex. Voluntary, you can hold your breath. Why? Because the inputs are coming from the cerebral cortex. So voluntary is always from the higher center. The cerebral cortex, inputs coming via to the muscles, respiratory muscles, via the corticospinal tract through the descending pathway. Then automatic control of respiration is located in the brainstem, in the medulla and the pons. That is what we are going to see. So what we are seeing here are the respiratory centers. Respiratory centers are nothing but group of neurons. These respiratory centers are nothing but group of neurons which are controlling the rate, the rhythm and force of respiration. Okay, so neural control again could be voluntary and automatic. Voluntary is from the inputs are coming from the cerebral cortex through the corticospinal tract. Okay, then talking about the automatic control of respiration, it is mainly located in the brainstem. These centers are called as respiratory centers. Okay, so these respiratory centers are located in the medulla and pons. So we have pontine medullary center, pontine centers and the medullary respiratory centers, pontine respiratory centers and medullary respiratory centers. Okay, what do these respiratory centers do? They control the rate, they control the rhythm and they control the force of respiration. Okay, so now let us look at these centers briefly. So what you see here are the pontine centers and medullary center. In pons you have two centers, pneumotaxic center, apneustic center. So two centers we are seeing, pneumotaxic center and apneustic center. Okay, what is the work of this pneumotaxic center? The pneumotaxic center will inhibit the apneustic center. Normally, the pneumotaxic center will inhibit this apneustic center. Okay. Then, what is the role of this apneustic center? We'll come to it. Then, you have the medulla. In medulla, we have two centers, dorsal group of neurons, ventral group of neurons. Very famous, like DRG, VRG. Okay. Now, what will this apneustic center do? It will stimulate, the apneustic center will stimulate the dorsal respiratory group of neurons. So other than these four neurons, pneumotaxic, apneustic, DRG and VRG, in the ventral, at the top of the ventral group of neurons, we also have the pre-Botzinger complex. Okay, we also have the BOTC, pre-Botzinger complex. Okay, these pre-Botzinger complex are pacemaker cells. Okay, they have the capacity to fire on their own. Now let us look at the functions. So already some functions I told you, salient functions I told you. Pneumotaxic center will inhibit the apneustic center. There is one more thing also that inhibits the apneustic center, vagus nerve. So vagal stimulation will also inhibit the apneustic center. What is basically this apneustic center do? It will stimulate the dorsal respiratory group of neurons. Why? Because this dorsal respiratory group of neurons are the ones which is important for inspiration. Okay. Now apneustic center will stimulate the DRG. Okay. With this we will look at the functions. Okay. So in medulla you have the medullary respiratory center. First is a pre-Botzinger complex, which are the pacemaker cells of the respiration. They are important for spontaneous respiration. So initiation of respiration. So the moment you see pre-Botzinger complex, you have to remember this term, initiation of respiration. Okay, then DRG. DRG is mainly for inspiratory discharge. DRG means inspiration. Then we have the ventral respiratory group. VRG means forceful expiration. Why normal expiration is not included here? Because normal expiration is a passive process. Okay, automatically because of the recoiling properties of the lung, it is going to recoil. So there you don't need anything. Only during forceful expiration like exercise, we need the ventral respiratory group of neurons. Then pneumotaxic center, already I told you, it is going to inhibit the apneustic center. By inhibiting the apneustic center, what it is doing, it is switching off and on between inspiration and expiration. So it is switch off and on center for respiration. When you see these keywords, switch off and on means immediately you have to remember pneumotaxic center. Apneustic center, what does it do? It is exciting the dorsal respiratory group of neuron. So it brings about inspiration. Actually, this apneustic center prolongs inspiration and causes apneosis. Okay, that is prolonged inspiration and then a pause. Okay, fine. So that is with these centers. As I told you, the vagus nerve and the pneumotoxic center keep the apneustic center in check. So when you have this question, vagotomy stimulates. So once vagotomy is done, what is it going to do? It is going to stimulate the inspiration because the inhibitory influence of vagus on apneustic center will be removed in vagotomy. So now apneustic center is going to go and stimulate DRG. So it is going to stimulate inspiration. Prolonged inspiration will happen. Okay. So now coming to the question. Now you answer this question. Forceful expiration means which neurons? Yes, ventral respiratory group of neurons. So dorsal respiratory group of neurons is for what? Inspiration. Pneumotaxic center is what? Switch on and off neurons. What is it switching on and off? Inspiration and expiration. Chemoreceptors are chemical regulators of respiration. It doesn't come under the neural regulation. Okay, I hope it is clear. Now coming to the peripheral chemoreceptors. Okay, so what does the peripheral chemoreceptors do? The peripheral chemoreceptors respond. So this now from neural regulation of respiration, we are moving on to chemical regulation of respiration. Peripheral chemoreceptors respond to hypoxia using which channel? Peripheral chemoreceptors. Is it first true? Do peripheral chemoreceptor respond to hypoxia? Yes. By using which channel? So that is what they are asking. Let us first discuss little bit about the chemical regulation of respiration before answering this question. So when we are talking about chemical regulation of respiration, we have the peripheral chemoreceptors, central chemoreceptors, right? So what you see here is a peripheral chemoreceptors. Okay. So in peripheral chemoreceptors, you have the aortic body and carotid body. Where is carotid body located? At the bifurcation of internal and external carotid artery. Signal from this carotid body is carried via the ninth cranial nerve, that is the glossopharyngeal nerve. Ninth cranial nerve, glossopharyngeal nerve to the medullary respiratory centers. Okay, and information from the aortic bodies are carried by the 10th cranial nerve, vagus nerve, to the same medullary respiratory centers. Peripheral chemoreceptors are stimulated. They respond to changes in partial pressure of oxygen, partial pressure of carbon dioxide, and hydrogen ion concentration. So it is going to respond to all these three things. When decrease in partial pressure of carbon dioxide, increase in partial pressure of oxygen, decrease in pH. All these three things peripheral chemoreceptors will respond. But if you have to pick one best, what is it? What is the answer? Hypoxia. Okay, so hypoxia or reduced availability of oxygen is the most potent stimulus for peripheral chemoreceptor activation. Now our question, what was our question here? The hypoxia is going to activate the peripheral chemoreceptor using which channel? Okay, we'll come back to that. So by now this is clear for you. It is going to respond to all these three changes, but hypoxia is the most potent stimuli for peripheral chemoreceptor activation. Now what you see here is the central chemoreceptors. Okay, central chemoreceptors, where are they located? They are again located in the medulla. Now the central chemoreceptors are most sensitive. Okay, it is most sensitive to changes in partial pressure of carbon dioxide. Okay, how do they respond to this change in partial pressure of carbon dioxide? By looking at the hydrogen ion concentration in the fluid that is lining the blood. Okay, so by looking at the hydrogen ion concentration in the CSF or the blood that is perfusing the brain. Okay, fine. So now what is happening here is, in the extracellular fluid, the concentration of partial pressure of carbon dioxide increases. Okay, now we have a blood brain barrier here. Okay, so this blood brain barrier is very tight and it doesn't allow ions like hydrogen ions to go into the chemosensitive area or in this chemoreceptor zone. Hydrogen ion cannot enter here. Hydrogen ion cannot enter because of this blood brain barrier. But I told you it is most sensitive to, or it will respond to, increase in hydrogen ion concentration. How? By sensing the partial pressure of carbon dioxide. What happens is, when the partial pressure of carbon dioxide increases, in case of respiratory acidosis, okay, when the partial pressure of carbon dioxide increases, this carbon dioxide being a gas, this can easily cross the blood brain barrier. Then crossing the blood brain barrier, what will happen? It enters into the brain and this carbon dioxide combines with water to form carbonic acid in the presence of the enzyme carbonic anhydrase, and immediately it will dissociate into hydrogen ion and bicarbonate ion. And this hydrogen ion is stimulating the central chemoreceptors and it brings about hyperventilation. Okay, so peripheral chemoreceptors are most sensitive to hypoxia. Central chemoreceptors are sensitive to hypercapnia and respond to hypercapnia by being sensitive to hydrogen ion concentration. Okay, now our question was about the peripheral chemoreceptor. So whenever there is hypoxia, there is increased in cyclic AMP activity. Where? In the peripheral chemoreceptors, that is a carotid body and aortic sinus, and also decrease in the mitochondrial NADPH activity and loss of oxygen from the heme containing protein that is present in the carotid and aortic bodies. All this collectively is going to inhibit the potassium channels. Due to the inhibition of potassium channels, there is decreased potassium efflux. When potassium efflux is decreased, positive charge inside the cell, positivity of the cell increases. Whenever the inside of the cell becomes positive compared to the outside, what is going to happen? Depolarization will happen. So depolarization of the type 1 glomus cell, to be more specific, type 1 glomus cell of the carotid and aortic bodies will happen. Okay, depolarization is going to cause opening up of voltage gated calcium channels, influx of calcium, calcium mediator neurotransmitter release is going to happen. This is going to increase the discharge in the 9th cranial nerve. Another very important MCQ here is what neurotransmitter is released. Here, in case of your glomus cell, influx of calcium is going to cause release of dopamine. Okay, be very careful. Please don't select acetylcholine. It is a general tendency to select ACH, not acetylcholine, but here the neurotransmitter that is released in case of our glomus cells in peripheral chemoreceptors is dopamine. So 2 points you have to remember in peripheral chemoreceptors. Okay, one is which ion is responding to this? Potassium. Usually for depolarization to happen, what do you need? We will always think it is opening up of voltage gated sodium channels, more positive charges coming in. But here for depolarization to happen, here in this case, it is inhibition of the potassium channels which causes the depolarization. That is one concept you have to remember, which is different and unique. That is why it comes as an MCQ question. The second concept is, in response to this action potential, what neurotransmitter is getting released? Dopamine is released. So these are the two key concepts you have to remember. Then stimulation of the respiratory centers and ventilation will happen. So to answer our question here, what is the channel here? It is the potassium channel. Okay. Then next question. Okay, we are looking what is this? Ventilation perfusion ratio. Okay, true about infinite ventilation perfusion ratio. So before again looking at the options, let us discuss about ventilation perfusion ratio. VA by Q ratio. What is this ventilation by perfusion ratio? This is the ratio which evaluates the matching of ventilation to perfusion. It is a ratio that evaluates the matching of ventilation to perfusion. As such, you know, in our lungs, again, due to gravity, if you can recall all those concepts which I already told you in lung compliance, understanding and remembering this is going to be easier. Okay, due to the effect of gravity, already what I told, the alveoli in the apex of the lungs are already distended. Because of their already distended alveoli, the blood vessels are all compressed. So how is it going to be? What is happening to the perfusion? What is this ratio? Ventilation by perfusion ratio. So at the apex of the lung, how is it going to be? The blood vessels are all compressed by already distended alveoli. So naturally the perfusion is less. The perfusion is less. What about ventilation? The compliance of the lungs at the apex is low. Since the compliance is low, the ventilation is also going to be low. Okay, thus in the apex of the lung, the ventilation is also decreased, the perfusion is also decreased. But the decrease in perfusion, okay, the diffusion perfusion, this is Q, sorry, V by Q ratio. The decrease in Q is denoted by perfusion. The decrease in perfusion is far much greater than the decrease in ventilation. So naturally, what is going to happen? The V by Q ratio is more. Okay, the V by Q ratio in the apex is increased. Okay, it is around 3.6 normal value. Zone 2 is the ideal zone. 0.8, everything is normal here. Coming to the base. Okay, in the base, you remember the size of the alveoli, it is small. What about the compliance? Base, the compliance is best. So what is going to happen? What about the ventilation? Since the compliance is good, the ventilation is going to be more. What about the perfusion? The perfusion is also going to be more because the size of the alveoli is small. So the blood vessels are all not compressed. So more blood flow will be there. Perfusion is more. Compared to the ventilation, the perfusion is far much better than the ventilation. So here the V by Q ratio actually decreases. So at the base, the V by Q ratio decreases. Okay. So how much is this ratio here? At the base, it is around 0.6. Okay. Since the V by Q ratio decreases here, what do we call this type of ventilation? wasted perfusion. In the base, there is wasted perfusion because why? The blood flow is so much high, but the ventilation is not as high as the blood flow. So, since it is not getting matched, this is called as, in base we call it as wasted perfusion. In apex, what do you call it as? Wasted ventilation, because there is air is there, but the blood supply is not there, so exchange of gases are not happening. At both the places there is no proper exchange of gases. Apex is called as wasted ventilation, base is called as wasted perfusion. In the base, the V by Q ratio decreases, in the apex the V by Q ratio increases. Sometimes when we say decreases, we can also take it as V by Q ratio is around 0 here, decreases. When I say increases, we can also say at the apex the V by Q ratio is infinite. At the base the V by Q ratio is 0. Ideally it is decreasing. So we can even correlate it and say it is 0, and in the apex we can say it is infinite, because in our question what they are asking, infinite ventilation perfusion ratio. So one thing is, where do you see infinite ventilation perfusion ratio? At the apex of the lung. At the base of the lung it is 0. Okay, so what are all the conditions in which you will have a infinite ventilation perfusion ratio, as we see in the apex of the lung? Okay, what are those such conditions? One is, you can see when there is a dead space. Okay, and also pulmonary embolism. In both these conditions, see, in dead space you have so ventilated, remember this word, wasted ventilation. So in dead space what is happening? The air is there, but no exchange of gases is happening because there is no blood supply. Okay, so this is wasted ventilation. So dead space. Second is pulmonary embolism. Blood flow in the pulmonary capillaries are stopped because of the emboli. Because of that also there is no gas exchange. So that is another cause of wasted ventilation. Now coming to the base. Base is wasted perfusion. When can this happen? Shunting of blood. Okay, so ventilation perfusion ratio can be 0, which is usually at the base of the lung in conditions like shunting and bronchial obstruction. Bronchial obstruction. In bronchial obstruction, what is happening? Air is not flowing, blood is there, but air is not there. So this is called as wasted perfusion. With this idea, now you answer. Infinite means, what is the answer here? It is usually at the apex and dead space. Shunting means what? At the base, where the ventilation perfusion ratio is, V by Q ratio is 0. Here the V by Q ratio is infinite. Which part of the lung usually? You see it as the apex of the lung. Which part of the lung you see this? You see this at the base of the lung. Okay, clear all of you? This is a little tricky, but if you go through it once, you will be able to answer and grasp the concept. So instead of asking you in a theoretical manner like this, they can even give a graph like this, ventilation perfusion graph. So when you look at this graph, same concepts what I discussed here, you're looking at a graph. So in this graph, you in the x-axis on the right side and on the left side, this is the left side. Okay, so on the right side, what you see is the apex of the lung. What you see here is the base of the lung. Just remember this much. The rest of the thing is the same discussion what we saw. Okay, here the right lowermost part shows the apex of the lung and uppermost part on the left side is the base of the lung. Okay, let's move on to the next question. Identify the marked region in this spirometry graph. Definitely one question keeps coming from spirometry. Okay, so what is the area marked here in black? We have to identify it. Okay, let's go through this graph one by one. Okay, so what is this tracing? This is a tracing of the different lung volumes and capacity. What is the difference between a lung volume and capacity? When you add more than 2 or more than 2 lung volume, what you get is a capacity. So always the value of lung capacity is going to be greater compared to lung volume. Capacity is going to be greater compared to lung volume. Keep this one concept in mind. Now let us look at the definitions and normal value and the physiological significance. As I keep telling toward this entire live session, what I am telling is physiological significance, physiological significance. Why? Because once you understand these concepts, once you understand all these physiological concepts, believe me, answering not only physiology question, even the questions that comes from general medicine, okay, even that is going to be very, very easy. Okay, because the same, only when you know this normal physiological concept, you will be able to extrapolate it to the disease concepts. Okay, why it is happening, what is the cause of this particular sign and symptom, all this only if you understand the basic physiology, you will be able to interpret and answer those questions. Okay, so now let us come back to our topic. We will start from here, tidal volume. Okay, I will use a different color because red is here. Okay, now tidal volume. What is tidal volume? It is the normal respiration. Normal inspiration and expiration at rest is called as tidal volume. So normal inspiration and expiration at rest is called as tidal volume, which is around 500 ml. Okay. Now, following a normal tidal inspiration, the maximum volume of air that can be inspired following a normal tidal inspiration is called as inspiratory reserve volume. How much is inspiratory reserve volume? Around 3000 ml. Then again you do a normal tidal respiration. Following a normal tidal expiration, what is the maximum volume of air you can expel? That is called as expiratory reserve volume, which is around 1200 ml. Okay, so we have finished 3 volumes: tidal volume, inspiratory reserve volume, expiratory reserve volume. Then what is remaining? Residual volume. Okay, so this portion what you see here is the residual volume. So it is a volume of air remaining in the lungs after a forceful expiration. After forceful expiration. So what is the normal value for this? Again 1200 ml residual volume. Okay, then we have capacities. Now we are moving on to capacity. So we discussed 4 volumes. What are those 4 volumes? Tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume. 4 volumes we discussed. Then move on to the capacities. So first is the inspiratory capacity. That is, okay, so inspiratory capacity is the maximum volume of air that can be inspired following a normal expiration. So that is called as inspiratory reserve volume. Okay, how much is inspiratory reserve volume? Inspiratory reserve volume is tidal volume plus inspiratory capacity. Inspiratory capacity. Inspiratory capacity is tidal volume plus inspiratory reserve volume. So how much is it? 500 plus 3000. So it is equal to 3500 ml. So inspiratory capacity is 3500 ml. Then what do you have? Vital capacity. Okay, so what is vital capacity? Vital capacity is nothing but the volume of air that can be forcefully expelled after a maximal inspiration. That is vital capacity. So vital capacity, if you can see, it is inspiratory reserve volume plus tidal volume plus expiratory reserve volume. So which is around, how much is inspiratory reserve volume? 3000. How much is tidal volume? 500. Expiratory reserve volume again 1200. So it is around somewhere around 4.2 liters. Okay, so that is vital capacity. Then you have one more. That is what they are asking. What is this? What is this? Expiratory, what is this? Functional residual volume, or sorry, functional residual capacity, FRC. So what is FRC? So many times we already saw the volume of air that is remaining in the lung at the end of normal expiration. That is expiratory reserve volume plus residual volume 1200 plus 1200, which is 2400. So vital capacity is around 4.2 liters. This is around 2400 ml. And what is total lung capacity? When you add all these things, okay. TLC, total lung capacity, is inspiratory reserve volume plus tidal volume plus expiratory reserve volume plus residual volume. When you add all these things, you get is 6 liters. So that is total lung capacity. Then in this, so already we know the answer. Marked region in this pyrogram, what is it? Functional residual capacity, which is around 2400 ml. And you know the significance of functional residual capacity. What is it? It is a point at which the outward recoiling of the chest wall and the inward recoiling of the lungs is exactly balancing. Okay, so that is the functional residual capacity. What is the significance of residual volume? Residual volume is the volume of air that is there in the lung even after a forceful expiration. So this residual volume is the one which prevents collapse of the lung. Okay, prevents the collapse of the lung and also provides constant air for gas exchange. Okay, so that is the significance of residual volume. What do you mean by vital capacity? It is simply telling you how much of air can move out, how much of air the lungs can move out. That is told by vital capacity. Okay, then what about total lung capacity? TLC, that is telling you how much of air the lungs can hold. How much of air lungs can hold is total lung capacity. How much of air the lungs can move out is vital capacity. So sometimes you have to understand the concept. They will only give these key lines. The capacity of the lungs to, maximum capacity of the lungs to hold air is given by what? Then you have to take total lung capacity. The ability of the air to move, ability of the lungs to move air out signifies what? Vital capacity. So like that, they won't give the exact definition, they will give the interpretation of the definition. So that also you should be able to know. So I have almost covered all these things here. One more concept coming to this lung volumes and capacities. Among all these lung volumes and capacity, which are the ones that cannot be measured by spirometry? Anything that involves residual volume in its formula, we cannot measure it directly by spirometry. So what are those three things where you see residual volume? In functional residual capacity, okay, so in FRC you have residual volume, so FRC cannot be measured. In total lung capacity you have residual volume, so total lung capacity also cannot be directly measured. What else? Residual volume per se. So residual volume, functional residual capacity, total lung capacity cannot be measured directly by spirometry. Okay, so that almost covers our entire discussion on lung volumes and capacities. Now let us move to the next topic in our respiratory system. What is this? What are we seeing here? By looking at this picture, by now you should have guessed it. What is it? This is on surfactant. Okay. So what is this question telling you? A preterm baby was delivered at 28 weeks. Which of the following is true about surface tension and compliance? Okay. Very, very easy answer, direct question, you will be able to answer it. Let's just discuss the basics. So first is, we are talking about surfactant. The question is on surfactant. What is surfactant? It is a surface active agent that reduces the surface tension. Surfactant is a surface active agent that reduces the surface tension. By reducing the surface tension, what is it doing? Prevents collapse of lung alveoli and also decreases the work of breathing. So these are the two very important functions of surfactant. Okay. Now, what is the source of surfactant? It is secreted by type 2 alveolar epithelial cells. So, what you see is a type 2 alveolar epithelial cells. Even in this type 2 alveolar epithelial cells, they will ask you which organelle contains the surfactants. The surfactant is stored in the lamellar bodies. Very important MCQ. Lamellar bodies inside the type 2 alveolar epithelial cells contain surfactant. Okay. How is it synthesized? With the help of different proteins, mainly dipalmitol phosphatidylcholine. Okay. So now let us look at the composition of surfactant. It contains 90% of the surfactant is made up of lipids. Among this, most important lipid is this DPCC, dipalmitol phosphatidylcholine. Then you have phosphatidylglycerol and other phospholipids and neutral lipids. 8% is proteins. Okay, what do these proteins do? That is again an important MCQ. They facilitate the formation of phospholipid film. What do proteins and surfactants do? They facilitate the formation of phospholipid film at the surface of the alveoli. Important proteins are albumin, immunoglobulin A, which provides immune functions, and surfactant protein A, B, C, and D. Okay. In this, most important surfactant protein A, which is controlling the reuptake of surfactant by type 2 cells. So, other than the proteins, lipids, 2% of carbohydrates is also present. Okay. What is the time of starting of synthesis of surfactant? At around 28 weeks. This poor baby, preterm baby, is born at 28 weeks. So, will this baby have surfactant? No. Okay. And this is completed, about 90% completed at term. That means even after birth, the surfactant synthesis will continue. Okay. What are all the factors that facilitates the synthesis of surfactant? Glucocorticoid hormones, thyroid hormone, insulin, stretching of the lungs immediately after the first birth. After birth, during the first breath, the lungs are getting stretched. That is going to increase the secretion of surfactant. Even in adults also, stretching of the lungs is going to increase the production of surfactant. Beta adrenergic agonist, calcium, regular exercise, all this will increase the surfactant synthesis. What are the factors that is going to, see, it is written wrongly written, it is not facilitate. Please in your PDF correct it. Inhibit. What are the other factors that inhibit surfactant synthesis? Prematurity, just like the case scenario we are seeing, hypoxia, acidosis, inflammation, mechanical ventilation, pulmonary edema, oxidative stress, malnutrition, smoking, drugs, all these are going to reduce the synthesis of surfactant. Okay. So in this question, already I told you, two very important functions of surfactant is preventing the lung collapse and decreasing the work of breathing. Now let us look at this. What is true about surface tension and compliance? So since this baby is born preterm at 28 weeks, definitely surfactant is going to be low. Because of that, the surface tension will be high. And whenever the surface tension is more, the compliance is going to be less. So what is the answer here? Option A. Okay. Now let us look briefly at other functions of surfactant. Already I told you it prevents a lung collapse. It is very important for alveolar stability. It is important to prevent edema, and it also decreases the work of breathing. It has IgA and other immune substances which is important for phagocytosis. How does surfactant maintain this alveolar stability? Okay, we will see that concept because that is also important for your MCQ point of view. Normally what you see here is a lung alveoli which is lined by a layer of fluid. Okay, this fluid, see how are all they very close to each other. Why? Because of the intermolecular hydrogen bonding. Because of the intermolecular hydrogen bonding or attraction. As they attract each other, what are they going to do? They are going to come closer. When they come closer, what will happen to the diameter? The diameter of the alveoli will decrease and finally it will collapse. Now what is surfactant doing? It is going and inserting between these water molecules. So the distance is increased. distance is increased and the attraction is prevented. The intermolecular attraction is cut or it is prevented because the surfactant molecule inserts itself in between these water molecules. So because of this, what is that? Maintains the alveolar stability. So thus surfactant reduces the surface tension and maintains the alveolar stability. Okay. But if you look at the law of Laplace, what does it say? According to law of Laplace, pressure is equivalent to twice the tension divided by radius. So this is, you see, two lung alveoli are there, alveoli 1 and alveoli 2. In lungs, you can find both these alveoli. Okay, because the size of all alveoli inside the lungs is physiologically not the same. It is going to be like this only inside the lungs. Similarly, the size of the alveoli during inspiration and during expiration is also going to be different. So now, according to Laplace law, smaller the radius, greater will be the tension developed, right? If more is the tension, then what is going to happen? According to law of Laplace, this smaller alveoli should empty its content into the larger alveoli and this should collapse. But it is not happening. Why? Because of this surface active agent, that is the surfactant, prevents the collapse of this alveoli and maintains the alveolar stability. So that is another very important functions of surfactant. Then next very important function of surfactant is it prevents the development of pulmonary edema. Okay, why? How it? What is happening is when the surface tension is more, the interstitial pressure reduces. Okay, when the surface tension is more, the interstitial pressure reduces. When the pressure in the interstitium reduces, automatically the fluid is getting filtered from the capillaries into the interstitium. So this is going to result in pulmonary edema. Now, under the presence of surfactant, the surface tension is reducing so that occurrence of pulmonary edema is also prevented. Okay, so that is our discussion with surface tension. Now, going to the next question. A man develops dyspnea and palpitations after he is ascending to an altitude of about 300 meters. Sorry, 3000 meters. Which of the following should not be done? So when you are going to high altitude, they are asking what should not be done. When a person is going to high altitude, what are his chances? There are chances of him developing high altitude pulmonary edema, high altitude cerebral edema, right? So keeping that in mind, let us see all those four options. Option A, acetazolamide. Option B, rapid descent, that is coming down immediately. That is what they are telling us, he has gone to 300-meter altitude and this patient has developed high altitude pulmonary edema. Now, what should not be done to this patient? Because see, they are telling he is developing dyspnea and palpitation. So he is developing high altitude pulmonary edema. Now, what should not be done when a patient is having high altitude pulmonary edema? Will you give acetazolamide? What is acetazolamide? Acetazolamide is a carbonic anhydrase inhibitor. It is a diuretic. So what is it going to do? It is going to remove the fluid from the lungs and expel it out via the urine. So definitely acetazolamide can be given. Rapid descent. Yes, first thing is bring him down. Don't maintain him at that high altitude. So that is also correct. Oxygen supplementation. He is dyspneic. There is pulmonary edema. He needs supplemental oxygen. That is also true. IV digoxin is the answer here. What you don't do is you don't give IV digoxin. So digoxin, you know better. It is given for treatment of heart failure and other heart conditions like atrial fibrillation, not indicated in high altitude pulmonary edema. Very briefly, before ending our discussion on respiratory system, let us look at the physiological changes that occur at high altitude. Okay. So a few important questions here is you already know. As you ascend up to high altitude, what is happening is the barometric pressure decreases. It is not the percentage of oxygen that is altered. Oxygen is always 21% only. The partial pressure of oxygen, the barometric pressure, the partial pressure of oxygen is what decreases. That is what they are telling you here. Okay. Now, all the symptoms that is coming is because of hypoxia. And when do these hypoxic symptoms occur? Usually at a level of about 10,000 feet and it becomes more severe around 15,000 to 18,000 feet. Okay. What are all the immediate changes and late changes? Immediate change is hyperventilation, hypoxia induced hyperventilation. But this hyperventilation is not going to be there for very long. Why? Because of hyperventilation, what will happen? The partial pressure of carbon dioxide will decrease. When partial pressure of carbon dioxide decreases, what will happen? The stimulation for hyperventilation is reduced. Okay. So what will happen? In the first stage, the hyperventilation that occurs due to hypoxic stimulation decreases. Then in the second stage only, slowly after 8 to 10 hours, again it increases and it remains sustained for about 2 weeks. This is called as reaching the plateau. This is the most important concept what you have to remember in case of high altitude. Okay. Then what are all the changes? We all know very clearly. Respiratory changes, increase in pulmonary ventilation. Heart, increase in heart rate, cardiac output and blood pressure. Hematological changes, very, very important. Hypoxia is the most potent stimulator for erythropoietin secretions from the kidney. So naturally what is going to happen? The RBC count is going to increase. As the RBC count increases, what will happen? There will be polycythemia. Why is this polycythemia beneficial? Because more hemoglobin is available to carry oxygen. Tissue changes are also very important. The number of capillary increases, the mitochondria increases, oxidative enzymes like cytochrome oxidase, myoglobin content and angiogenesis will happen. That increase in capillaries is nothing but angiogenesis. Okay, so that completes our discussion on respiratory system. After a short break, we will move on to our cardiovascular system. Welcome back. Let's continue our discussion with cardiovascular system. Okay. So what does the first question say? Identify the true statement regarding myocardial action potential curve. Again, a graph based MCQ, right? So here they have given different phases and they are asking you which among those four statement is true. Okay. Now let us look at this myocardial action potential graph. Here you can see. Okay. What is this here? Resting membrane potential. Okay. Then what is this? Point of stimulus. Okay. Now what is happening? Phase 1. What is this phase 1? Phase 1 is nothing but depolarization. And we all know what is the cause of depolarization? Influx of sodium. Sodium influx. Okay. So depolarization is mainly due to influx of sodium. After the depolarization is over, immediately there is a small phase here, phase 2, a small phase. Okay, what is the small phase here? That is called as initial repolarization. What is this phase called as? Initial repolarization. What is the cause of this initial repolarization? Opening of potassium channel, transient. Opening of transient potassium channel and slow sodium channel. Okay, and closure of fast sodium channel. So many things are happening in the small phase here. Okay, most important is opening of transient potassium channels. Okay, so if transient potassium channel is opening, what will happen here in this phase? Potassium efflux. There is going to be efflux of potassium. Then after that, what is happening? This phase 3 is also called as plateau phase. Okay, and this phase is because of opening of slow or L-type calcium channel. Along with this L-type calcium channel, slow sodium channels are also open. So in plateau, what is going to happen? Influx of calcium, influx of potassium, right? Then after the long plateau phase, you have the final, number 4 is final depolarization. In final depolarization, it is again opening of potassium channel, efflux of potassium ions. Then resting membrane potential. What is the cause for resting membrane potential? Sodium potassium ATPase pump. Okay, so this is what are the phases and ionic changes of action potential curve. I'll repeat it again. Here you can see both these. What is this? Phase 4 is resting membrane potential. That is during depolarization. During depolarization or phase 0, what is happening? Opening up of sodium channel, influx of sodium. Phase 0 is influx of sodium. Look here. Can you see? Open sodium and closed fast potassium channels is phase 4. No, that is wrong. Okay. What is phase 4? Phase 4 is actually the return to RMP because of the sodium potassium ATPase pump. What is this pump actually doing? During action potential, there is reversal of the membrane potential, right? So what is happening? The extracellular sodium comes inside and intracellular potassium leaves the cell. Now, when you want the resting membrane potential to be restored, we want this to reverse. And what is going to reverse this? Sodium potassium ATPase pump. All the sodium that has come from outside will be pumped out by this pump, and all the potassium which has gone out will be pumped back into the cell by the sodium potassium ATPase pump. So phase 4 is the resting membrane potential, which is because of the activity of sodium potassium ATPase pump. But what are they telling? Opening up of sodium and closure of fast potassium channel is called as phase 4. So this statement is wrong. Okay. Then what is phase 0? Depolarization because of opening up of sodium channels and entry of sodium. Okay. Then what are they saying? Due to slow, let us look at the next option. I'm just searching whether they are given opening up of sodium channels here. Okay. Opening up of sodium and closure of fast potassium channels. That is what they've given as phase 4. That is wrong. And phase 3. What is phase 3? Phase 3 is actually final repolarization. Phase 3 is final repolarization, which is due to opening up of potassium channels. Opening up of potassium channels. So can you see? Closure of sodium channel and opening up of slow potassium channel. That is phase 3. So this is actually should be phase 3, but they have not given the phase here. Okay. Actually what they are telling, phase 3 is due to this. So that is also wrong. Actually this is only phase 3. Then what is the right answer here? Option A. What is it? Due to slow prolonged opening up of calcium channels is phase 2. Phase 2 is the plateau. Plateau is the phase 2. So the right answer here is this. Actually in this question, for C, they have not given what phase it is. It okay? So that is why it is a little confusing here. But however, the right statement here is option A. That is, the plateau phase is due to the opening up of slow type of calcium channels and little of sodium channels. Okay. So again, this is very, very important. I will revise. Depolarization is due to opening up of what you see here is phase 0 is depolarization. Phase 0 is depolarization, which is due to opening up of voltage gated sodium channels, influx of sodium. Then here, according to this, phase 1 is initial repolarization. What is it? Initial repolarization, which is due to closure of sodium channels and opening up of fast potassium channels. Actually, this has to be that closure of sodium channels and opening up of transient or fast potassium channels is the phase 1. Since they are transient, immediately these potassium channels will close. So the efflux of potassium will stop. So that ends this phase. Initial repolarization is stopped. Then starts the phase 2 plateau phase. So in plateau phase, what are you seeing? A prolonged depolarization. In plateau phase, basically plateau is nothing but prolonged depolarization. Why is there sustained or prolonged depolarization? For depolarization to happen, you tell me what should happen. Here in phase 0, what has happened? Basically, positive charge has to be more inside the cell. That is going to cause depolarization. Now, in plateau phase, what are the channels that are open? L type, that is slow type of calcium channels are open. Calcium ions is coming inside, positive charge. Additionally, even your slow sodium channels are also open. That also is going to cause sodium ions to enter into it. So more positive ions are coming. So for a sustained long period of time, lot of positive ion keeps coming into the cells because these are slow channels. Slowly positive ion keeps on accumulating inside the cell. So the depolarization is sustained for longer duration. That is why it is in the form of a plateau. Then finally, next, once plateau is over, you have the final repolarization, which is due to opening up of sodium channels. And then the phase 4 here is the coming to the resting membrane potential due to the activity of sodium potassium ATPase pump. I hope now it is clear. Okay. Now we already saw the action potential for nerve. We have seen this action potential curve for cardiac muscle. What is the drastic differences that you can appreciate between the action potential of a neuron and action potential of a cardiomyocyte? What is it? Yes, the duration. The duration of a neuronal action potential is hardly for 1 to 2 milliseconds. Okay, neuron, cardiac muscle. Okay, so the duration is only for 1 to 2 milliseconds, whereas in cardiac muscle it is 250 milliseconds in case of atrium, and in case of ventricle it is around 350 milliseconds. So it is a very long action potential. In this long action potential, if you see this depolarization, it is hardly for 1 to 2 milliseconds. This phase 1 initial repolarization is again for 2 milliseconds. It is this plateau which is there for more than 200 milliseconds. Okay, and this final repolarization is around 100 milliseconds. Okay, so most important here is there is no plateau, whereas here you have the plateau. Because of the presence of plateau, cardiac muscle cannot be tetanized. Okay, whereas here this can be tetanized. Okay, clear? So these are all the difference between the neuron and a cardiac muscle action potential. Then next we'll go to jugular venous pressure. So many questions. This topic seems to be the favorite of the examiners. Every year one or the other questions comes from JVP, and JVP is very pretty easy to answer. It is almost direct questions are direct answers are only there in JVP. Okay, the C wave in JVP corresponds to what? Okay, let us see this JVP waveform. Okay, so here you are seeing the JVP waveforms. Okay, first, what is JVP? JVP is jugular venous pressure. So what do you mean by jugular venous pressure? Jugular venous pressure is nothing but the pressure in the right atrium is directly reflected in the jugular veins. And when you record it in a waveform, what you get is your jugular venous pressure waveform, what you see in this picture here. So in this JVP wave, you have 3 positive waves, A wave, C wave and V wave. All these are positive waves, and 2 negative waves, that is X descent, Y descent. So 5 waves are there. A, C and V are positive waves, X descent and Y descent are negative waves. Okay, so what is the cause of this A wave? So in this question what they have asked about C wave. Okay, so first we will discuss one wave after the other. What is the cause of A wave? A wave corresponds to atrial contraction. Very easy. A for A. A wave corresponds to atrial contraction. Okay, then comes C wave. Okay, A, C, V is there. No, what is the reason for C wave? C wave corresponds to ventricular systole. C wave is ventricular systole. Please remember. See, first is atrial systole, A wave. Following atrial systole, what will happen? Ventricular systole. Okay, most of the time, we are once atrial systole is over, we don't discuss about atrial diastole because it happens during the ventricular systole, right? So once atrial systole is over, move on to the atrial diastole. That is, A wave is over. Next, C wave. Easier way to remember, it is during ventricular systole. So during this ventricular systole, what is happening? Most important, closure of tricuspid valve. On the right side, we are talking about the right side, right? So on the right side, the tricuspid valve closes. So C wave corresponds to the closure of the tricuspid valve, and at the same time, as it happens during the ventricular systole, as the ventricle contracts, what is going to happen? As the right ventricle contracts, there is a slight bulge of this tricuspid valve into the right atrium, which is recorded as this small positive wave, C wave. Earlier, then why can't we call it as B wave? Why have we named it as C wave? Because earlier it was thought that C wave is because of the pressure transmitted from the nearby carotid arteries. So that is why we are calling them as C wave. So now you know the reason for C wave. No confusion, very, very easy to remember. A wave, atrial contraction, atrial systole. C wave when happens during ventricular systole. So what is the event that happens during ventricular systole? Closure of the tricuspid valve. Okay. So ventricular C wave is during the ventricular systole. Then V wave. Okay. The last is the V wave. What is the reason for V wave? V wave is due to the ventricular filling against the closed tricuspid valve. Now the tricuspid valve is closed, the ventricle is filling. Okay. So this is the reason for the V wave. Then 2 negative waves are there, X descent and Y descent. X descent occurs during when the atrium is relaxing. When the X descent is atrium is relaxing during the ventricular systole. Then Y descent is due to the opening up of tricuspid valve. Y descent is due to the opening up of tricuspid valves and blood flows into the right ventricle. Okay, so these are the causes of the different waves. Now you tell answer. C wave is due to, is it due to atrial contraction? No, that is A wave. Is it due to atrial relaxation? No. Is it due to isovolumetric relaxation? No. It is due to isovolumetric contraction. C wave. What did I say? C wave is during ventricular systole. What happens? Actually, it is isovolumetric ventricular contraction. Ventricular systole. Okay, so the cause of C wave is isovolumetric ventricular contraction. Again the same question. C wave in JVP is seen due to, what is it? Closure of tricuspid valve during isovolumetric ventricular contraction. Option B. Okay. Next question. Again, another question is also from JVP. The cardiovascular findings in a patient were as follows. The patient has got large A waves, mid diastolic murmur, pedal edema. So these are all findings of what? Mitral stenosis, mitral regurgitation, tricuspid stenosis, tricuspid regurgitation. Even if you don't know the causes, you can easily rule out two options: mitral stenosis and mitral regurgitation. Why? Because they correspond to the left side of the heart. We don't want that. We are concerned, JVP is concerned with the right side of the heart. So the answer should be either tricuspid stenosis or tricuspid regurgitation. Okay, so based on the clinical scenario here, it is most likely to be a tricuspid stenosis. Why? Because only in tricuspid stenosis you will hear a mid diastolic murmur and there will be prominent A waves. When can you have prominent A waves? There are actually two, prominent or large A wave. Okay, then canon A waves. Canon A waves are very, very huge A waves. Okay, so they will ask like this. So when do you have a prominent A wave? Okay, whenever the any right-sided diseases like pulmonary hypertension. Okay, pulmonary artery stenosis, then right heart failure, and cardiomyopathy. All these conditions can cause a prominent A wave. Okay, and what about canon A waves? When a right atrium is forcefully contracting, when the right atrium is forcefully contracting, there will be canon A waves. Okay, now okay, so now let us see. In this condition, the answer is tricuspid stenosis. So the right answer here is tricuspid stenosis. Okay, now if the same patient, in a patient with tricuspid stenosis, if they say arrhythmias is present, okay, if it is along with atrial arrhythmias, if there is atrial arrhythmias along with tricuspid stenosis, A wave will be absent. I think this topic you will deal in much greater detail in your general medicine. I'm just setting the base for you to understand. Okay, so if there is tricuspid stenosis along with atrial arrhythmias, then definitely A wave will be absent. So that can also happen. Here they are telling large A wave. Suppose they are giving absent A wave with arrhythmias. Same finding, absent A wave with arrhythmia. Then also the answer is tricuspid stenosis. Not only large A wave, even absent A wave also. But when it comes as absent A wave, arrhythmia will be a finding. Okay, the next question. The ebb and flow phase are seen in normal cardiac cycle, normal respiratory cycle. Is it a stress response or is it a muscle contraction during exercise? Again, even if you don't know ebb and flow phase, at least this much you can see that it is not muscle contraction during exercise, definitely. right? So then what is this ebb and flow phase? These are nothing but, ebb and flow phase are nothing but, these are concepts typically used in shock physiology. Whenever there is a trauma, injury to the cells, and when the patient goes into shock, the patient will enter into two phases. The initial phase is called as the ebb phase, and the next phase is called as a flow phase. Initial ebb phase, most important is all the tissue functions will come down to save the life of the patient. Okay, so due in response to trauma, tissue perfusion and all metabolic functions are decreased. That is the F phase. Following the F phase, once cardiopulmonary resuscitation is done, once the patient is stabilized, then the subject will enter into the flow phase, where slowly perfusion will increase, metabolic activity will increase, and the healing process will start. So that is a ebb and flow phase. So what is the answer here? It does not happen during normal cardiac cycle, not during normal respiratory cycle. The right answer is, it is a stress response. So initial ebb phase, everything is decreased. Flow phase, later regaining of normalcy. Okay. Next question. Which of the following will be involved in baroreceptor reflex? Okay. So four things they are asking. Is it a negative feedback? Is it a positive feedback? Is it an adaptive control? Is it a feed forward control? Baroreceptors we know very well. You don't, this is like, even if we wake you up from sleep and ask, you will be able to tell, because this is a direct question. Baroreceptor is negative feedback mechanisms. Okay, baroreceptors are the one which can act in both the direction. Okay, it can act in a BP range of around 500 to 200 mmHg, mean arterial blood pressure of around 50 to 200 mmHg. So a pressure which can go as low as 50, or a pressure which can rise as high as 200. In the range of the range in which the baroreceptors act is very, very wide, 50 to 200 mmHg of mean arterial pressure. Okay. Can you give me some examples of other negative feedback mechanisms? Can you recall and tell? Negative feedback mechanisms, try to recall. Hormones, thyroid hormone, adrenocorticotropic hormone, growth hormone, all these hormones mainly act via negative feedback mechanisms. Then positive feedback mechanism, childbirth, blood clotting. Okay, Hodgkin's cycle. What is Hodgkin's cycle? So as we have been discussing this, what is it? Action potential graph. I remember this Hodgkin's cycle. Why? Opening up of, during that local response, when some sodium channels open, what is it going to do? It is going to cause opening up of more and more sodium channels, right? That is leading to depolarization. That is called as Hodgkin's response. That is also an examples of positive feedback mechanism. Okay, blood clotting, childbirth, all those things. What is this adaptive and feed forward control? This adaptive and feed forward control mainly happens in the central nervous system. Okay, a type of adaptive control is feed forward control. Basically, what is happening? The central nervous system will anticipate and do the correction even before the actual event happens. Okay, so that is called as adaptive and feed forward controls. Okay. Now, a little bit about baroreceptor reflex. Okay, so baroreceptor reflex is what type of reflex? It is a negative feedback mechanism. Already I told you, it is a short-term regulation of blood pressure. Okay. Baroreceptor reflex is a short-term regulation of blood pressure. What is happening here in baroreceptor reflexes? It can act in either direction. Since I am telling short-term, under short-term it is nervous regulation. Because in short term again you will have different types, right? So baroreceptors are the nervous regulation which are short term. They will act within seconds to minutes. They will bring about the changes during seconds to minutes. It is very, very important for everyday activity. At the same time, it is very, very important even as a life-saving reflex. Okay, so both ways this baroreceptors is important. I'll tell you why. Then another question what they will ask is the BP range. Already I told you, 550 to 200 mmHg of mean arterial pressure. So that means baroreceptor is the only short-term regulation which can act in both direction. Act in both directions. That is, if the pressure increases, it will reduce it. If the pressure reduces, it is going to increase it. So we also call it as buffer mechanisms, and the nerves, the glossopharyngeal nerve and the vagus nerve are called as buffer nerves. Okay, so these are all some salient MCQ point usually asked regarding your baroreceptor reflex. Now let us see how this reflex works. Okay. So there is increase in blood pressure. So here is a scenario where the blood pressure has increased. Once the blood pressure has increased, what is our aim? We have to bring down the blood pressure. So increase in blood pressure is going to cause stretching of the carotid sinus. So once the carotid sinus stretches, what will happen? These baroreceptors are stretch sensitive receptors. Okay, they are receptors sensitive to stretch. So they get activated. There is increased discharge in the 9th and 10th cranial nerve. So that is going to cause the stimulation of nucleus tractus solitarius in your medulla. Because of the stimulation of the nucleus tractus solitarius, what is going to happen? Two effects will happen. Stimulation of cardiac inhibitory center leading to stimulation of vagus nerve. Inhibition of vasomotor center. Inhibition of vasomotor center. If vasomotor center is inhibited, what will happen? The sympathetic outflow is decreased. When cardiac inhibitory center is activated, what will happen? The vagal outflow will increase. Once the vagal outflow increases, the heart rate decreases, the cardiac output decreases, the blood pressure decreases. Simultaneously, as parasympathetic outflow decreases, there will be decreased myocardial contractility and vasodilation. When vasodilation happens, blood pressure will drop. Similarly, when myocardial contractility comes down, cardiac output will reduce. This is how baroreceptor reduces the increased BP. The just opposite will happen if it has to increase a low BP situation. Okay, it is because of this baroreceptors only when we are changing posture. I told you, baroreceptors is very important for everyday activities as well as it is life saving also. Why? Because it is not just a CNS seismic response which acts as a last ditch response to save a patient. Even this baroreceptors are very important for our normal healthy living. Why? Because do we ever have dizziness, or do we fall down? Do we get hurt when we are changing posture? When you are getting up in the morning immediately from the bed, we don't have postural hypotension. But imagine how much of drop in BP happens. Almost 20 mmHg drop in this mean arterial pressure happens when we are shifting the posture from lying down to standing, which is almost equivalent to a 15% of blood loss. If 15% of blood is lost, that much of drop in BP will happen. So that kind of phenomenon happening, but we are totally unaware of it. Why? Because the baroreceptors are the one which is protecting us, bringing back the blood pressure even before us realizing that it has dropped, right? Now, another very important thing about baroreceptors here, what I want to stress is baroreceptors, that means if these baroreceptors are so effective, then why should a patient end up having hypertension in the first place? Immediately when the BP rises, it will reduce it and it has to bring it back to normal, right? But this doesn't happen. Why? Because the baroreceptors get adapted to the higher set point. Continuously, if the person's blood pressure remains high for a long duration, the baroreceptors will shift their set point to that higher value. So, from a normal 95 mmHg mean arterial pressure in hypertensive patients, if it is 120 mmHg, then it is going to, I'm talking about mean arterial pressure, not the systolic pressure, right? So now the baroreceptors will reset its set point to 120 mmHg and it will consider this 120 to be normal, and within that set point it will try to bring the BP back to normal whenever it changes. Okay, right? So I think we have discussed almost important high yield areas in cardiovascular system, and then let's move on to another very interesting topic, that is our renal physiology. Okay, so renal physiology, first question, what is it? What are they asking? Which gag? What is this gag? See, all these things they will give purposefully to make it harder for the students to answer the question. Okay, but you are more intelligent than them, definitely. You have read all these things, so if you just think for a while, you will be able to crack it. So nothing but GAG is what?
glycosaminoglycans. Okay, so which glycosaminoglycan is present in the glomerular basement membrane? Okay, so what are basically glycosaminoglycans? Glycosaminoglycans are nothing but polysaccharides, okay, carbohydrates, which are mainly present in the extracellular matrix. So glycosaminoglycans are polysaccharides which are mainly present in the extracellular matrix. Okay, what is their function? Stability. They provide cellular and metabolic stability. They provide cellular and metabolic stability to the surrounding cells. That is the function of glycosaminoglycans. In this option, they have given you 4 options, right? Heparin sulfate, chondroitin sulfate, keratin sulfate, and keratin sulfate 1 and 2. All these 4 options are glycosaminoglycans. It is only the location differs. So, in case of a glomerular basement membrane, what is the answer? It's a direct question. Answer is heparin sulfate. Okay, so in case of our glomerular basement membrane, it is the heparin sulfate which is present. Okay, what about the other things? Where are they present? Chondroitin sulfate. Yes, come on. What is the answer? Cartilage, bone physiology. Keratin sulfate 1 and 2, mainly in your skin, eyes, and other connective tissues. Okay, so that is the answer for this question. Now let us discuss, since these glycosaminoglycans has been asked, let us discuss one very important topic in the renal physiology related to this. What do you see here in this picture? What is this picture? What do you see here? This is a filtration barrier. In the glomerulus of the kidney. Okay, so there are 3 layers here. From outside to inside, there are 3 layers. Outside to inside, the glomerular filtration barrier is made up of 3 layers. What are those 3 layers? Okay. So what are those 3 layers? The first layer, what you see, is the capillary endothelium. Capillary endothelium is the first layer. Then what is this layer? Basement membrane. So that glycosaminoglycan, what we were discussing here, heparin sulfate, is actually present in this basement membrane. The heparin sulfate is actually present in this basement membrane. What is the third one? The podocytes, especially the food processes. Food processes of the podocytes. All these 3 make up the basement filtration barrier. Can you see some unique features? Can you identify some unique features for this basement membrane? Sorry, unique feature for this capillary filtration barrier. Okay, what we see here is the endothelial cells are not continuous. In between, they have pores called as fenestrations, and it is a filtrating membrane, right? So substances are, the size of these pores are quite large, so substances can be easily filtered through this filtrating membrane. The size is quite large, so substances can be easily filtered through these filtration pores. Okay, so these are called as fenestrations. Okay, so through this substances was passing, then it will pass through the basement membrane, and then here again you are seeing openings. So what is this opening you are seeing here? It is called as slit pores. It is called as slit pores. In between these slit pores, that is, there is one podocyte here, there is another podocyte here. In between these podocytes, you have a gap called as slit pores. Okay, now this gap is bridged by a protein. Okay, this gap is bridged by a protein called as nephrin. Okay, so, and that bridge is called as filtration slit diaphragm. Okay, is it clear? between podocytes there are gap. Those gaps are bridged by a protein called as nephrin. Basically, how is this protein nephrin bridging the gap? By forming a diaphragm, a membrane. So that membrane is called as filtration slit membrane or filtration slit diaphragm. Okay, so these are the salient features of our basement filtration barrier. One more thing what you have to stress here is the capillary endothelium has glycoproteins. These are negatively charged anionic glycoproteins. Basement membrane, already you know it has heparin sulfate, then it has other negatively charged molecules like collagen, okay, fibronectin, lamellin, okay, all this together are again negatively charged. Then while coming to podocytes, this nephrin is also negatively charged. So now when a fluid is getting filtered, when the blood is getting filtered at the glomerular capillaries, it is going to encounter negativity at every layer of this filtrating barrier. So that is why we are calling it as filtrating barrier. This barrier prevents the filtration of negatively charged proteins. That is why proteins are normally not found in urine. Now can you answer why proteins are not filtered? Because of this. Because of the negatively charged filtration barrier, proteins are not filtered. Okay. Second thing, what is nephrin? Again, very important question. Nephrin is nothing but a protein which bridges a gap between the podocytes by forming the filtration slit diaphragm. In patients of nephrotic syndrome, there is a mutation of the gene producing this protein, nephrin. So, in their urine, proteinuria will be there. Proteins will be present in their urine. Or any disease process which is damaging this layer is going to cause the basement membrane is going to lose its negativity. Proteins will be present in the urine. Okay. Now, next question. The components responsible for counter current mechanism in the kidney are all except. Okay. So, the moment you see except, you have to be extra cautious, extra careful. Okay. Now, let's see what is the, before going and answering this question, let us discuss the basic topic of mechanism of countercurrent mechanism. Once we are discussing this countercurrent mechanism, it will be easier to answer that question. So basically, other than the kidneys, where else do you see countercurrent mechanism? It is present in the kidneys, it is present in the scrotum, and it is present in the GI tract, okay, intestines. So these are all the areas where you will have countercurrent mechanism. So to label a mechanism as a countercurrent mechanism, what are all the prerequisites? First, there should be two tubes. Okay, so we have a tube A, we have tube B. So there are two tubes. Second, these tubes should run parallel to each other. Yes, these tubes are running parallel to each other. And they should be in closed proximity. They should be close, they should be parallel to each other. Then the inflow in one tube should be opposite to the flow in the other tube. So if the fluid is flowing in this direction towards down in tube A, the fluid will flow in the opposite direction in tube B. In the kidney, where do you see such a structure? What is the answer? Loop of Henle. So in the kidney, in the loop of Henle, we have such an arrangement. So the countercurrent mechanism, where does it takes place in the kidney? First, it takes place in the loop of Henle. Okay. Now, what are all the components of this countercurrent mechanism? We have the countercurrent multiplier, which is the loop of Henle. We have the countercurrent exchanger, which is a vasa recta. Vasa recta is nothing but the blood vessel surrounding it. Okay, in running close to the capillaries are the, running close to the loop of Henle surrounding it is the vasa recta. Okay, so vasa recta is the countercurrent exchanger, and then you have the equilibrating device. Juxtaposed to this loop of Henle, we do have the collecting duct, okay, which acts as the equilibrating device. Collecting duct acts as a equilibrium. Actually, it is a osmotic equilibrating device. Collecting duct is named as osmotic equilibrating device. Okay. Now the components are clear. This is also very important MCQ. What are all the components of countercurrent mechanisms? Usually you will say countercurrent exchanger and countercurrent multiplier, but osmotic equilibrating device is also a component of countercurrent mechanism, and that osmotic equilibrating device is nothing but the collecting duct. Okay. Now let us come to the interesting part. Okay. I hope it is clearly visible to you. How does countercurrent mechanism operate in the kidney? Okay, so how does countercurrent mechanism operate in the kidney? So before that, let me just have a sip of water. Okay, so now let us see the countercurrent mechanism. Listen carefully. What do you see here? On your left side, we are seeing the loop of Henle, right? So this green color structure is the loop of Henle. In this loop of Henle, we have the proximal convoluted tubule. The fluid that is coming from this proximal convoluted tubule, please help me. How will be the tonicity of this fluid, right? How will it be? Will it be isotonic, hypertonic, or hypotonic to that of plasma? Let me see if you are answering in the comment box. So this proximal convoluted tubule, the fluid that comes out of the proximal convoluted tubule is isotonic to that of plasma. Okay, isotonic fluid is coming out of the proximal convoluted tubule. This fluid travels down and enters into the descending limb of loop of Henle. Okay, descending limb of loop of Henle. If you have to understand countercurrent mechanisms, I want you to just remember 2 points. These 2 points will take you through this countercurrent mechanism. It will be a cakewalk if you remember these 2 points. What is it? Descending limb of loop of Henle, permeable to water. Okay. Then you have the ascending limb of loop of Henle. This is permeable to solute. That's all. These are the 2 key points. Descending limb of loop of Henle is permeable to water. Ascending limb of loop of Henle is permeable to solute. Or you can remember anyways. Descending is permeable to water. Ascending is impermeable to water. That ways also you can remember. But for the ease of understanding which is going to move out of that segment, I prefer you remember like this. Descending limb of loop of Henle, the thin descending limb of loop of Henle. To be more specific, thin descending limb of loop of Henle is permeable to water. The ascending limb of loop of Henle is permeable to solute. That's all. That is the key point you have to remember. Second is, what is the function of this countercurrent mechanism? What is the role or objective of the countercurrent mechanism? The countercurrent mechanism forms a concentrated urine. Okay, the major objective is countercurrent is what is the most important function? Concentrated urine. So if you want to have concentrated urine, if you want to form concentrated urine, first the medullary interstitium, the portion which is in between these tubules, that is called as medullary interstitium. So this is the medullary interstitium, this is the medullary interstitium, this is the medullary interstitium. So this medullary interstitium has to become hyperosmolar. Okay. This medullary interstitium has to become hyperosmolar. That means you have to increase the solute load to achieve this countercurrent, to achieve this concentrated urine. The medullary interstitium should be hyperosmolar. The solute load should be more. That is, solute should be added to the medullary interstitium. Okay, this is the second point. First point is the permeability. Remember the permeability, only about the loop of Henle. Okay. Then second point, remember that we want to make the medullary interstitium hyperosmolar. How can you make it hyperosmolar? By adding it solutes to it and by removing water from it. That much, right? Now we will start. The proximal convoluted tubule is there. Isotonic fluid is coming down into this loop of Henle. So as it comes into the descending portion of loop of Henle, what is happening here? Can you see? Passive diffusion of water. Passive diffusion of water. Where is it going? The water is going into the medullary interstitium. If this water stays in the medullary interstitium, what will happen? It is going to dilute this portion, right? We will come back to it later, but at least now remember to start with, as the isotonic fluid that comes from proximal convoluted tubule descends down into the descending limb of loop of Henle, water moves out of this. So as water keeps on moving out of it, what will happen to the tonicity of the fluid here? From isotonic, it is going to become hypertonic. Okay, so initially it was isotonic. Now it is becoming hypertonic. Why is it becoming hypertonic? Because the thin descending limb of loop of Henle is permeable to water. So water is leaving the tubule, water is leaving the tubular fluid and entering into the interstitium. So what is happening? The fluid in the tubule is becoming hypertonic. At the tip of the medullary, at the tip of the loop of Henle, it is more hypertonic, greater than that of the medullary interstitium. Okay, then what is happening? It is slowly ascending up. When it is ascending up, what is happening? You know, this ascending limb of loop of Henle, now the fluid is not isotonic, it is hypertonic. This hypertonic fluid is ascending up. As it is ascending up into the ascending limb of loop of Henle, what is happening? Since it is permeable, this portion is permeable to the solute. Now what is happening? See here, from this portion, solute is moving out. As it is going up, solute is moving out. And which solute is moving out? Sodium chloride. Okay, so now what will happen to the tonicity? The salt are getting removed. So as it goes up, it is becoming hypotonic, because the salts are getting removed from this fluid. Okay, so in the descending limb, water was removed. When it is ascending up, the salt is getting removed. And which salt? Sodium chloride. The sodium chloride also, this portion is the thin ascending limb and this is a thick ascending limb. Look at the arrows. Here it is a thin arrow, here it is a thick arrow. Here it is an active process. That is ATP is used. Here it is a passive process. The movement of this sodium chloride, here it is passive process. Okay, and whereas in the thick portion, the movement of sodium chloride is an active process. But by both ways, what is happening? Sodium chloride, the solute is added to medullary interstitium. So now what is happening in the medullary interstitium? The osmolarity will increase. The osmolarity of the medullary interstitium increases. Okay, so at least around 50% is done by sodium chloride. Can you see urea here? Yes. So sodium chloride contributes around 50%. The remaining 50% solute load to increase the medullary interstitial osmolarity, that is to make the medullary interstitium hyperosmolar, the remaining solute load is contributed by urea. From where do you get this urea? You see, what is this? Collecting duct. Okay, right, collecting duct. I told this collecting duct acts as an equilibrating device. Osmotic equilibrating device. So, see the outer cortical collecting duct, the medullary collecting duct, they are all impermeable to urea. Urea is impermeable to these regions. It is only when you are coming to the inner medullary collecting duct, movement of urea happens. Okay. Now this urea, where is it going? It is going into the medullary interstitium. When an osmotic active particle like urea moves out of the collecting duct, in the presence of antidiuretic hormone, water also moves out to maintain the osmotic equilibrium. Otherwise, what will happen? Here it will be hyperosmolar, here it will be hypoosmolar. To maintain this osmotic equilibrium, water is also leaving the compartment. When water leaves the fluid here, how will the fluid become? If water leaves, then what is happening? The fluid becomes concentrated. That is how the final concentration of urine is decided by the cortical collecting duct under the influence of antidiuretic hormone. So this one single line has so much of explanation. Okay, so the final concentration of urine is decided by the collecting duct under the influence of antidiuretic hormone. So now you have added urea, you have added sodium chloride, so the medullary interstitium has become hyperosmolar. But did you see in the starting, I told you we'll come back to it. Water has also got added to this here, right? Water was also added to this medullary interstitium. If the water stays here, what will happen? The water is going to dilute it. So the hyperosmolar medullary interstitium, which was multiplied by the effect of loop of Henle, will get washed off if water stays here. So to prevent this, we have the vasa recta coming into play. That is why vasa recta is called as exchanger. Multiplier is increasing the medullary interstitial hyperosmolarity. Exchanger is going to maintain it. Maintain the medullary interstitial hyperosmolarity. That is the function of the vasa recta. How is the vasa recta doing it? The blue color tube, what you are seeing here is the vasa recta. For vasa recta, this is the ascending limb. This is the descending limb. Okay. So here for your loop of Henle, this is descending, this is ascending. Whereas in vasa recta, look at, see, no confusion at all. Look at the arrows, you will understand it. This is the ascending limb. So this ascending limb, where it will go into the general circulation. Okay, what is present in the vasa recta? Actually, blood is present, right? And these are blood capillaries. So now, if you look at the vasa recta, what is happening? We will see vasa recta is doing two things. It is reabsorbing water and sends it to general circulation so that the extracellular fluid volume is maintained. The water that is getting diffused into the medullary interstitium will be immediately, see it is written here, water is removed by VR. So this water which is getting secreted here is immediately removed by the ascending limb of vasa recta, and this water goes into general circulation, and that is how the extracellular fluid volume is maintained. Okay, one of the ways. What about solute? For solute, what does the vasa recta do? The vasa recta is recirculating the solute. Okay, how is it recirculating the solute? You see, in the descending limb, sodium chloride and water is added in the vasa recta. Now, when it is ascending up, the same urea and the sodium chloride and urea, which was reabsorbed here in the descending limb, will come out through the ascending limb. So that is how it is recirculating the solutes. That is how vasa recta is recirculating the solute and maintaining the hyperosmolar medullary interstitium. Okay, so this is completes our entire discussion on countercurrent mechanism. Okay, now very little, one more topic in countercurrent mechanism. Now look at this picture. Same thing what we discussed. Okay, don't get scared that she's going to give a lengthy explanation again. No, only if you understand this, why so much of explanation was given, because once you understand this concept, it is going to become very, very easy. When they ask any question on acidification of urine, or when they give the single sentences like which among this is an osmotic equilibrium device and why, you will be able to answer it without any confusion. That is why this explanation was needed. Now, when we are looking at this picture, osmotic gradient across the medulla of the kidney, the same thing what I told you with some numbers, right? Look at the gradient from here as we keep coming down, as we keep descending down into the medullary interstitium, the color gradually becomes darker. From light orange, it becomes to dark yellow. Why? It is indicating that the interstitium is actually becoming hyperosmolar. So to start with from 300, it comes to around 1200 milliosmoles per kg of water. How this is achieved? That is what we just now saw with the help of the loop of Henle countercurrent multiplier. What I want you to see here is look at the difference. Anywhere you see, it is only a difference of 200. Okay, from 400, it slowly increases. Now you know, no, as water is leaving this part of the descending limb of loop of Henle, from 400, the osmolarity increases to 600, then it increases to 800, then increases to 1000, then to 1200. So in increments of 200 only, it is increasing. Why? Because that is a maximum capacity with which the system can move the solute, especially the active pump which is present in the thick ascending limb of loop of Henle. The maximum capacity is only 200 milliosmoles per kg of water. Okay. Now, okay, let's answer that question. We are going without answering that question. So what is the answer? The components responsible for countercurrent mechanism in kidney are all except. So they're talking about the components. Sodium outflow in the thick ascending limb of loop of Henle. Yes, correct. And also the sodium outflow in the thick ascending limb of Henle is an active process. Correct. Then water outflow in the thin descending limb of loop of Henle. That is also true. Sodium outflow in the thin descending limb of loop of Henle. No, it is impermeable to water. So this is the answer. This is a wrong statement. Okay, let us look at the fourth option also. Flow of tubular fluid from PCT to DCT. Yes, from the proximal convoluted tubule, it is going to the distal convoluted tubule via the loop of Henle. Okay. So that is with countercurrent. Then we are moving on to vasopressin. Okay. Vasopressin acts through which channel in the collecting duct? Direct question. Vasopressin acts through which channel in the collecting duct? First, you should know vasopressin is nothing but antidiuretic hormone. Here only I told you, know, under the presence of antidiuretic hormone, water will be reabsorbed, right? From the tubular fluid, the water will be reabsorbed into the cortical collecting duct. From the cortical collecting duct, the water is entering into the vasa recta, and that water goes into circulation. Now, can you understand and can you correlate? See, this portion only. The question is asking about this portion. Okay. The cortical collecting duct has some receptor which is going to reabsorb this water. That is why from the lumen, the water will go into the cell. That is what they are showing it as water is coming here. The water which has come here will be reabsorbed, taken up by the ascending limb of the, will come into the interstitium. From the interstitium, this water will be taken up by the ascending limb of your vasa recta and it will go into the general circulation. Okay. So now, what is that receptor which facilitates this reabsorption of water? By looking at all these four options, you know definitely GLUT3 and GLUT4 are not the answer. Then what is the answer? It should be either aquaporin 1 or aquaporin 2. So the one thing you should be clear is the water channels that causes reabsorption of water in the medullary collecting duct under the influence of vasopressin is aquaporins. Now, which aquaporin? Aquaporin 1 or 2? We have around 7 aquaporin channels, water channels. Okay. Each of them are present in different location. Please go through it when you have your time. Now, in this case, at least this you should know, it is vasopressin 2. The answer is, sorry, under the influence of vasopressin, it is aquaporin 2. How does it happen? Let us look at the mechanism of this vasopressin induced aquaporin upregulation. Okay. I hope it is I hope it is still visible for you. Okay, so now what is this cell? This is the epithelial cells of your collecting duct. Antidiuretic hormone or vasopressin is released. This vasopressin is going to act on the V2 receptor. V2 receptors is vasopressin receptors. Once this V2 receptor binds, antidiuretic hormone binds with V2 receptor, hormone receptor complex is formed. This hormone receptor complex is going to activate cyclic AMP. Activating cyclic AMP has two effects. Cyclic AMP increases the formation of protein kinase A. When protein kinase A is produced, it is going to cause formation of phosphoproteins, which is leading to formation of new proteins. So these new proteins are going to cause increased production of vesicles containing aquaporin 2 channels, and these aquaporin 2 channels get upregulated and they come and fuse with the luminal side of the cortical collecting duct, and they cause reabsorption of water. Okay, then what other effect of this ADH is, it also acts on the nucleus, causes gene transcription and leads to formation of new aquaporins. Okay, so that is with antidiuretic hormone. Then we have another graph. What is this? By looking at itself, you can say, what is this? What is this? Cystometrogram. So what we are seeing here is a cystometrogram. So this cystometrogram has different phases, right? So what are they asking? True statement. What is a true statement about the following figure? For that you have to first analyze the figure. Okay. For this first you have to analyze the figure. It has three phases. 1A, 1B and 2. Okay. So in the x-axis what do you have? Ideally when they give a picture like this, they should label the x and y axis. Okay. So in the x-axis you have volume of urine in milliliters. So this is intravesicular volume and this is intravesicular pressure in centimeters of water. Okay, so now when initially in this 1A, when the volume of urine goes from 0 to 50 ml, when there is a 50 ml increment in the urinary volume, the pressure increases around 10 centimeters of water. There is a linear increase in 1A. After that, what is happening? Look at 1B. This 1B is called as the filling phase. Filling phase of cystometrogram. Sir, so here what is happening? From this 50 ml, now the urine volume has gone up to 400 ml. So much of rise in volume. But there is no increase in pressure. No increase in pressure. Okay. On what basis can we explain this phenomenon? Normally, when the volume increases, the pressure will also increase, right? But here, so much of increase in volume, but the pressure remains the same. The pressure remains at the same 10 centimeters of water. Why? This can be explained based on the Laplace law. What does Laplace law say? So that means 1B can be explained by law of Laplace. Okay, so what does law of Laplace say? Pressure is equal to 2T by R. In a spherical structure, the pressure is equal to twice the tension developed by the divided by the radius. So our urinary bladder is a spherical structure, right? And the importance here depends upon the type of muscle. So the muscle in your urinary bladder is a unitary or single unit smooth muscle. It is a single unit smooth muscle. Now, smooth muscle has the property of plasticity. That is, they have the ability to adapt to a new length without much increase in the tension. So that is called as plasticity of the smooth muscle. Because of this plasticity of the smooth muscle, what is happening? When additional volume of urine is getting added, the smooth muscle is adapting to this new level without the smooth muscle is adapting to this new level without any increments in the pressure. So that is called as the filling phase, or that is the reason for this filling phase, or 1B. And the last is the phase 2. What is this phase 2? In this phase 2, there is micturition reflexes initiated. Okay, micturition reflexes initiated. Why micturition reflex is initiated? After a volume of 400 ml, the urge to urinate will be very high and the pressure sharply rises and micturition reflex will happen. What does this dotted line tell you? the inconvenience that happens to us when the urine volume goes to around 400 ml. Okay, so now look at all these 4 options and tell me which is the right answer here. Yes, option segment C. Option C, segment 1B represents Laplace law. So that is the right answer. Yes, segment 1B represent Laplace law. Okay, so here little bit of points what I want you to remember more is the first urge to void comes around when the bladder is filled around 150 ml, but this will get suppressed, and later only when the volume increases to as much as 300 to 400 ml, the reflex contraction will happen and that inconvenience will be felt. Okay. Okay, so we have one more question. Before taking a short break, we will complete this one more question in renal physiology and we'll take a short break. So what is this question? Identify the respective segments in the clearance graph. Again, a graph based MCQ. They are asking you to identify each of these substance. Okay, very easy. What are you seeing here? This is the Bowman space, this is a proximal tubule, this is a distal tubule, and this is the urine in the x-axis. On the y-axis, what are we seeing? Percentage filtered and the load remaining. Okay, so here they have given us 4 substances: inulin, okay, then you have glucose, then you have bicarbonate, then you have para-aminohippuric acid. So now they are asking you to identify which of these curve is for which substance. Look at A. What is happening in A? The substance is completely filtered. Bowman's capsule, right? It is completely filtered. Then it is not at all entering into the urine. That means it is completely filtered and reabsorbed. What is one substance among these 4 which is completely filtered and reabsorbed? Glucose. Glucose is an essential nutrient which is completely filtered at the glomerulus and it is reabsorbed. Only in pathological conditions like diabetes mellitus, when the blood glucose level exceeds around 180 to 200 milligram per deciliter, you will find glucose in urine. Otherwise, all the glucose will be reabsorbed. So, substance A is glucose. Among these 4 options, which is having A as glucose? Option B. Right? So that is the right answer. So this is how easily you can identify. But let us look at the other options. Now, B. According to this, what they are telling? Bicarbonate. Okay. Bicarbonate is a very important buffer. Now, this bicarbonate is secreted. Bicarbonate is also filtered and partially reabsorbed. So it is not fully reabsorbed. Some amount is reabsorbed and some amount is excreted in the urine. Depending upon the acid base status of the individual, bicarbonate can either be retained or it can be excreted in the urine. So that is why B is for bicarbonate. Okay. Then look at C. C is, by looking at the graph itself, you can say it is neither reabsorbed nor secreted. It is neither reabsorbed nor secreted. What is the such substance? Inulin. And finally, what is D? Para-aminohippuric acid. Okay, so this para-aminohippuric acid is filtered and secreted. Filtered and completely excreted in the urine. So this is PAH. This is inulin. This is bicarb. This is glucose. So the answer is option B. One more thing what I want to stress here is to measure GFR, we will use inulin clearance. To measure plasma flow, we will use para-aminohippuric acid, P for P. Para-aminohippuric acid, plasma flow, inulin you all know to measure GFR. So this completes our discussion on the renal physiology. We will take a short break and then we will move on to endocrine and reproduction.
Welcome back. Now that we are done with the renal physiology, we will move on to endocrine and reproduction. So what is this question? Again, a picture-based MCQ. Purposefully only here we have put a lot of picture-based MCQ so that you will get used to how to approach such questions and answer. Okay. So now, which type of signaling is shown in this picture? This is a very pretty easy question. Okay. So what type of signaling is happening here? Actually, the picture should be like this. Okay. So what type of signal is happening here? So the type of signaling which is shown here is it autocrine, paracrine, merocrine or endocrine? It is paracrine signaling. Okay, why? Let us look at the different types of signaling. What you see here, chemical substance is released from cell A, that is a hormone, which is emptied into the bloodstream, travels via blood to a distant organ, to cell B and brings about its action. Such kind of signaling is called as endocrine. Similar manner, only difference between the above and this is the what you see down is the cell which releases this hormone is a neurotransmitter. Okay, so sorry, not neurotransmitter, it is a neuron. The cell which releases this chemical substance hormone is a neuron. So when it is released, when a hormone is released from a neuron and when it circulates into the blood, we are calling it as neurocrine secretion. Endocrine, you know all the endocrine hormones. Examples. Can you tell some examples? T3, T4, growth hormone, prolactin, etc. For neurocrine, just now we discussed, no? Antidiuretic hormone. Okay, so these are all examples of neurocrine. Then paracrine secretion, that is what we identified here. That is, they act locally. Okay, they are not like hormones which go to a distant organ and bring about its physiological effects. They act locally and bring about their physiological effect. That is what is a paracrine secretion. From the hormone that is released from one cell will travel locally and influence the another cell, that is paracrine. Autocrine means on the own cell. Okay, example for this type of secretions is histamine, cytokines. These are all paracrine secretion released locally and act within the cells in the nearby area. Okay, all mediators of inflammation. Autocrine secretion. Okay, very important here. Autocrine secretion, the substance is secreted from the cell and it acts on the same cell. Okay, example, cancer cells. Okay, the chemical substances released from these cancer cells are going to promote their own growth. So that is examples of cancer cell. And regular cell, secretion of insulin. Secretion of insulin from beta islets. Okay, that is also an autocrine way of cell signaling. Okay, so is it clear? Different types of cell signaling. Okay, here one more thing. What do you mean by merocrine secretion? Merocrine secretion, examples for merocrine secretion is sweat, saliva. All these secretions are merocrine secretion. Here, the cell which is causing the secretion will not lose its vesicle nor its cytoplasm. By doing so, what is happening to the cell? The cell is able to sustain and give its products for a longer duration. So, such type of secretion is called as merocrine secretion. Okay. Now, a little bit more on different types of secretions. See, direct communication between one cell to the other happens via gap junctions. Neural communication happens via synapse. Endocrine communication happens via circulating hormone. Paracrine communication happens via locally released hormones. Autocrine secretion, hormones released from the same cell. Juxtacrine secretion is through growth factors expressed on the cell surface. Okay, so all these fancy words only are examiner's favorite. Juxtacrine communication is growth factors expressed on the cell surface. Neurocrine secretion is chemicals released at the nerve terminal. Okay, so that summarizes our discussion on cell signaling. And then we will move on to the next question. Which of the following hormone acts through an intracellular receptors?
Okay, so among these four hormones, they are asking which acts through intracellular receptors. So for that, first you should know classification of hormones. The classification of hormones based on chemical nature. Okay, based on their chemical nature, we have protein or peptide hormone. Okay, based on the chemical nature, we have protein or peptide hormones. We have derived steroid hormones, and we have derivatives of amino acid tyrosine. Acid tyrosine. Three, based on the chemical nature, three groups of hormones are there. Correct? The major chunk is formed by this protein or peptide hormones. Okay, we'll come to that later. What are all these steroid hormones? Very easy. Adrenal cortical steroids, sex steroids. What are the adrenal cortical steroids? Glucocorticoids, mineralocorticoids. Sex steroids are, what are those? Testosterone, estrogen, progesterone, and then another steroid hormone is vitamin D3. 1,25 dihydroxy active form of vitamin D3. Okay, then hormones that are derivatives of the amino acid tyrosine. Okay, so what are those hormones that are derivatives of amino acid tyrosine? T3, T4, and then catecholamines. What are the catecholamines? Epinephrine, norepinephrine, dopamine. So these are all derivatives of amino acid tyrosine. Then we have the peptide hormones or protein hormones. Okay, peptide hormone. When do you call as an hormone as peptide hormone? When it has less than 100 amino acid sequences. Okay, the length of the amino acid is less than 100, we call it as peptide. When it is greater than 100 amino acids, we call it as a protein hormone. Okay, so other than this, the rest of the major chunk are protein hormones like anti-repituitary hormones like LHS, FSH, ACTH, thyroid stimulating hormone, prolactin, antidiuretic hormone, insulin. Okay, somatostatin, then glucagon. Okay, all these are peptide hormones and many more. Okay, so now do you understand? Steroid hormones derived from cholesterol, then derivatives of amino acid tyrosine T3, T4 and different catecholamines. The rest of them are either protein in nature or peptide depending upon the amino acid sequence. Now, what we have to see is all those hormones that are protein in nature will act on the cell surface receptors. Okay, they bind to the receptors present for protein hormones. The receptors are present on the cell surface. After binding to the cell surface, hormone receptor complex is formed. So for a protein hormone, the receptor is on the cell surface. The receptor, the hormone binds to the receptors and form hormone receptor complex. This is going to activate G proteins. Activation of G protein is going to cause activation of second messengers. Second messengers is going to cause formation of protein kinase A, protein kinase C, or activate calcium, diacylglycerol, inositol triphosphate, various types of second messengers are there. They are going to cause activation of protein kinases, which brings about formation of phosphoproteins. Okay, formation of phosphoprotein is going to cause synthesis of new proteins. That is how it brings about its biological effect. It brings about biological effects. What? Protein hormone. So one important thing you have to remember is the receptor for protein hormone is in the cell surface. For steroid hormone and derivatives of amino acid tyrosine, okay, like mainly for steroid hormone and derivatives of amino acid tyrosine T3 and T4, and for steroid hormone the receptors are inside the cell. Inside the cell you have two components, nucleus and cytoplasm. Where will you find it? Only T3 and T4 act at the level of nucleus. So very easy to remember. Nucleus. T3, T4 are the only hormones that act at the level of nucleus. The rest of them, steroid hormones, are going to act in the cytoplasm. Okay. And these catecholamines, what are they going to do? They are going to act via the cell surface receptors, right? Now, what are all the hormones that is acting at the cytoplasmic receptor? As I told you, glucocorticoids, mineralocorticoids, testosterone, estrogen, progesterone, retinoic acid, and active form of vitamin D3, 1,25 dihydroxycholecalciferol. So all this will act at the level of cytoplasm. Only T3 and T4 will act at the level of nucleus. Okay. Now let us see which hormone acts through intracellular receptor. They have commonly told as intracellular receptor. That means inside the cell. They didn't ask whether it is in the cytoplasm or the nucleus. Okay. What is the first option? Thyroxine. So it acts at the level of the nucleus. So what is the answer here? Thyroxine. What about the remaining three? Glucagon, epinephrine, parathormone. All these are going to act at cell surface receptors. Right? Now, here is an exhaustive list of all the different types of second messengers and the hormones that are acting through all these second messengers. Okay. When you are having time, you can take this PDF and go through it once. But to simplify it and to remember the important second messengers, the enzymes that is activated by the second messengers, and the hormones I have given here, this table. This table we can go through it once now. See, norepinephrine and parathormone and norepinephrine acting via beta receptors activates the adenyl cyclase enzyme acting through GS. See, G proteins have three types of G proteins, GS, GI, GQ. In this, S and Q are stimulatory, I is inhibitory. Okay, so GS is going to form stimulation of adenyl cyclase. The second messenger is cyclic AMP. Norepinephrine acting via alpha 2 receptor, and for angiotensin 2, it is GI. The G protein is inhibitory, so it is going to inhibit the formation of adenyl cyclase enzyme. So the second messenger here would be a decreased cyclic AMP formation. Then when we are talking about antidiuretic hormone which acts through the V1 receptor and thyrotrophin releasing hormone, it is the GQ G protein that is getting activated. So this enzyme which GQ activates which enzyme? Phospholipase C. When phospholipase C is activated, what is the second messenger that is formed? Inositol triphosphate and diacyl glycerol. Okay. Then atrial natriuretic peptide and endothelium derived relaxing factors. What is this endothelium derived relaxing factor? Nitric oxide. Favorite question of the examiners. Nitric oxide acts through guanyl cyclase. And the second messenger is cyclic GMP. Very commonly asked. Okay. Rest, again important one. Insulin like growth factors. Okay. For them, the enzyme, they don't act via G protein. A different pathway. The enzyme they activate is insulin means, again important question of examiners, insulin activates or acts through activating tyrosine kinase and it produces phosphoproteins. Growth hormone and erythropoietin, again another important, they also don't act through G protein but they activate the JAK-STAT pathway. Which one? Growth hormone and erythropoietin activate JAK-STAT pathway. Okay. Then transforming growth factor alpha and other hormones, they act through serine and threonine kinase. This is not very important. Then we have T3, T4 which acts at the level of the nucleus. Okay. Norepinephrine, see, acts on the potassium channels. It causes either, see, this is a very important point. Norepinephrine acts on potassium channels. It can cause either an influx or efflux of potassium. Acetylcholine, these are ligand-gated ion channel, the membrane proteins, and they are going to act through increasing the intracellular calcium. Okay, so this you should remember. Rather than this exhaustive list, this is very important. Most of the important hormones and their second messengers are covered here. Now, which hormone acts via tyrosine kinase? What is it? Just now we saw tyrosine kinase means insulin. Okay. So next question here is, compared to minimal baseline levels of cortisol in the evening, rise in both ACTH, adrenocorticotropic hormone, and cortisol levels are likely to be seen when? Normally, the cortisol level is more in the morning, so that it prepares the person for the hectic day ahead. You have to be very active, very energetic. So the cortisol level rises in the morning, which helps us go through the activities of the day. And basically, it levels comes down in the evening, because in the evening you want to rest and finally go to sleep. So that is what they are saying, minimal baseline cortisol levels in the evening. But they are asking, identify the condition where ACTH and cortisol both are high. Normally, it has a feedback inhibition. Once the cortisol level increases, ACTH level will be decreased. But they are asking, identify one condition where both ACTH and cortisol levels are high. One condition where both are high is Cushing's disease. In Cushing's disease only, I am not telling Cushing's syndrome, I am telling Cushing's disease. In Cushing's disease, both ACTH and cortisol level is going to be high. What is the cause of Cushing's disease? Actually, Cushing's disease is a subdivision of Cushing's syndrome. In Cushing's disease, because of a pituitary adenoma which secretes ACTH, the levels of cortisol is going to be high. So both ACTH is also going to be high. Because of increased ACTH, more cortisol is also going to be produced. So what is the answer for this question? It is Cushing's disease. Okay. Now, here you can see some features of Cushing syndrome. Okay. So Cushing syndrome is what? Basically, excessive glucocorticoids in the blood. Because of this excessive glucocorticoids, what are the things we are seeing? Thinning of hair will be present. Moon-like face, the face becomes round, moon-like face and plethoric face. The patient is very dull, apathetic, and also the face is rounded because of the deposition of fat as well as swelling. Okay. And also we can see deposition of fat, abnormal deposition of fat. The fat is deposited in the interscapular region leading to buffalo hump, and also the supraclavicular clavicular pad of fat can be seen, and centripetal obesity because of the central distribution of fat. Because of the fat deposition, the skin is getting stretched, so there are purple striae. Okay, and there is proximal muscle wasting leading to myopathy and weakness. The skin becomes very thin, the capillaries are also very thin, so there is easy bruisability. Excess of cortisol causes bone reabsorption or bone demineralization leading to osteoporosis and compression fracture. Compression fracture is because the the spinal cord, the vertebrae get compressed. Okay. And then also it is very common to have fracture head of femur in case of excess cortisol. Okay, excess cortisol also causes disruption in glucose homeostasis leading to hyperglycemia. There is, because of excessive fat, there is hypertension, and peptic ulcer is also present. Okay, so these are all the salient features of Cushing's syndrome. Next question. Which among the following will be synthesized from the smooth endoplasmic reticulum? So endoplasmic reticulum, we have smooth endoplasmic reticulum and rough endoplasmic reticulum, smooth ER and rough endoplasmic reticulum. In rough endoplasmic reticulum, what is attached with this? Ribosome. In smooth endoplasmic reticulum, there is no ribosome. Okay. So smooth endoplasmic reticulum is going to secrete which one? Steroid hormones. Then rough endoplasmic reticulum is going to secrete protein hormones. Okay. Now tell me, steroid hormones, where is the receptors? The receptors are there in the cytoplasm. Protein hormones, where are the receptors? On the cell surface. Now coming to the next question. Aldosterone synthesis is stimulated by, aldosterone secretion is stimulated by. They have given 4 options. So before answering the question, we will see the discussion. Aldosterone is the major mineralocorticoids in the humans. Okay. 3 things are going to regulate the secretion of aldosterone. What are those? Angiotensin 2, adrenocorticotropic hormone, and plasma potassium concentration. Among these 3, the most potent stimuli for aldosterone synthesis is angiotensin 2. Okay. Closely followed by plasma potassium concentration. Okay. What does aldosterone do? It causes, most important function is sodium and water reabsorption and potassium excretion. Correct? So whenever the plasma potassium concentration increases, aldosterone will be secreted, or whenever the ECF volume decreases or the sodium chloride load decreases, aldosterone will be secreted. Okay. Now coming to the question here. So now you know what is the answer. It is stimulated by angiotensin 2. What is this PSH? It is nothing but prolactin stimulating hormone. Okay. So low potassium and high sodium are actually going to decrease decrease aldosterone secretions. Okay. Now let us see some common conditions where it increases and decreases. So aldosterone secretion is increased whenever you want the extracellular fluid volume and sodium chloride load to increase, or you want potassium to be excreted. Then aldosterone will be secreted. Right? So what are such conditions? Hemorrhage, hypovolemia, hyponatremia, hyperkalemia, standing for long, anxiety, physical trauma and surgery. Again, more potassium will be released, and secondary hyperaldosteronism. In all these conditions, aldosterone secretions will increase. Just the opposite. Increase in extracellular fluid volume, hypernatremia and hypokalemia. What will happen? The secretion will decrease. That is why these 2 options, hypernatremia and hypokalemia. Okay. Now, I already told you the functions of your aldosterone is sodium and water retention and potassium excretion. How does it bring about its function? Through their receptor. What is the name of the receptors? Mineralocorticoid receptor. What is the name of the receptor for aldosterone? Mineralocorticoid receptor. Specifically, the receptor has a name, NR3C2 receptor. This NR3C2 receptor is a mineralocorticoid receptor. Okay. Now, where are these receptors present? They are present in the collecting ducts, principal cells of the collecting ducts, in the distal tubule, in the collecting already collecting ducts I told you, collecting tubule, collecting ducts, distal convoluted tubule, sweat glands, salivary glands, intestinal epithelium. It is also present in the hippocampus, myocardial, muscle, and also blood vessels. Okay. But not in liver. This is an important point. They will ask you. They will give all these options and ask the receptor for aldosterone is not present where? Is absent in the liver. Okay. So now that is with what are all, we just know what did we see? We saw what are all the factors that increases the secretion of aldosterone, that decreases the secretion of aldosterone, different stimuli, important stimuli and different receptors, name of the receptors, different location where this receptor is present. Okay. Now we will see how this receptor bring about its function. What is the major function? I'll repeat it again. It is sodium and water reabsorption, potassium excretion. How does it do? Once aldosterone is synthesized, it is going to cause upregulation of a gene called as SGK1 gene. Okay, this SGK1 gene is nothing but serum glucocorticoids and potassium 1. Okay, so this kinase 1, serum glucocorticoid kinase 1. What is the name of this The name of this gene is serum glucocorticoid kinase 1. Once aldosterone upregulates the serum glucocorticoid kinase 1, that is going to activate the formation of something called as ENaC. ENaC is nothing but epithelial sodium channels. So once these epithelium sodium channels are upregulated, what will happen? Or this gene is going to cause the synthesis or formation of ENaC channels, epithelium sodium channels. Epithelial sodium channels are formed. These channels are going to cause sodium and water reabsorption. Okay. Next question. Insulin-like growth factor is secreted by which organ? Don't directly go and select pancreas. Okay. Insulin-like growth factor is produced in the liver. Okay. What is happening? Growth hormone will act on the liver and cause the synthesis of insulin-like growth factor. This insulin-like growth factor is also called as somatomedins because they have growth promoting effects. And this insulin-like growth factor is very important in fetal life because after birth, most of the skeletal muscle growth or growth of the skeleton is caused by growth hormone, directly by growth hormone or indirectly through production of insulin like growth factors from the liver. But in fetal life, growth hormone is not responsible for growth of the fetus. It is this insulin like growth factor IGF-1 and 2 which is important for the growth of the fetus. This is a key point what I want you to remember in this topic. Okay, next question. Tetany will result from which of the following disorders? Tetany, mainly what is the cause of tetany? Hypocalcemia. So we also call it as hypocalcemic tetany. So you can easily rule out these two options. Tetany will not occur when there is hypercalcemia. It will not occur when there is hyperoxemia, that is more oxygen. So either metabolic acidosis or respiratory alkalosis. Let us take respiratory alkalosis. What is the cause of respiratory alkalosis? Why do respiratory alkalosis happen? What happens in respiratory alkalosis? In respiratory alkalosis, because it is primarily due to what? Hyperventilation. As a result of hyperventilation only, respiratory alkalosis will happen. So, main thing in respiratory alkalosis is the carbon dioxide level in the blood is decreased. Okay. When this decreases in alkalotic conditions, what will happen is the pH is changing. Because of the change in pH, the albumin levels will be reduced. So basically in alkalotic conditions, we are talking here about respiratory alkalosis, but in general in alkalotic conditions, the availability of albumin will be less. And we know calcium is bound to albumin. So the level of ionic calcium, ionized calcium level decreases. Okay. Alkalotic condition, there is less calcium bound to albumin. This leads to decreased ionized calcium. So when the ionized calcium is less, it leads to hypocalcemia and tetany. Now, what are all the important features of tetany? We have something called a Chopstick sign. What is this Chopstick sign? Contraction of the facial muscle by tapping over the facial nerve. So when we tap over the facial nerve at the angle of the jaw, that side of the facial muscle is going to contract. So this is called as Chopstick sign, which is a diagnosing criteria for tetany. Next is Troisier sign. You would have seen this picture, right? Spasm of the upper extremity, which causes flexion of the wrist and extensions of the metacarpophalangeal and interphalangeal joints. So that is called as Troisier sign. Other than that, there is carpopedal spasm also. That is spasm of the wrist and ankle together is called as carpopedal spasm. Then there is laryngospasm, which is a very, very disturbing sign of tetany. Because of the laryngospasm, the patient might even die. Air entry is prevented because of the spasm of the larynx. Air is not going inside. Okay. Then in hypocalcemia, another very important thing what you have to note is the QT interval is prolonged. QT interval is prolonged because of the unavailability of calcium. So in hypocalcemia, QT interval is prolonged. In hypercalcemia, QT interval will be decreased. Very, very important MCQ. Okay. And there will also be a hyperphosphatemia in case of hypocalcemic tetany. Okay. Then we have a next question. What is this? Which of the following will cause a decrease in extracellular potassium concentration? So what are they asking? What decreases the extracellular potassium concentration? And let us look at this. This is a little tricky question. Let us look at the options. Is it lactic acid? Is it epinephrine? Is it glucagon? Or it is atropine? Okay. Normally when there is acidosis, what will happen? Potassium will be released into the bloodstream. So acidosis causes increase in potassium. Okay, hyperkalemia. Acidosis causes hyperkalemia. But lactic acid is little different. Okay, so lactic acidosis is associated. Normally, it is, please, this PDF, you have to make this correction. Acidosis is normally associated with an increased potassium levels. Okay, but in lactic acidosis, there is an intracellular shift of potassium, and this leads to hypokalemia. In lactic acidosis, there is hypokalemia. In generally in acidosis, there will be hyperkalemia. Specifically lactic acid, it is lactic acidosis, there is hypokalemia. Why? Because of the sodium potassium ATPase pump, which pumps the potassium ions into the cell, leading to hypokalemia. Okay. So their question is, what causes hypokalemia? So that means lactic acid could be one answer. Then you see, what about epinephrine? Epinephrine typically causes an increase in the extracellular potassium levels. Okay. Then what is happening is, initially epinephrine will cause an increase in the extracellular potassium levels, mainly by acting on the liver. Okay, so it will increase the extracellular potassium concentration, and also by acting through the beta adrenergic receptors. Later what it will do, it will cause the uptake of calcium back. Okay, it stimulates beta 2 adrenergic receptors in various tissue, including skeletal muscle, leading to a increased uptake of potassium from the extracellular space into the cells, causing a decreased ECF level. That means overall this is also going to cause hypokalemia. Okay, glucagon has similar effect. Okay, glucagon also causes hypokalemia with the similar mechanisms of epinephrine. Now let us look at atropine. Okay, what is atropine? Atropine is an antagonist of acetylcholine. So it is an anticholinergic drug. So now what does acetylcholine do? It normally stimulates the potassium release from the cell. So it will cause hyperkalemia. But now atropine is going to cause the opposite effect of acetylcholine. So what is atropine also going to do? It is going to decrease the extracellular potassium levels. Right? So that is also going to cause hypokalemia. So all four options are actually causing decrease in extracellular potassium concentration. So if you have to select one best answer from this, I would go with epinephrine. Okay. Then coming to reproductive physiology, simple question. Testosterone is secreted by which cells? Leydig cells. Okay, the Leydig cells of the testis secrete testosterone. What acts, which gonadotrophin acts on the Leydig cell and stimulates it to secrete testosterone? It is a luteinizing hormone. Okay, so luteinizing hormone acts on the Leydig cell, stimulates it to secrete testosterone. Then what about follicle stimulating hormone? We have two gonadotrophins like FSH and LH. You can see it here. So we have gonadotrophins, FSH. This gonadotrophin releasing hormone will act on the anterior pituitary, and that will stimulate the anterior pituitary to release FSH and LH. LH acts on the Leydig cells and causes them to secrete testosterone. FSH acts on the Sertoli cells. Okay, and that Sertoli cell secretes inhibin, which will inhibit FSH secretion. So Leydig cells, luteinizing hormone will act on the Leydig cells, and in response to that it will produce testosterone. Follicle stimulating hormone will act on the Sertoli cells and helps in the process of spermatogenesis. Also, under the effect of FSH, the Sertoli cells is going to produce inhibin, which is going to inhibit the FSH release from the anterior pituitary. Very important concept. Then what else? Functions of testosterone. It is a principal steroid hormone present in the testis. It is very important for male development. development of external as well as internal genitalia, and during fetal life it is very important for the descent of the testis. Okay. Now coming to the female reproductive hormone. The hormone predominantly secreted after the 14th day of menstrual cycle. So here in this picture you are seeing both the pituitary gonadotrophins like LSH and FH, sorry, pituitary gonadotrophins like LH and FSH, and also the ovarian hormones like estrogen and progesterone. Okay, let us number these hormones in their order. So the first hormone what you will see here will be the FSH. Okay, so as FSH is released, once FSH, so what are you seeing here? This is the pre-ovulatory phase. This is the post-ovulatory. Or to be more specific, what will you, how will you name it in case of menstrual cycle? What will you say? This is the proliferative phase. This is the ovulation. This is the secretory phase. Or another name is, this is the progestational phase. This is the estrogen phase. Okay, all these are the same. So what happens during the first half of the menstrual cycle is, the first hormone to increase will be your follicle stimulating hormone. As the FSH level increases, what will happen? As the FSH level increases, here you can see the ovarian follicles are growing. Okay, as the FSH level increases, the ovarian follicles are growing. As the ovarian follicles are growing, it is going to secrete the second hormone, that is the estrogen. As the ovarian follicles are growing, they secrete estrogen. So as the follicles are growing, the estrogen levels are also increasing. Okay, after the estrogen levels have increased, what is happening? Suddenly the luteinizing hormone, which has been at the basal level, by day 14, day 3 to day 14, the level of estrogen is going up. This is sorry, the level of luteinizing hormone is going up. This is called as LH peak. LH peak or LH surge. Okay, so as the level of, so the third hormone to increase will be your luteinizing hormone. As the luteinizing hormone increases, what is happening here? Ovulation happens on day 14. After ovulation, what is happening to the LH level? The LH also comes to baseline. FSH is also reducing, because why? Already once the follicle has attained its complete growth, the mature graphene follicles is formed, FSH has no role. So the FSH levels is also coming down. Once LH surge has happened, ovulation has also happened, again LH levels are also coming down. So the anterior pituitary gonadotrophins are mainly active during the proliferative and the ovulatory phase of the menstrual cycle. Now, last hormone, we already saw estrogen increases during the which phase? Proliferative phase. That is why under the effect of estrogen, there is proliferation of the endometrial tissue. The endometrial layer increases and also the endometrial glands are all increasing in number, right? Now, afterwards, what is happening? The estrogen has increased. Okay. Then following it, ovulation has happened on day 14. After that, what will happen? The corpus luteum is formed. Okay, corpus luteum is formed after ovulation. The corpus luteum, which is formed after ovulation, what is this most important? It secretes progesterone. See, the follicles will secrete estrogen. The corpus luteum will secrete progesterone. So, to answer our question here, the fourth hormone to be secreted is progesterone, and this progesterone continues to rise, and it will be maintained at a higher level if pregnancy occurs. If pregnancy doesn't occur, then by the end of 26 or 27 day, the corpus luteum degenerates and progesterone level also comes down along with the estrogen, which has already come down. Okay, so all these hormones are withdrawn. It is going to result in uterine bleeding. So what is our question here? What hormone is predominantly secreted after day 14? After day 14, it is always progesterone. Why? Because if pregnancy occurs, progesterone is going to give nourishment and growth to the growing fetus until the placenta comes and takes over. Another thing, once ovulation has happened, this half of the thing, the secretory phase is always 14 days. It is fixed. It is only the proliferative phase which is variable. Okay, the length of the secretory phase is always the same. Okay. Now, next question. Highest level of prolactin are seen during. Okay, highest levels of prolactin are seen during when? What is prolactin? Prolactin is the major hormone for milk secretion, right? And what is the pathway by which prolactin can act? JAK-STAT pathway. Okay. Can you remember any other hormones we just now discussed with JAK-STAT pathway? Yes, you can put it in your chat box. What are the hormones that acts through JAK-STAT pathway? Yes, growth hormone, erythropoietin. And then now you also have prolactin which is acting through this JAK-STAT pathway. Okay, now highest prolactin is seen during when? Lactational phase, REM sleep, 1 hour of walking, or 24 hours after delivery? The answer is very obvious, 24 hours after delivery. Coming to sleep, when will you see prolactin? Usually we say breastfeeding mothers, feed your baby at night time. It causes increased secretion of prolactin, right? So when during sleep? It is during the NREM sleep or the deep wave sleep that the prolactin levels are very high. Okay, so what does this prolactin does in female? It causes hyperplasia of the breast tissue, increases the lobules in the alveoli of the mammary gland, okay, and it also causes lactational amenorrhea by inhibiting ovulation. That is why in breastfeeding mothers there is lactational amenorrhea, protection against pregnancy. It is highest, as I already told you, after 24 hours after birth. Coming to males, what does prolactin do? It is important. Prolactin decreases spermatogenesis. What does it do? Prolactin decreases spermatogenesis. Now some certain drugs, L-DOPA. Okay, this can cross blood-brain barrier. It decreases the prolactin release by forming dopamine. So they are antagonists. Dopamine is antagonist of prolactin. That is why L-DOPA decreases prolactin release. Then we have bromocriptine, which is a dopamine agonist. Agonist means what it is going to do? It is inhibiting prolactin release by stimulating dopamine receptors. Sorry. Bromocriptine is actually, what is it going to do? It is going to inhibit the prolactin release by stimulating the dopamine receptor. Okay. Then we have chlorpromazine. Okay, what is it going to do? It is going to enhance the prolactin release by blocking the dopamine receptor. Okay. So now that completes our discussion on endocrine and reproductive system. Now let's move on to our last topic and final and the most important topic, central nervous system. Okay. Okay. So what is the first question? What is the location of Meissner's corpuscle? What type of corpuscle is Meissner's corpuscle? It is the touch receptor. Meissner's corpuscle is a touch receptor. Okay. And this Meissner's corpuscle is present in the superficial layer of the skin. This is present in the superficial layer of the skin. Another important point about this Merkel's corpuscle is it is a rapidly adapting touch receptor. And finally, this receptor is numerously found in the lips, fingertips, okay, on the skin. All these are important sites where Meissner's corpuscles are present. Okay. So with this background, now you tell me, where is it located? It will be located in the papillary dermis, because papillary dermis is a superficial layer of the skin. Now, little bit about receptors. What are receptors? They are basically transducers that is going to convert various forms of energy into action potential so that the sensory neuron can carry them into the somatosensory cortex where they can be interpreted, right? We have we can classify receptors into two types: exteroreceptors and interoreceptors. Exteroreceptors are what? Which is present on the outside in the skin or in your superficial layers. Okay, interoceptors are the one which is present inside the body. Exteroceptors are one which is present on the outside layers of the body. Exteroceptors are again classified into three types: cutaneous receptors, chemoreceptors, and telereceptors. Chemoreceptors are what? Receptors for taste and smell. Smell is the olfactory receptor. For taste, it is the taste bud. Okay. Then we have telereceptor. Telereceptor mean distant receptors. The stimuli is at a distant. The stimuli it as a distant. For example, for vision, the light is coming from far, and the receptors are for this is rods and cones in the retina. Similarly, for hearing, it is the hair cells in the organ of cortex. So these are examples for telereceptors. Most important, lot of questions keep happening. The lot of questions they keep asking is from the cutaneous receptors. What are these cutaneous receptors? They are again divided into so many different types: touch receptors, pressure receptors, cold, thermoreceptors, cold and warmth, and pain receptors. For pain, we all know it is a free nerve ending, right? For warmth, it is a Ruffini end organ. For cold, it is the Krobs end bulb. For pressure, PP, Pacinian corpuscle. And for touch, it is the Meissner's corpuscle and Merkel's disc. Actually, for touch, we have 4 receptors. Okay. Two receptors are located superficially and 2 are located deep. Meissner's corpuscle and Merkel's disc. Okay. And then Krobs end bulb and Ruffini end organ. Okay. So these are deep receptors. And okay. Clear? Now coming to the next question. Golgi tendon organ is responsible for regulating. So what is your question? What is the function of Golgi tendon organ? Golgi tendon organ is responsible for regulating. We have only two things, right? We have muscle spindle and Golgi tendon organ. Muscle spindle is for, what is it? Length of the muscle. Okay. And rate of change of this length. Muscle spindle will detect length of the muscle as well as the rate of change in this length. Golgi tendon organ is going to detect muscle tension. Okay. So what is the answer here? Golgi tendon organ is responsible for regulating muscle tension. Okay. So the same difference what I told you is written here. Okay. You can go through it later. Location. Okay. So where is muscle spindle located? Deep inside the muscle. Okay. Where is Golgi tendon organ located? In the tendon. Okay. Muscle spindle, how is it located? Parallel to extrafusal muscle fibers. Whereas Golgi tendon organ, how is it located? In series. Okay. Okay, here you can see the structure of a muscle spindle and location of a Golgi tendon organ. You see this is the extrafusal fibers, that is the skeletal muscle fibers. Okay. Deep into the skeletal muscle fibers, this yellow portion is your muscle spindle. It is located parallel, and this muscle spindle is attached either to the ends of the skeletal muscle or to the tendon. Now look at the structure of Golgi tendon organ. It is located in series in your tendon. The primary afferents supplying the Golgi tendon organ is 1B, whereas in your in case of your muscle spindle, it is 1A and type 2. Okay, we will shortly see that. Okay, because this muscle spindle is again two types, right? Nuclear, what is this? Nuclear bag fibers. Then one more thing you have, nuclear chain fibers. Okay, so this primary 1A afferent is supplying both nuclear bag and nuclear chain fibers. Then you have type 2, which is supplying only the nuclear chain fibers. These are the afferents for muscle spindle. What about the efferent for muscle spindle? Efferents. Well, the efferents for muscle spindle are the alpha and gamma motor neuron. So for muscle spindle is the gamma motor neuron for both nuclear as well as the nuclear bag fiber and as well as the chain fiber. The efferent is gamma motor neuron. And additionally, you also have the beta neuron. Okay, so beta fibers, it is not very important. Please remember the gamma motor neuron. Okay. Okay, so now before going into the next question, let us take a short break.
welcome back. Let us continue our further discussion on the central nervous system. So here we have a question asking us to identify the phase of EEG. Okay, so what do you mean by EEG? EEG is the electroencephalogram, the record of the electrical activity of the brain, right? Especially the cortex. Now, the waveform, generally EEG waves, what are the different types of EEG waves? We have 4 different types of EEG waves, actually 5, but important ones are 4. We have the beta wave, the alpha wave, the theta wave, and the delta wave. Okay, so what are the 4 importance wave? Beta, alpha, theta, and delta. Why have we named it like this? Why are we starting from beta and moving to delta? Depending upon their frequency. So beta wave has the highest frequency, delta wave has the lowest frequency. So EEG waves, 4 types of EEG waves are there: beta, alpha, theta, and delta. Among this, beta wave has a frequency of greater than 14 hertz or 14 cycles per second. So it has the highest frequency. Delta waves have the lowest frequency. Okay, that is why delta waves are also called as deep, not because of the lowest frequency. Delta waves are present during deep sleep. So delta waves are also called as deep sleep waves. Okay, now this beta, as we go, so for beta wave, the frequency of beta wave is around 14 hertz. The frequency of alpha wave is around 18 to 13 hertz. It keeps decreasing. The theta wave further decreases 4 to 7 hertz, and finally delta waves are the lowest frequency of 3 to 5 hertz. So which EEG wave has the highest frequency? Beta wave. Which EEG wave has the lowest frequency? Delta wave. Now, amplitude is just the opposite. The wave which has the highest frequency has the lowest amplitude. The wave that has the highest amplitude has the lowest frequency. That means delta wave has lowest frequency, highest amplitude. These two you have to remember. Very important MCQ question. Next, that is with their frequency and amplitude. So we are categorizing the EEG waves based on their frequency and amplitude. Next, from where do we record and when do we find such waves? That is the next thing you have to see. Okay. So coming to beta waves, already I told you, delta waves are recorded during deep sleep. Delta waves are recorded during deep sleep. Then coming to beta wave, when will you see beta wave? 2 conditions. One, when the person is awake. Second, when the person is in his REM phase of sleep. Okay, that is his light sleep. Delta waves, high amplitude, low frequency during deep sleep. Beta wave, high frequency, low amplitude when a person is awake and alert. Okay, just the opposite. So beta wave when a person is awake, when a person is alert, when they are doing complex mathematical calculations, all these things you will be able to record beta wave. Okay, from which region? Parietal region, frontal region mainly. Okay, now alpha waves. When will you record alpha waves? The person is drowsy or the person has not gone into sleep. The person is awake, his eyes are closed. Very, very important. Alpha wave, the person has to be awake. At the same time, the eyes should be closed. Once the eyes are open, alpha desynchronization will happen. So just remember, alpha waves, when a person is awake in quiet resting state with eyes closed. These are the key words you have to see. Eyes are closed, he is quiet, he is resting, and he is not asleep. That is alpha wave. Theta waves is usually, alpha waves are recorded from the parieto-occipital region. Theta waves are usually recorded from the hippocampus as well as in parietal and temporal region, normally in children. And in adults, whenever they are depressed, whenever they are disappointed, whenever they are frustrated, whenever they are in any kind of emotional stress, then theta wave will be recorded. Okay. Then delta waves is mainly recorded from cerebral cortex and from thalamus. You already told you delta waves is during deep sleep. If a person is awake and you still you're recording delta waves means because of serious organic brain damage. In those conditions also delta waves are seen other than deep sleep, not when a person is awake. Other than deep sleep, if you're recording delta wave, then it means some serious organic brain damage. Okay, now we have seen the different types of waves. Let's go back to this. Okay, so here they are asking you which phase is shown here.
Okay, so this type of wave is actually beta wave. Okay, that is high frequency, low amplitude, or sometimes you can even say mixed frequency, high or mixed frequency waves with low amplitude. So these are all beta waves. Okay, so when do you see beta wave? I told you, no, beta wave is seen either when a person is awake or when a person is in rapid eye movement sleep. So the answer here is rapid eye movement sleep. Okay, so now since we are having this rapid eye movement sleep discussion, we should know what are the different types of sleep. NREM sleep, REM sleep. REM means rapid eye movement sleep, also called as paradoxical sleep. NREM sleep is also known as slow wave sleep. Okay, so REM sleep is called paradoxical sleep because all the features that happen during REM sleep will mimic when the features of when a person is awake. Only when you are awake, I told, beta waves will be seen, rapid eye movements will be seen. So all these things are seen during REM sleep, but the person is asleep. And even the physiological changes, like there will be increase in blood pressure. Normally when we are there in NREM sleep, all our physiological functions will come down by 20%, but during REM sleep all the physiological indices will go back to normal levels. So that is why REM paradox. So REM sleep is also called as paradoxical sleep. One very important feature, how will we tell that when everything is looking like awake pattern, how will you know, or how will you confirm that this person is not malignaring, he is not acting as if he is sleeping, he is truly in his REM sleep? There will be muscle hypotonia. Along with all features, when you see muscle hypotonia, then you know for sure it is the person is in REM sleep. Okay. So now let us see the classical features of REM sleep. Okay, REM sleep is a light phase of sleep, but still arousal is difficult. Okay, here you can see mixed frequency wave. So what we saw here is actually a mixed frequency wave. Okay, which is low in amplitude, especially beta waves. Okay, this is also called as desynchronized or paradoxical sleep. Dreaming occurs in REM. See, dreaming actually occurs both in NREM sleep and REM sleep. Dreaming occurs both in NREM sleep and REM sleep, but it is the recall of these vivid dreams, that is, the person is able to remember the dreams during that happened during REM sleep. Okay, and dreams are associated with muscle activity to prevent a person from enacting the dreams. That is why there is muscle hypotonia, which happens during NREM sleep. Normally, NREM sleep occupies 20 to 30% of the total sleep cycle. Autonomic activities will be increased. Already I told you, BP, everything will be looking as if the person is awake. What are all the sleep disorders that will be present during REM sleep? Nightmares are common in REM sleep. Night terrors are common in NREM sleep. Narcolepsy, nocturnal penile tumescence, all these three are REM sleep disorders. Okay. So to summarize, REM sleep is the one where rapid eye movements are there. It is paradoxical because it looks as if the person is awake. There is only muscle paralysis, which is going to total muscle hypotonia, which is going to tell us that the person is in REM sleep. Okay, increased autonomic activities will be seen in form of increased heart rate and increased blood pressure. Now coming to NREM sleep. NREM sleep actually has three stages. Okay, N1, N2, N3. Earlier classifications were telling it as stage 1, 2, 3 and 4. Now stage 3 and 4 has been merged to stage 1. Stage 1 is the light sleep, predominantly theta wave. Stage 2, the hallmark of stage 2 is sleep spindles and K complexes. Very, very important. Hallmark of N2 or stage 2 is sleep spindles and K complexes. Sleep spindles is something which will look like this. Burst of, oh God, burst of electrical, sorry, sleep spindles are nothing but burst of electrical activity. So this is This is how sleep spindle will look, lasting for less than 0.5 seconds. Okay, burst of electrical activity lasting for 0.5 seconds. This is sleep spindle. K complex is a biphasic wave. Okay, so this is a K complex. K complex is a biphasic wave. This is also going to last less than 0.5 seconds. When you see under a regular wave, when you see in this background, when you see the sleep spindles and K complexes, definitely the person is in NREM stage 2. Another very important feature about NREM stage 2 is the major portion of the sleep cycle is occupied by this NREM stage 2 sleep. Another very important feature is what is physiological basis for these K complexes and sleep spindles. These K complexes, occurrence of these K complexes and sleep spindles is giving us evidence that memory consolidation is happening. Whenever memory consolidation happens, K complex and sleep spindles are seen to be recorded from the EEG. Okay, so these are some latest information. Stage 3 of sleep is called as the deep sleep. What is the wave which will come? Delta waves. When more than 50% of the epoch is occupied. What do you mean by epoch? When we are analyzing a sleep study in a polysomnography, one epoch is a duration of 30 seconds. So in that 30 seconds, when more than 50% of the epoch is occupied by delta waves, then we call it as N3. Okay. Then as I told, dreams occur both in NREM and REM sleep, but the dream that occurs in NREM sleep, we don't remember it. So NREM sleep can also be called as dreamless sleep. Now, what are all the disorders that happens during NREM sleep? That is important. Sleepwalking, somnambulism, sleep talking, somnolaki, night terror, bruxism, that is tooth grinding, and nocturnal analysis, bedwetting. All these are disorders of NREM sleep. So they can ask you, following or REM sleep disorders except, or identify the REM sleep disorders from the following, or identify the NREM sleep disorders from the following. Mostly between nightmares and night terrors. Night terror is an NREM. Nightmare is an REM. Okay. Okay, next question. Alpha waves are seen during. When do you see alpha waves? When the person is active? No. Beta wave. REM sleep? No. When he is asleep? No. When the person is relaxed? Another one feature is eyes closed. Okay, that is when you see alpha waves. Okay, now with next question about hypothalamus. Which of the following event occur during the phase B to raise body temperature to the hypothalamic set point? So again, another graph based MCQ. Right here, what we are seeing is the alteration in the hypothalamic set point for temperature. Once the hypothalamic set point for temperature is getting altered, what is the response that is happening during phase B? That is what they are asking. Is it shivering, sweating, the decrease in thermogenesis, or cutaneous vasodilation? Okay, this is very easy to interpret. Just look at it. The same thing here. What is this in degree? On your y-axis, you have the body temperature. Here you have the time in hours. Now, normal body temperature is, how much is a normal body temperature? 98.8 degree Fahrenheit. So that is the normal set point. This is the normal set point. Normal hypothalamic set point for temperature in hypothalamus. Okay, this is clear. This is a normal. If I have to say in degrees Celsius, 37.1 degrees Celsius. Fine. Now what is happening? Suddenly some stimuli, okay, or some factor has shifted. Suddenly some factor has shifted the hypothalamic set point to 103 degree Fahrenheit. From 98.8 degree Fahrenheit, it has shifted. Some factor has shifted the hypothalamic set point to 103 degree Fahrenheit. Okay. Once this hypothalamic set point is shifted to 103 degree Fahrenheit, from here, once it is going to shifted here, some changes are happening. That is what they are asking. What are all the changes that will happen? Okay, see what are all the changes here happening? All features, whenever you are exposed to cold environment, what are all the changes that will happen? All those changes are happening, like vasoconstriction, piloerection, epinephrine secretion, shivering. All this is happening when the hypothalamic set point has increased to 100 degree Fahrenheit. Why all these things should happen? Because normal set point is 98.8. Now suddenly some factor is coming and increasing it to 103. So what is the temperature of the blood? It is now going to be 98.8 only. So now, so whatever changes will happen when you're exposed to a cold environment, to raise, why in cold environment, what are the changes will happen? Changes to increase the body temperature will happen. The same changes will happen now. Why it is happening now when you're not exposed to a cold environment? We are not, the body is not exposed to the cold environment, but the hypothalamic set point has gone to a higher level of 103. Now to raise the body temperature, all these mechanisms are happening, like shivering, piloerection, epinephrine secretion, and vasoconstriction. So by doing all these things, what is happening? The temperature increases, the core body temperature increases, and now goes to the newer set point of 103 degrees Celsius. What will happen to the subject? He will not experience any discomfort until and unless the stimuli which cause the resetting of the set point is present. Okay, until and unless the stimuli or the factor which cause this resetting to a higher level is present, nothing is going to happen. The person is not going to feel anything. But when this stimuli is removed, okay, so in B, what is the answer here? Shivering. Answer A. Okay, shivering. Now the set point, the factor that has brought it to this 103 degree Fahrenheit, it is removed. Once the factor is removed, the person is going to experience certain changes. That is called as crisis. Okay, so this is called as crisis. Now what will happen? The factor is removed. The hypothalamic set point is again going to come back to its normal 98.8 degree Fahrenheit. So how will it come back to normal 98.8 degree Fahrenheit? Whenever you are exposed to a hot environment, to dissipate the extra heat, what are all the changes that will happen? Vasodilation and sweating. So these things will bring back the temperature to the normal low value. So that is how we are going to interpret this graph. Very easy. Fine. So before the advent of antibiotics, okay, one extra information. So before the advent of antibiotics, physicians will be waiting for this crisis to happen. Physicians who are treating their patients with infection, they will be waiting for this crisis to happen. Why? Because when they know crisis happens, that means the infection has subsided. The fever is going to come down. The subject is going to recover. Okay. Next question. A laborer becomes unconscious. A laborer, okay. The occupation is very important. Becomes unconscious and it is brought to the emergency room with a temperature of 105 degrees Fahrenheit and decreased skin turgor. Decreased skin turgor means the skin has lost its elasticity. When will the skin turgor decrease? It will decrease when there is dehydration. So you know he is dehydrated. Okay. What is not seen in this patient? Among the four, one feature is not seen in this patient. Now, what is the diagnosis of this patient? It is pretty clear. What is it? He is having heat stroke. The subject is having heat stroke. Why? Because he is a laborer. He is working extensively. So much of physical activity will be there. The physical activity with raised temperature is predisposing him to heat stroke. Okay, we are seeing that he is dehydrated also. So what are all the classical signs and symptoms which is present in heat stroke? It is a life-threatening medical emergency where the body temperature typically goes above 100 degree Fahrenheit or 40 degrees Celsius because of prolonged exposure to hot environment, and also it will be exacerbated or it gets predisposed when the person is also doing extreme physical activity. What are all the features? High temperature will always be their hallmark, and then altered mental state will be there. They will be confused, they will be delirious, and sometimes even unconscious. So this subject is unconscious, right? What else? Skin turgor is reduced, I told you, because of dehydration. lack of sweating is a hallmark of heat stroke. Okay, lack of sweating is an hallmark of heat stroke because the classical heat dissipating mechanisms will come to an halt. That is why the patient goes into heat stroke. That is why, what is the answer here? What is not seen? Sweating is not seen. So answer here is option C. In heat stroke, sweating is not seen. Okay, next you have a question. A patient had a penetrating cervical neck trauma piercing the lateral aspect. What is it? Cervical neck trauma, lateral aspect of the dorsal column tract. Which of the following findings are seen? Now tell me, what type of tract is dorsal column tract? Ascending tract, correct. Okay, ascending tract. So it's the sensory tract. What are all the sensations it carries? It carries proprioception, it carries fine touch, it carries vibration, it carries 2-point discrimination, it carries tactile localization, and most important, stereognosis. Okay, so all these are the sensations that is called by dorsal column pathway. Another name for this dorsal column, posterior column also they will say, or medial lemniscal pathway. All these are the names synonymous with the dorsal column pathway, and these are the 6 important sensations that is carried by this. Okay, now what are they asking is, which of the following findings are seen in this patient? After the injury, what is the finding in this patient? So before that, I already told you the sensations that is carried by this dorsal column pathway. These sensations that is carried by the dorsal column pathway will go through two fasciculi. Okay, that is the sensations from the upper half of the body will be carried through cuneatus fasciculus. Okay, the sensation from upper half of the body is carried through cuneate fasciculus, and the sensations, all the sensory information from lower half of the body is carried through gracile fasciculus. Okay, that is why you are seeing two lines, the red and the green line. Okay, now you tell me which is lateral and which is medial. Okay, so which is lateral? The cuneate fasciculus is lateral. Okay, cuneate fasciculus is for upper limb, so that is lateral. Gracile fasciculus is for lower limb, so that is occupying the, this is medial portion, this is lateral portion, right? So this is medial portion, this is the lateral portion. So the upper limb is occupying the lateral portion, the lower limb is occupying the medial portion. Okay, then they are ascending up. They do not cross over in the medulla, they do not cross over in the spinal cord. They ascend up, go to the medulla, synapse with their respective nuclei. Upper limb fibers will synapse with nucleus cuneatus, lower limb fibers with synapse with nucleus gracilis. Then they will cross over to the opposite side in the medulla, continue as medial lemniscus pathway, go and synapse with the thalamic nuclei, and then project to the sensory cortex. This is a pathway, right? Now you tell me, there is a trauma to the lateral aspect. The moment I say lateral aspect, what is gone? Lateral is upper limb sensations. Okay, which of the following findings are seen? So one thing you should be clear is, rule out the lower limb. It is not lower limb. Okay, so you are ruling out the lower limb. Then you have two more options: absence of ipsilateral proprioception of the arm, absence of fine motor movements of the arm. This also easily you can roll it out. Motor movements is not the function of a sensory tract. Motor movements is function of the corticospinal tract. This is for corticospinal tract lesion. Okay, so the answer here is A, absence of ipsilateral. See, you know, no, proprioception is the function of the ascending tract on the same side. Why or not on the opposite? Arm, you are clear. Laterally means it is arm, that is fasciculus cuneatus. Okay, then why ipsilateral? Because the crossing over for dorsal column is happening in the medulla. It is not happening at the spinal cord level. So here the injury is at the cervical level. That is why ipsilateral proprioception of that arm is lost. So that is the answer. Okay, another question. Neurological examination of a patient reveal the following signs and symptoms. He has diplopia, tingling and numbness in the lower extremities, and it gets worse upon taking a hot bath. Which of the following cells are involved here? Okay, all these clinical features are consistent with a demyelinating disorder, namely multiple sclerosis. Okay, so in multiple sclerosis, there is demyelination. Now, among these, all these are neuroglial cells. Okay, all these are neuroglial cells. Among these neuroglial cells, which of the neuroglial cell lays down myelin sheath? That is what you have to identify. Pretty direct answer. What is it? Oligodendrocyte. Oligodendrocyte is responsible for myelination in the central nervous system. Then, in the peripheral nervous system, it is the Schwann cell. Schwann cells for myelination in the peripheral nervous system. Ependymal cells, what is it? It is lining the ventricles, has some role in CSF formation. Okay. Astrocytes, star-shaped cells. Okay. Astrocytes are star-shaped cells. What is the function of astrocyte? It forms the blood-brain barrier. Microglial cells, the smallest of glial cells in the central nervous system. What is its function? Phagocytosis, because they are derived from blood monocytes. Okay, clear? And another thing what you have to remember is glial cells are only supporting cells. They outnumber the neurons. For every one neuron, there are about 10 to 30 neuroglial cells. The most important functions of neuroglial cell is to provide support, provide metabolic, provide support, both in case of skeletal support as well as metabolic support. It secretes trophic factors which causes the nourishment and growth of the neuron. Microglial cells, not just microglial cells, glial cells have the ability to divide, whereas neurons doesn't have the ability to divide. They don't undergo mitosis. Another feature differentiating between neuroglial cells and neurons are the neuroglial cells cannot transmit action potential, only the neurons can transmit action potential. All those tumors in the central nervous system are basically because of the excessive proliferation of these neuroglial cells. Neurons are not responsible for the tumor. Central nervous tumors are mainly because of these tumors of neuroglial cells. That is why they have the name as gliomas. Okay? Because the neurons, they don't have centrioles, they don't have centrosomes, they don't undergo mitosis. Okay. Now coming to the last question of our today's life. Very, very easy. Arrange the following components of pathway in the correct sequence. Many times they keep asking this question on auditory pathway. Okay. So in ascending order. Ascending order means what? From the first order neuron till the third order neuron. Arrange it in the following order. That is what they are asking you. Okay. So here they have given. There is a mnemonic to remember this. Okay. Okay. So this is the mnemonic. E. Echo Lima or E. coli MA. Anyways, you can remember. Okay. So this is the order. This is the order to remember this auditory pathway in your ascending order. So what is E? If you look at the auditory pathway here, you will be able to say. Okay. I will tell you. Echo Lima. Okay. So what is E here? E is the eighth nerve, eighth cranial nerve. So that is E. Okay. Then C is the cranial nerve nuclei. C. Okay. O is for superior olivary nucleus. O. Then L is for lateral lemniscus. L. I is for inferior colliculus. M is for medial geniculate body. And A is for auditory cortex. Okay. Now you can see ECOLIMA, echolima. Okay. Now here there are some specific functions also. The superior olivary nucleus and the inferior colliculus will detect the direction of sound. It will detect sound direction. And the medial geniculate body is to identify music. Okay, so these are the salient features. So now let us put this echolemma here and see. So E is for what? Eighth nerve nucleus. It is not there. C, what did I say for C? Cranial nucleus. O is for what? Olivary complex. Okay, 4. Then L is for lateral lemniscus. Okay. Then what do you have? I. I is for inferior colliculus. M is for mediate geniculate body. So what is the order? 4, 1, 3, 2. Okay. Easier to understand. So now that completes our discussion on our physiology revision series. Again, I hope you all understood the topics, and if you have any doubts even after this discussion when you're going through the videos, you can always feel free to approach us and ask us questions, and also you can refer to our app where all these things are discussed in great detail. I wish you all a very best for your forthcoming NEET PG examination. Thank you for your patient listening.